to heart failure, which is a favorite part of cardiology for me. We will have very nice and interesting topics here. My name is Professor Špinarová and I am from Brno, Czech Republic. And my co-chairman is Professor Han, who came from very far country, from South Korea. And he's here with me and also with his fellows, so many thanks for coming. And we will share the chairing for this session. So we shall begin with the first presentation from Brno, Czech Republic. The presenter will be Dr. Špinarová, and the title of the presentation is Impact of Mid-Regional Proadrenomedulin to the dosage of loop diuretics.
So it's working. Okay, good morning, ladies and gentlemen, dear chairs. Thank you for the opportunity for being here again. And I would like to present to you our data about the new biomarkers in systolic chronic heart failure. I will start with my presentation. I wait for the first slide. Great. So, as you see, the topic of my presentation is the impact of mid-regional proadrenomedulin to the dosage of loop diuretics in patients with chronic systolic heart failure. I have nothing to declare. This data came from a FAR NHL registry, which is our register of pharmacology and neurohumoral activation in patients with stable systolic chronic heart failure. These data were collected from 7 departments in the Czech Republic with special heart care. Included patients had to be treated for systolic heart failure with non-preserved ejection fractions and had to be stable at least for 1 month with an optimal pharmacotherapy. The primary endpoint in 2-year follow-up was an all-cause mortality, heart transplantation, or left ventricle assist device implantation. A total number of 1,088 patients were included in this register. However, the level of mid-regional proadrenomedulin was available in 569 of them. We have collected medical historical data from the patients, did the physical examinations, and have the biochemical results, including the standard parameters used in the diagnosis of chronic systolic heart failure, as well as the new ones. Adrenomedulin. Adrenomedulin is a vasodilator peptide hormone. I think you are familiar with already. It's synthesized by endothelial and vascular smooth muscle cells. Its expression can be induced by various stimuli. One of them is the volume overload. So that's the reason why we think it's a good biomarker for patients with heart failure. It circulates in the plasma level in very low concentration in healthy adults. However, it rapidly increases in patients with heart failure. Adrenomedulin itself is unstable and it's not suitable for laboratory measurement. However, it's displayed from a larger precursor peptide and leaving 2 smaller biological inactive fragments. One of them is mid-regional proadrenomedulin, which is stable enough and it's a reliable surrogate for the measurement which we use for our data. So this is the baseline characteristic of our patient cohort. As I already mentioned, we have included 569 patients with systolic chronic heart failure. Most of the patients were men, the mean age about 65. They've got a normal level of blood pressure and heart rate. The mean ejection fraction was around 31%. The most common etiology of the heart failure was an ischemic one or dilated cardiomyopathy. Because it was a stable patient, most of them were classified as NIHA 2 or 3. As I already mentioned, we set the basic biochemical data of all these patients. That means the standard parameters, as it is the NT-proBNP, as well as the new one, which is the mid-regional proadrenomedulin. The patients need to be treated with an optimal pharmacotherapy. So as you can see, they were administered by all the basic groups for heart failure. Almost 93% have received beta blockers, diuretics, or furosemide, as the most common loop diuretic, was administered to about 80% of the patient. And here are already our results in a 2-year follow-up, and we see quite clearly that the patients with high level of mid-regional proadrenomedulin reach the primary endpoint in 2-year follow-up much more often than the patients with the lower level of mid-regional proadrenomedulin, which is displayed in this chart with the probability of the event. Then we set the cutoff value for mid-regional proadrenomedulin to 0.79 to an adequate sensitivity and specificity, and we again see the differences between the patients with the lower and higher level of mid-regional proadrenomedulin, that those with high level has reached the primary endpoint, means death, hospitalization, transplantation, or LVAD implantations much more often than these with lower level. We have also discovered statistical significant differences in other parameters, like patients with a higher level of mid-regional proadrenomedulin were statistically significant older, classified with a higher NIHA class, more often suffer with comorbidities such as hypertension, atrial fibrillation, diabetes mellitus, more often have a swollen lower limbs, and have worse renal functions. There were no statistical difference in sex, in etiology, and in ejection fraction. Then we related the level of mid-regional proadrenomedulin to the dosage of loop diuretics, the furosemide, and we have discovered that patients taking higher doses of diuretics are having statistically significant higher level of mid-regional proadrenomedulin, which we conclude that may reflect their level of congestion, that these patients are suffering with a higher level of congestion or maybe are not adequately decongested, so they need to receive a higher dosage of loop diuretics, and maybe it might help us also in guiding their therapy, such as add another diuretic or, for example, use some other method for their treatment. So to conclude, mid-regional proadrenomedulin appears as a predictor of more serious prognosis in 2-year follow-up in patients with systolic chronic heart failure. The detection of mid-regional proadrenomedulin provides prognostic information in addition to an independent of the assessment of NT-proBNP. High level of mid-regional proadrenomedulin combined with increased use of loop diuretics may reflect a level of congestions and may help to detect the patients that are inadequately decongested or are resistant to a diuretic therapy to reevaluate their treatment. Otherwise, low level of mid-regional proadrenomedulin may help identify patients with lower residual congestions whose dose of diuretics appears to be adequate. Thank you for your attention.
So thank you very much for the presentation. You are perfectly in time, and the paper is open for discussion from the audience. Are there questions? Well,
Your cut point of 0.79, where did you get that?
It was the best cutoff with the best sensitivity and specificity we got from the statistic.
So you used like an ROC curve or something?
Not really.
Okay.
Yeah. Thank you. And could you tell me what are the limitations for usage of this new neurohumoral substance?
Well, I think that the most important limitation for mid-regional proadrenomedulin is that it's still a new biomarker, which is not the part of the standard laboratory parameters. So, for example, in the Czech Republic, we don't have all the laboratories equipped with the special machines or possibilities to set the level of mid-regional proadrenomedulin. So it's still more expensive, more complicated to get this parameter. And it's like, it's not a new NT-proBNP. It's something additional. It's something what adds us another information about the prognosis and about the congestions. So I think that there is still space for this new biomarker, but it wasn't superior to NT-proBNP. It's something additional, something what may just give us some further information about our patients.
You said that there was independent from
Yes,
marker of congestion from NT-proBNP, but did you analyze this, if it was an independent predictor?
Yes, we did.
I couldn't see.
I'm sorry, I don't have this data, and this NT-proBNP will be presented by my colleague here, so I don't want to skip his presentation. But the NT-proBNP's prognostic value was was superior to the other biomarkers.
So, thank you very much again. And we move to a second presentation from Italy, Luca Crisanti and colleagues, and the name is Utility of High-Sensitive Troponin in Risk Stratification of Patients with Acute Heart Failure without Acute Coronary Syndrome, comparison between heart failure with preserved ejection fraction versus reduced ejection fraction.
Okay, so no. Okay, so non scorre, cioè non scorre il comando. Ok, andiamo dalla prima sicuramente. Okay, so good morning. I think Professor Spionova already introduced me, so we can go to the first slide, and we start, that was our starting point on the left, so it was an article published by Professor Peacock a few years ago, and he showed how a positive test for conventional troponin correlated with a higher in-hospital mortality in patients with acute heart failure. In the same paper, they also showed how there seemed to be a correlation between a positive test for troponin and a reduced ejection fraction. On the right, you'll see a more recent article where they've used high-sensitivity cardiac troponin in patients with chronic heart failure, and they found that a higher concentration of cardiac troponins are associated with a higher left ventricular mass and preserved ejection fraction. So since we couldn't find any consensus in the literature, we decided to set this study with this as our primary goal, so to evaluate the relationship between high-sensitivity troponin and the left ventricle ejection fraction in patients with acute heart failure and with their final disposition from the emergency department. Okay, so this is our study design. First of all, it's a retrospective study where we included all those patients admitting to the emergency department with a final diagnosis of acute heart failure from the beginning of this year until April. And of course, they needed to have a final diagnosis of acute heart failure. They needed to have a cardiac ultrasound evaluation in the emergency department, and of course, a high sensitivity troponin determination. We had to exclude all those patients with acute coronary syndrome, of course, based on the clinical evaluation, so history, physical, EKG, and troponin. On the right, you'll see the data that we gained about our cohort, and below the 5 hospitals in Rome where we did the enrollment. Okay, so we managed to enroll 376 patients. These are their phenotypes at presentation according to the more recent guidelines, and as you can see, more than 80% were admitted with acute decompensated heart failure, and second comes pulmonary edema. We found that they are all equally distributed regardless the left ventricular ejection fraction and the high sensitivity cardiac troponin. On the right, you'll find the distribution of our cohort across the 5 hospitals, and below the final disposition from the emergency department. So only 10% were discharged, and then again, more than 90% had to be admitted. Of those, 65% in a low-intensity ward, such as cardiology, pneumology, or internal medicine, 12% in a sub-intensive care unit, and 10% in the ICU. We will focus here just on some data. So as already described in the literature, male patients and younger patients tend to have a reduced ejection fraction and a lower systolic pressure. Then below, the BNP levels are highly affected by the ventricular function. And finally, the cardiac troponin, well, we couldn't find any difference across the 3 cohorts in the mean value. We also gained some data about the right ventricle overload, and we estimated it as having an inferior vena cava of more than 20 millimeters, or if it was non-collapsible, and we found it significantly different across the 3 cohorts, so a reduced ejection fraction correlates with a right ventricle overload, but it doesn't correlate with a positive test for cardiac troponin. And below, the wet lung at presentation evaluated either through lung ultrasound or chest X-ray, and it was equally distributed in the 3 subgroups. So again, what we found basically is that 2/3 of our patients had a positive test for cardiac troponin, but again, there was no difference across the subgroups. So we might think that the high sensitivity cardiac troponin remain a reliable biomarker of myocardial injury, regardless the ejection fraction in the acute setting. And below, you'll find the final disposition correlating with the average high sensitivity cardiac troponin I. And of course, a high value of troponin at admission correlate with a final disposition to a higher level of care. Of course, this study has several limitations. First of all, it's a retrospective analysis without a follow-up, so we couldn't make a proper risk stratification. There are some confounding factors because of the etiologies of the acute heart failure, and finally, we lack some data about medical condition and the use of any medications. So to conclude, we can say that while the BNP levels are highly affected by the ventricular function, troponin seems to be independent from it, and therefore they should remain a reliable biomarker of myocardial injury in the acute heart failure without coronary syndrome. Of course, a prospective study will be needed in order to find if a simultaneous cardiac ultrasound evaluation and troponin determination in the emergency department can be integrated for a more appropriate risk stratification in patients with acute heart failure. And that's what we plan to do next. So a prospective study with an actual follow-up, and maybe also divide patients on the basis of the acute heart failure etiology. Thank you.
So again, many thanks for your presentation and interesting data, and also you were in the time limit, and again, the paper is open for discussion.
Thank you for a great presentation, very interesting subject. I have 2 questions, sorry. So first one is, you said that you included patients that had a troponin. Is not that routine in your service that troponin is
well, it depends
collected
on the
for
presentation,
all patients with acute heart failure?
Yeah, we do that. We don't do the ultrasound evaluation. So, of course, those 375 patients weren't all the patients admitting with heart failure, so just a few fraction had a cardiac evaluation.
And the second question is, how exactly did you classify the acute coronary syndrome? Because sometimes it's hard, it's a gray zone, if the acute heart syndrome is the trigger for the acute heart failure or not.
It's not.
So did you take this information for the chart retrospectively, or did someone adjudicated these charts to be sure that the patients really didn't have?
No, we did a review of the charts after, but most of these patients have been evaluated by a cardiologist in the emergency department, so the coronary syndrome was excluded by a specialist in the emergency department, so before the enrollment.
Thank you for the wonderful presentation. Actually, the ejection fraction is very good to assess the LV systolic function. But in this case, in chronic heart failure, ejection fraction is always low. But sometimes E over E prime or filling pressure is high. Sometimes it is not. So for the evaluation, I think instead of ejection fraction, we should check the E over E prime, or at least filling pressure, and correlate to the HSTNI. And also in case of RV overload, you said it's a pressure overload, I think, it is not volume overload. And the IVC and the inspiratory collapse is not enough. And adding TRV max and RVSP is much more accurate. So in this study, I just meant comment, not ejection fraction, E over E prime and RVSP kind of more sensitive, more vulnerable to change according to the acute condition. It's much more well correlated with HSTNI.
We tried to make it as simple as possible because you always have like 30 seconds to evaluate the patient, so we will have to look into that, of course, but yeah, we have to see how fast we are in doing the evaluation.
Yeah. So, yes, this was small commentary from the audience. Yeah. And I just wanted to ask you how you were evaluating the right ventricle.
Just through the inferior vena cava evaluation.
Yes.
So we couldn't make a proper estimation of, I don't know,
Yes.
the taps or...
Yes.
No, of course.
Thank you. So, no more questions. So, again,
Okay.
thank you for the presentation. And we are going to the third presentation, and
Pointer.
yeah, this is again coming from Brno, Czech Republic, colleague Trčková, and the name of her presentation is Comparison of Patients with Reduced versus and Mildly Reduced Left Ventricle Ejection Fraction.
Good morning, dear colleagues. I have another data from our register. So we present the results from the pharmacology and neurohumoral activation registry, which collects data on patients with chronic heart failure. The register contains 1,088 patients with chronic heart failure. And it's from 3 workplaces in the Czech Republic, which specialize in the care of patients with heart failure. Everybody is familiar with this slide, so let's go through quickly. According to the ASC guidelines, patients with heart failure are divided into 3 groups. Ejection fraction, reduced ejection fraction group is 40% and below. Then is a mildly reduced group, it's between 41 and 39%. And the last one is a group with preserved ejection fraction, and it's below 50%. The last group must have another criterion. It's elevated NT-proBNP, and at least one additional criteria, either diastolic dysfunction or hypertrophic cardiomyopathy or left atrial dilatation. And of course, all 3 groups must have symptoms and signs of the heart failure. Our methodology. We consider stable conditions to be when the symptoms and signs of the disease are unchanged for at least a month and effective pharmacotherapy is set. There were patients with ejection fraction below 50%. Patients were free from 3 cardio centers, as I said. These cardio centers are specific that we have patients with more serious conditions, such as before orthotopic heart transplantation or before left ventricle assist device. And these patients were outpatients, and patients were hospitalized too. These hospitalizations were elective. It was, for example, before implantation of ICD or before coronarography. The aim. The aim of this study was to determine whether patients with mildly reduced ejection fraction and reduced ejection fraction differ in clinical manifestation, laboratory findings, pharmacotherapy or epidemiology or comorbidities. And another goal was to compare 2-year prognosis between this group, and we have primary combined endpoint, and it was death from any cause, or orthotopic heart transplantation, or left heart support implantation. Now our file. Patients with reduced ejection fraction are more likely to be male, are older, have lower systolic blood pressure, and are less likely to be ischemic. So let's focus on this ischemic group. In not selected population, we would expect more ischemic causes of heart failure. But as I said, in our cardio centers, we very often have not so common causes of heart failure, for example, cardiomyopathies. Yeah, in our register, patients with with reduced ejection fraction have higher New York Heart classification, and in laboratories they have elevated concentration of NT-proBNP, urea, and uric acid. Now our comorbidities. There are no significant differences in presence of comorbidities and proportion of smokers and non-smokers. But you can see that hypertension is less often in a reduced ejection fraction group, mainly due to higher consumption of diuretics compared with mildly reduced group. And pharmacotherapy. Reduced ejection fraction group was more treated with loop diuretics and with mineral corticosteroid receptor blockers, and less often with thiazides. And it's because thiazides were included as hypertension therapy using diuretic effect in a mildly reduced group. But patients with reduced ejection fraction group have a bigger benefit from furosemide. Now you can see 2-year event-free survival without achieving a combined endpoint. You could see that prognosis of patient with reduced ejection fraction is worse. 2-year prognosis without reaching our combined endpoint was 82% in the reduced ejection fraction, but in mildly reduced ejection fraction it was 89.6%. So our conclusions. Again, patients with reduced ejection fraction in our research have a higher class of New York Heart Association. In laboratories, they have a higher concentration of NT-proBNP, urea. They are more often treated with loop diuretics and mineralocorticoid blockers, and less of thiazides. And compared to patients with mildly reduced, patients with reduced ejection fraction have, of course, more severe heart failure and more pronounced neurohumoral activation and worse prognosis. And as I said, they do not differ in the presence of comorbidities. So thank you for your attention.
Many thanks for the presentation, and again you were comfortably in the time limit, so no stress. And now we can discuss the paper. So are there any questions from the audience? Please raise the hands. Well, so I would like to ask you, when I saw this table with pharmacologic treatment, there was not mentioned ivabradine, so could you explain it?
Yeah, lots of colleagues ask me why there is not ivabradine, but it's because our patients very often have the highest dosage of beta blockers, and a lot of them have atrial fibrillation too, so we couldn't use ivabradine, so we didn't have it in this research, this data.
Yes, thank you. Other questions? So if not, thank you again.
Thank you.
And the next presentation is again from Czech Republic, Brno City, Dr. Laber. And his topic is natriuretic peptides and comorbidities in chronic heart failure.
So, dear Chairman, ladies and gentlemen, let me present or continue with FAR NHL registry of chronic heart failure, and I will focus on natriuretic peptides and comorbidities in this chronic heart failure. As we know, heart failure is a very common comorbidity, and the natriuretic peptide describe heart failure and can diagnose heart failure, and their serum levels, when they're higher, then the heart failure is more severe, and as well could be the worst prognosis. There are many causes of elevated natriuretic peptides, and it could be cardiovascular and non-cardiovascular. And for example, it is atrial fibrillation, as you can see from ESC guidelines, or elderly or kidney disease, but as well acute coronary syndrome, or maybe heart contusion, stroke, ischemic or hemorrhage, or COPD, anemia. As it was mentioned before, the FAR NHL registry contains 1,088 patients. It is a registry of chronic heart failure with at least 1 month stable, patients with left ventricle ejection fraction below 50%, and we included outpatient and inpatient patients, but these hospitalized patients were not hospitalized for decompensated heart failure. The inclusion was from 2014 till December 2015, and it all happens in 3 centers in Czech Republic, and it was St. Anne's University Hospital in Brno, then the other university hospital in Brno, and in Prague, Na Homolce Hospital. Then there participated some institutes from Masaryk University, like biostatistics, pathological physiology, or biochemistry. Let's move to FAR NHL and description of the sample of patients. We can see 80% of patients were male, and median of age was 65 years, and almost 2/3 or 60% were in NIHA class 2, 1/4 was NIHA class 3. The etiology of heart failure was in 50% ischemic heart disease and 43% dilated cardiomyopathy. This slide, or these graphs, I've borrowed from Professor Spinar and his article, and we can see the higher NT-proBNP is, the more higher occurrence of combined endpoints is present. Combined endpoint was death, heart transplant, or implantation of left ventricle assist device. And we can see in the other graph proportion of patients and levels of NT-proBNP, and the black curve means probability of endpoint, and you can see the higher NT-proBNP is, the probability of endpoint is very much higher. Then we have done univariant linear regression to predict NT-proBNP, and as well from this table you can see the higher NT-proBNP was predicted by presence of diastolic dysfunction, atrial fibrillation, diabetes mellitus, higher heart rate, or higher age. On the other hand, the lower NT-proBNP was predicted by higher ejection fraction, higher systolic blood pressure, higher hemoglobin level, or glomerular filtration rate, or higher body mass index. There was no influence of sex, hypertension, dyslipidemia, or in medical history. Then we have done multivariant linear regression using backward stepwise algorithm of independent predictors of NT-proBNP, and we can see again higher NT-proBNP was predicted by presence of diastolic dysfunction, atrial fibrillation, higher heart rate, but no longer by presence of diabetes mellitus. The lower NT-proBNP was predicted by higher ejection fraction and higher systolic blood pressure, higher hemoglobin level, or higher glomerular filtration rate, or higher body mass index. So let me conclude this presentation. According to FAR NHL registry in stable chronic heart failure, NT-proBNP level is mostly influenced by systolic and diastolic function of left ventricle, then atrial fibrillation, anemia, or renal impairment. And we can see the paradox of high body mass index and higher blood pressure beneficial for heart failure patients has been demonstrated. Thank you for your attention.
So again, thank you very much for the presentation. Again, we are perfect in limit, and there is time for questions.
Yes, you had the proportion of women was 19. I think you had a significant selection bias in the series, no?
Well, our sample of patients is from 3 centers where they focus on severe heart failure, and 1/3 of patients was from St. Anne's University Hospital, where we focus on heart transplant, and we have very severe patients, and for the heart transplant there is a limit of age. Maybe a little fluctuable, but limit of age. And when we see the heart failure patients, then the younger are men, the older, little older, are women with dilated cardiomyopathy. So we think this causes the unproportional thing with men and women. So and when you see the large registries of severe chronic heart failure patients, then you can see that men are very much more in these registries than women.
So I find the presentation very nice. You showed a nice regression model, and you showed that there is a significant correlation between uric acid and proBNP, right? And how would you explain this correlation when you already show that kidney failure is also correlated with that?
Well, we know that when we assess the uric acid, then that in general higher uric acid levels are very associated with worse prognosis, and worse prognosis is very associated with higher NT-proBNP levels. So I think that's the point. So the higher uric acid is in this thing associated with higher NT-proBNP level. I don't think there is other correlation in it.
Yes. So thank you very much. Thank you for the answers in the discussion.
Ciao a tutti. My name is Hans, and I will introduce the remaining three papers. The next presentation will be by Maria Bakushova. It's a tongue twister for me. The title of his presentation is Iron Deficiency in Patients with Advanced Heart Failure. Maria?
Thank you very much. I'm Maria Bakošová from Sandy University Hospital in Brno, Czech Republic, and Masaryk University. And I will talk about iron deficiency in patients with advanced heart failure. Iron deficiency is a very common comorbidity in patients with heart failure. More of 1 billion people of the world have iron deficiency anemia, and nearly twice of them has iron deficiency without anemia expressed. In the situation of iron deficiency, bioenergetic reserve is reduced in organs that need high energy supply, such heart muscle is. Iron deficiency occurs in more than half of patients with heart failure, and it is related with decreased exercise capacity, more frequent hospitalizations for heart failure decompensations, and according to some studies, it is connected also with higher mortality. According to guidelines for diagnostic and treatment of heart failure from 2021, there is highly recommended to screen all patients with heart failure for iron deficiency. In this group of patients with heart failure, iron deficiency is defined like a level of ferritin below 100 or 100 up to 299 in the situation when the transferrin saturation is below 20%. We wanted to find out the prevalence of iron deficiency in patients with advanced heart failure. So we included 52 patients placed on the waiting list for heart transplantation in 2021 at our center. And we divided this population into two groups. The patients with implanted left ventricle assist device in the time of data collection as a bridge to transplantation, and patients, the bigger group of patients without LVAD implanted. And we screened iron deficiency parameters or parameters of iron metabolism like guidelines says. So let's move to the results. We can compare non-LVAD and LVAD patients. And we can see that the prevalence was very high. Patients without LVAD, the prevalence was 82%. And in the group with LVAD implanted, it was 57% of patients with iron deficiency. We can see that all women had iron deficiency. And if we are talking about anemia, we can see that anemia or iron deficiency not have to be expressed by anemia because the levels of hemoglobin are similar. and we can see that all patients with LVAD had anemia. Talking about ferritin, as the definition says, patients without LVAD implanted had low ferritin in the group with iron deficiency, but the whole group with LVAD implanted had higher levels of ferritin. And also, in patients without LVAD implanted, saturation of transferrin was low in the causes with iron deficiency, but in the group with LVAD implanted, all patients had low saturation of transferrin. So we can see the differences in definition of iron deficiency in patients with and without LVAD. We also can see that in this group, the iron deficiency wasn't related with renal insufficiency. And we can also see that patients with LVAD implanted had better parameters of kidneys, probably because of better perfusion of kidneys. So we can see that there are some differences in defining iron deficiency in patients with and without LVAD implanted. And we can see that whole group of patients with LVAD implanted had statistically significantly higher levels of ferritin. It can be caused because of chronic inflammation in the bodies of patients with mechanical support implanted. And we can say that in many situations, the diagnosis of iron deficiency based on the ferritin, like a very specific marker of iron deficiency, can be false or not correct. As in the group of patients with chronic inflammation, as oncological problems, hepatic disease, maybe hemodialyzed patients chronically, and so on. And maybe transferrin saturation or other parameters can be better parameters to diagnose iron deficiency. So that brings us to conclusion. Let me repeat that iron deficiency was present in majority of patients with advanced heart failure. Not was always accompanied by anemia, and it was not related with renal insufficiency. And in patients with left ventricular assistance device, a false negative result of iron deficiency may occur due to chronic inflammation, because the ferritin is also the parameter of acute inflammation phase. So the saturation of transferrin or other parameters, for example, like soluble transferrin receptor, may be more precise to diagnose iron deficiency in this population with heart failure. Thank you for your attention.
Thank you for a nice presentation. So this interesting paper open for discussion. Is there any questions or comment from the floor? No, it's self-evident. So let's move on to the next presentation. Thank you. Next presenter is Lucas Opatrio, whose title is the Stress Pulmonary Circulation Parameters in Patients with After a Heart Transplantation and Cancer Survivors, a CMR study. Please.
So, dear ladies and gentlemen, my name is Lucas Opatrio. I'm from St. Anne's University Hospital in Brno, Czech Republic, and it's an honor for me to present here our work entitled Stress Pulmonary Circulation Parameters in Patients After Heart Transplant and Cancer Survivors, a CMR study. I have nothing to declare. As for pulmonary circulation parameters, in several versions, using different modalities, they have been studied for decades. The latest method of assessing them is by cardiovascular magnetic resonance, or CMR. It refers mainly to time needed for blood to get through the pulmonary circulation, in our case from right ventricle to left ventricle, and CMR offers many advantages, one of the biggest being assessing stress parameters as well. They have a potential to reflect the function of the cardiopulmonary system as a whole, mainly systolic function of both ventricles, diastolic function of left ventricle, and pulmonary hypertension as well. For the sake of this presentation, we will be referring mainly to two of them, PTT, or pulmonary transit time, which is the raw time needed for the contrast to get from the right ventricle to the left ventricle, and PTB, or pulmonary transit beats, which is the number of cardiac cycles which is needed for it. As for patient selection in our study, we included patients after heart transplant, 49 of them, with no signs of systolic dysfunction or pulmonary hypertension. We then divided them into two subgroups, 41 without any signs of diastolic dysfunction as a subgroup A, and 7 with signs of diastolic dysfunction in subgroup B. We then compared them to a group of childhood cancer survivors, or CCS group, where we included 39 patients with no signs of systolic, diastolic dysfunction, or pulmonary hypertension by echocardiography. They were patients that in younger age went through chemotherapy, in most cases anthracyclines in 49%, the rest cisplatin and carboplatin. And why we studied patients after heart transplant? Because as already published by Professor Melusine from our department, up to 58% of these patients showed diastolic dysfunction only detectable in stress conditions. And therefore we hypothesized that these patients should have their parameters prolonged when compared to CCS group. As for methods, we used short-axis perfusion images in both rest and adenosine stress-induced perfusion stacks. On image A, you can see that we did a ratio of interest in right ventricle and left ventricle. From the data obtained, we then made a graph of signal intensity to time. And as you can see, as the contrast agent is getting through the ventricles, firstly through the right ventricle, the signal intensity is going up, and then through the left ventricle as well. The time between onsets of these increases then defined PTT, or pulmonary transit time, and the PTB was defined as number of cardiac cycles between these onsets. In the image C, you can see how on the first pass perfusion images, the contrast agent, in this case gadolinium of course, is getting first through the right ventricle and then through the left ventricle as well. Of course, pulmonary transit time is affected by heart rate. Therefore, we used heart rate corrected PTTC as well, which was obtained from PTT by simply using Bazzet's formula as a correction, which is used, for example, on a QT interval and in the EKG as well. As for rest parameters, as you can see, there were no significant differences in the PTT between the groups. However, in the case of corrected PTT and PTB, they were both significantly prolonged in patients after heart transplant when compared to CCS group. You can see a box plot of it there as well. For the stress parameters, both corrected and uncorrected PTT were significantly prolonged in patients after heart transplant when compared to CCS group. To sum it up, all stress parameters and from rest, corrected PTT and PTB were prolonged in patients after heart transplant when compared to CCS group, which points to subtle diastolic dysfunction. Stress parameters were lower than rest parameters, which at the time of this publication was in contrary to only published data and therefore was a significant finding as well. However, we must say that we expected higher parameters in the subgroup with diastolic dysfunction in compared to the subgroup without diastolic dysfunction after heart transplant. As you can see from the box plot as well, there are clearly trends of higher values in this subgroup. However, it does not reach statistical significance, but we have to say that this was highly influenced by the very low number of patients in the diastolic dysfunction subgroup, only 7. As a conclusion, Assessing of these parameters is feasible. Patients with subtle diastolic dysfunction tends to have longer PTT and higher PTB. Changes are more prominent in stress conditions, and it offers a possible new stress test option. And I thank you very much for your attention, and I'm ready to answer your questions.
Thank you very much. So this paper is open for discussion. Okay.
Thank you so much. Wonderful presentation. Among the 48 heart transplantation patients, 7 was diastolic dysfunction. So I think, could you clarify the definition of a diastolic dysfunction in this case? Because diastolic dysfunction is such a spectrum from the impaired relaxation to the restrictive pattern. So if how this define the 7 patients of diastolic dysfunction?
It was assessed by echocardiography using Doppler techniques, both from mitral valve assessment, E2A, and to tissue Doppler imaging as well, E2 E apostrophe. And the patients in the first group did not reach the definition of a diastolic dysfunction, and in the group with diastolic dysfunction, they showed grade 2 or higher diastolic dysfunction.
UVE prime over than, greater than average 14 or 16?
In the group with diastolic dysfunction, E prime was E2 E prime was higher than 14. In the group
14.
Yeah, but in the group without diastolic dysfunction, the mean E2 E prime was below 8.
Yeah,
so
it was very tricky because in case we are included without pulmonary hypertension, so in diastolic dysfunction we have a combined index, not only UVE prime, TRV max, and array enlargement as well. But in patient of a heart transplant, not all, but most of the people have enlarged LA. And in the case, we excluded pulmonary hypertension, so we only rely on the UVE prime 14. Is it correct?
Sorry, I didn't understand the last part.
I think usually 2016 AHA-ACC guideline in case of defining diastolic dysfunction, ejection fraction less than 50, we included 3 indexes to define diastolic function. But in case of a heart transplant, it is a little bit tricky because LA usually enlarged. It is one of the components. And also in this study, we excluded pulmonary hypertension, but so we excluded the increased tricuspid regurgitation velocity. So among the 3 indexes, we only evaluated UVE prime. I understand. Is it correct?
Yes, it's correct.
Okay, if no further questions, so let's move to the last presentation. I'd like to invite Anna Cholopka to the podium. She will talk about the foxglove smoothie, a case of acute cardiac glycoside poisoning. Please.
Good morning, ladies and gentlemen. It's my great pleasure to share with you what I find very intriguing case of acute cardiac glycoside poisoning. That's a recent case from our department. I have nothing to declare. The learning objectives of this case are to describe the red flags pointing to cardiac glycoside poisoning. And I would like to also summarize the indications for treatment with specific antibodies fragments. Our lady was a 64-year-old lady which was admitted to our CCU department after ingestion of foxglove leaves. Sometimes our patients are very inventive, so she prepared herself a smoothie made out of about 10 leaves, fresh leaves of a foxglove from her garden. mixed with water. And unfortunately, this was all in a suicidal attempt. At the time of her admission, which was about 6 hours after ingestion, the patient presented with fatigue, mild nausea, and vomiting. Her vital signs were notable for bradycardia. She had normal blood pressure and normal oxygen saturation. Her physical examination showed cyanosis of the lips, which was very prominent. She had mild diffuse abdominal tenderness to palpation, and other findings were normal. Her past medical history was significant for alcohol abuse. She was not taking any prescription medications. She had no allergies. Now, what's the differential diagnosis? As we might know, there are different plants which contain cardiac glycosides. These are all in digitalis genus, or convallaria, or Nerium oleander, which is also quite famous. Then poisoning with beta blockers, calcium channel blockers, alpha agonists, they can all present with severe bradycardia and can mimic the same effects. From other differential diagnostics, we have to think about hypothermia, hyperkalemia, hypothyroidism, or sick sinus syndrome. The results of initial lab findings showed severe hyperkalemia, 5.5, with normal renal function. Her serum digoxin concentration obtained at presentation was within therapeutic range, 0.8, and decreased to subtherapeutic levels within 3 days. The chest radiograph was clear. Her echocardiogram showed normal systolic function, actually very good systolic function. And what was really interesting, and I'll show you in the next slide, was her ECG. The initial ECG revealed complete heart block with junctional escape rhythm of 50 beats per minute. And there was a distinctive digitalis effect with lateral T-wave inversions, short QT interval, and the typical scooped ST segments. So as you can appreciate, this is the actual ECG from our patients on admission with the prominent scooped ST segments, which are sometimes being described as very similar to the famous mustache of Salvatore Dali, to remember. And this is with patient's consent. This is her photo on admission, where we can appreciate the severe cyanosis of her lips. The patient has been admitted to the CCU for continuous cardiac monitoring, of course, because of her complete heart block. She was treated with IV glucose with insulin for hyperkalemia. She was given antiemetics and oral proton pump inhibitor. The National Poison Control Center has been consulted, and together with our clinical pharmacologist, and several management options were discussed. The GI decontamination with activated charcoal was used despite the relatively long delay since ingestion, because it's been described that cardiac glycosides undergo enterohepatic recirculation, and they can also be absorbed by activated charcoal. Most importantly, antidotal therapy with antibody Fab fragments has been considered. But since the patient was completely hemodynamically stable and the data supporting the indication for these specific therapies are not as robust in plant intoxication compared to the drug intoxication, it's been recommended to wait and monitor the patient. In the follow-up, the GI symptoms and fatigue resolved within roughly 2 days. The cyanosis of the lips due to vasoconstriction remained up to 5 days. And the ECG changes we can appreciate here. On day 9, we can see sinus rhythm with just borderline first-degree AV block, And there is still persisting digitalis effect on the ECG. On day 14, this completely resolved, and the patient has been discharged on day 15. So just a brief note about this beautiful yet quite dangerous plant. Foxglove is a plant containing cardiac glycosides and with positive inotropic effect. Digoxin has been first described by Sir Wittering, and it's one of the oldest drugs still used in cardiology and still recommended in patients with heart failure and atrial fibrillation. Its mode of action is the inhibition of the NAK ATPase, which increases intracellular sodium and influx of calcium, which increases inotropy and contractility, causes increased vagal tone and smooth muscle constriction. So typical is the increased automaticity with conduction blocks. In conclusion, the clinical presentation of cardiac glycoside poisoning is usually nausea, vomiting. There could be a splanchnic ischemia, which can be quite dangerous, vasoconstriction, visual impairment, which is famously described in the literature with the yellow vision, yellow halo, which our patient didn't have experience. There could be any kind of arrhythmia. There is a very typical distinctive digoxin effect on the ECG, so just remember the Dali's mustache. And what I wanted to point out here is the Fab fragment therapy. So the digoxin level is not the main parameter when we are thinking about specific therapy. On the other hand, what is hyperkalemia, because this has been described to increase mortality. So hyperkalemia more than 5.5 is one of the indications for specific therapy. Then the second one is hemodynamical instability, and the third one is ingestion more than 10 milligrams of digoxin. The antidotes are Digibind or Digifab, which are usually readily available in bigger centers, and they are given intravenously. Thank you for your attention.
Thank you, Anna, for a nice presentation. I realized that all the fresh smoothies are not always good to our health. So this interesting case is open for discussion.
Yes, I would like to ask you to your opinion concerning digoxin and nowadays treatment of chronic heart failure, mainly the patients with sinus rhythm. Does it have any place?
According to the current guidelines, digoxin is a second-line therapy for heart failure patients which are in sinus rhythm with congestive heart failure. They are not recommended for patients with preserved ejection fraction. In patients with heart failure and atrial fibrillation, they are actually a first line of therapy.
Yes, please.
In the United States, this stuff is like Digibind is like $5,000 a vial. Do you know the cost?
I saw 2,050 per vial, but we usually, the standard doses are usually 10 to 20 vials for a patient, so it is extremely expensive. Yes.
If no further questions or comments, thank you for all the presentations and the audience for the active presentation. I close this session. Thank you very much.
I don't. Whoops.
Really? Oh, yeah. Oops, this is yours. Should we start? I think we should. Yeah, of course. Just, please.
Good morning, everyone. We're going to keep going on with the second heart failure session this morning. Young experts on stage. The first presentation is from Katrina Dolezalova, alcohol septal. We're skipping. Caroline. Caroline. Okay, so Caroline Espersen from Denmark. Should we give her 5 minutes? Maybe she's not aware. 5 minutes? She's coming. Okay. Yeah, she's here. She's here. So this is Caroline Espersen talking about sex differences in congestive markers in patients hospitalized for acute heart failure. Thank you.
Yes. Thank you for your attention. Thank you for giving me the opportunity to present here at the great meeting. My name is Caroline Espersen. I'm currently a first-year resident from the University of Copenhagen. And I'll be presenting my work as a Fulbright scholar at the Brigham and Women's Hospital, Harvard Medical School. And the paper is entitled Sex Differences in Congestive Markers in Patients Hospitalized for Acute Heart Failure. So, several sex differences have already been reported and investigated in patients with acute heart failure, some of which are depicted here. However, we do not yet know how these differences relate to differences in congestion between women and men with acute heart failure, in particular pulmonary congestion. Pulmonary congestion is a cardinal finding in patients with acute heart failure, and lung ultrasound is a useful tool to both detect and quantify pulmonary congestion. In light of this, lung ultrasound has also proven useful for the diagnosis, in monitoring, and prognosis in patients with acute heart failure. And because of this evidence, lung ultrasound has also been included in the 2021 ESC guidelines for the diagnosis and treatment of acute heart failure. However, we do not yet know if there are any differences between women and men in lung ultrasound findings in patients with acute heart failure, or whether sex-specific cutoffs are needed. So, in this study, we sought to first investigate sex differences in congestive markers based on physical examination, chest X-ray, echocardiography, laboratory tests, and lung ultrasound at baseline in patients hospitalized for acute heart failure. Second, we wanted to examine sex differences in the dynamic changes in congestive markers during a hospitalization for acute heart failure. And lastly, we sought to assess the prognostic value of congestive markers at discharge on the composite 90-day outcome consisting of heart failure hospitalization and all-cause mortality in women and men. So, this was a post-hoc analysis of the two-center prospective observational study in adult patients hospitalized for acute heart failure at two academic hospitals, one in Boston and one in Glasgow. On admission, patients had a baseline lung ultrasound performed. At the same time, they also had an echocardiography performed. Then they also underwent a physical examination, had laboratory tests taken, including NT-proBNP, and if clinically indicated, they also had chest X-ray performed. And then the patient-reported dyspnea was also recorded on admission. Then, prior to discharge, a subset of patients had a pre-discharge lung ultrasound performed. They also underwent a physical examination again, and the patient-reported dyspnea was recorded prior to discharge as well. Then we followed the patients for 90 days and looked at a 90-day composite outcome consisting of heart failure hospitalization and all-cause mortality. And these events were adjudicated by experienced physicians at each site. Yes? Can you skip the next slide? No. Well, stay tuned for the lung ultrasound images. The one after. What I was going to show you was the lung ultrasound protocol used in this particular study. Because we used an 8-zone protocol and a simplified 4-zone protocol, and that's what I wanted to show you examples of here. Because the simplified 4-zone protocol only includes 2 zones in each hemithorax. So it's a more simplified version of scanning up to 28 zones. So, but we'll be able to show you.
Who performed the ultrasound?
The ED physicians.
The ED physician.
But they had an experience in lung ultrasound, so they had to have at least a few years of experience. Okay, we can see. There you go. So this here on the left is the 8-zone protocol. And then we have the simplified 4-zone protocol. And these were the lung ultrasound protocols we used in this study. And the lung ultrasound images were analyzed offline by experienced operators blinded to clinical findings and the timing of the lung ultrasound. Yes, you can change. Yeah. So then if we take a look at the baseline clinical and demographic data in this cohort, we found that women were older. You can click. They were older, they had a lower BMI, higher systolic blood pressure, and more often presented with heart failure with preserved ejection fraction. In contrast, men more often had a history of prior heart failure hospitalization, and more often had a history of ischemic heart disease. Yes, and if you then take a look at compare the congestive markers at baseline between women and men, we found that women reported a higher degree of dyspnea at rest at baseline, whereas men more often presented with lower extremity edema. However, there were no significant differences in the other physical examination parameters between the two groups at baseline. Based on the baseline chest x-ray, there are also no significant differences between women and men. Likewise, there are no significant differences in the NT-proBNP levels between women and men at baseline. However, the baseline echocardiography revealed significant differences between women and men. Overall, men had worse left and right ventricular systolic function, whereas women had higher measures of filling pressure. Lastly, if you take a look at the lung ultrasound and compare them between women and men, we found that there were no significant differences in the number of B lines, both based on the 4-zone and the 8-zone protocol at baseline. Then we looked at the dynamic changes in the congestive markers from baseline to discharge in women and men. And we found that there was an improvement in the dyspnea score at rest from baseline to discharge in both women and men. Likewise, there was a reduction in the supplemental oxygen demand, a reduction in the number of patients with jugular venous distension of more than 10 centimeters in both women and men from baseline to discharge. In men only, we also found that there was a significant change from baseline to discharge in the number of patients with crackles and leg edema. If we then take a look at the lung ultrasound findings and compare them from baseline to discharge in women and men, we found that there was a similar and significant decrease in the number of B lines from baseline to discharge in both women and men. And this was consistent for both the 4-zone and the 8-zone lung ultrasound. We also found that a higher number of B lines on the 4-zone lung ultrasound prior to discharge was associated with an increased risk of the composite 90-day outcome, consisting of heart failure hospitalization and all-cause mortality. And we found this in both women and men. In men only, a higher number of B lines in the 8-zone lung ultrasound was also associated with an increased risk of the composite 90-day outcome. And these are univariable analyses. So in conclusion, we found that echocardiographic markers differed between women and men at baseline, whereas the number of B lines in lung ultrasound did not, thus suggesting that we may not need sex-specific cutoffs for lung ultrasound findings in patients with acute heart failure. Second, we found a similar and significant decrease in the number of B lines from baseline to discharge in women and men, thus suggesting that women and men responded equally well to therapy during this acute heart failure hospitalization. And lastly, we found an increased risk of the composite 90-day outcome with a higher number of B lines in the 4-zone lung ultrasound prior to discharge in exploratory analyses in both women and men. And for those of you who are interested in reading more, the paper is now published in ESC Heart Failure in 2021. So thank you for your attention.
I see we already have a question on the floor.
Great job. I'm a big supporter of lung ultrasound. Two questions for you. Was the pre-discharge lung ultrasound available to the clinical team, or is it blinded?
It was blinded.
Okay.
Yeah, so it wasn't used in the clinical decision making.
Okay. What are your thoughts about using this? Should we be targeting B lines rather than NT-proBNP, JVP, et cetera, with our therapies over those 5 days in the hospitalization?
Well, I think it should be included as part of the evaluation. As lung ultrasound is it's readily available, it's portable, it doesn't expose the patient to any radiation, and it's easy to use, fast, so I think it should be implemented as part of the diagnosis in patient with acute heart failure. And it could also be used as a monitoring tool, also perhaps to guide the diuretic treatment, because now it's based on urine output, physical examination parameters that aren't always as sensitive. So using lung ultrasound might be a better and more objective way of targeting therapy.
100% agree. What are your thoughts about the lag of diuretic therapy and B lines? You know, how long should you be treating someone before you see a change or don't see a change and you think you need to ratchet up your diuretic therapy?
That's a very good question. Well, if you monitor it over time and you see a reduction in the number of B lines, then that's how you should use it. Yeah.
Thank you, Caroline, for this wonderful presentation. I have also one question. Oh.
Thank you very much for your presentation. My question is a fast question. The first lung ultrasound, was it done before acute therapy was in naive patients or after therapy of acute heart failure?
So the lung ultrasound was done within 1 day of admission to the hospital. Yeah. Any further questions?
Yes, well, I have one question. You showed that the women had a little bit better ejection fraction than men do.
Yeah.
How can you explain that?
Well, it's consistent with the literature that women more often present with heart failure with preserved ejection fraction, and they had more higher filling pressure, so they were more likely to have diastolic dysfunction, which is also consistent with literature in patients with heart failure and acute heart failure.
Perfect. Yeah, there is one more question.
Sorry, but I would like to remark on this topic on ultrasound evaluation in patients with acute heart failure in the emergency room. I think that Sean is absolutely right, and if you look carefully in the guidelines, they are absolutely recommended, even more than too much do echocardiographic assessment in sophisticated evaluation. So, and we publish as acute cardiac care group, a paper, position paper in European Heart Journal showing that what is important to standardize the evaluation. So it is not the problem to do or not to do, but also to do properly. So I would like just to leave an important concept. We should do lung ultrasound, which is much, much easier than the echocardiographic assessment, waiting for the new device for intelligence, artificial intelligence. But what is important to follow our guidelines, how to perform, to standardize. So at the end of the day, you do natriuretic peptide, you do echocardiographic, just left ventricular function and right ventricular function, vena cava. It's it. And then you do ultrasound. That is going to link it with wage pressure. But I think this is a message that we can discuss open probably in the future, but it's something I would like to discuss with the young fellow and the specialists in echocardiography to understand what is the value, big value of lung ultrasound in the emergency room, different from a lab where you do echocardiography, you can have 1 hour to do that. Sorry to make this comment, but this was important.
Yeah, thank you.
Any more questions from the floor? I have one quick question. Did you see a difference in the baseline characteristics regarding diuretics upon admission?
No, there's no significant difference in the diuretic treatment between women and men at baseline.
On what they were already taking?
Yeah, on what they were already taking.
Okay. Thank you very much.
So it's my pleasure to introduce the next speaker. This is Desiree Wusler. She's from Switzerland and give us insights from the randomized galactic study.
And is it working here? Yeah, perfect. So thank you for the nice introduction, Nisha. Thanks, Tenda. Colleagues and friends, I'm Desiree Wusler from Cardiovascular Research Institute in Basel, and I'm part of Christian's research group for several years now, and I'm also a resident for internal medicine and cardiology at the University Hospital in Basel. I'm very happy to be part of this meeting this year, and I welcome to you my presentation about the comprehensive vasodilation harms women with acute heart failure, novel insights from our galactic randomized trial. As indicated by my picture on the first slide, I will not start directly with acute heart failure, but with another passion of mine. So it's not working? Thank you. So this other passion is mountains, and I want to ask you a question. Any ideas which mountain this is? So I might give you some hints. It's in Nepal, and it's an 8,000 meter summit. Everest, okay, that's right. So this leads us back in turn to acute heart failure and the question, what do the highest mountain on Earth and acute heart failure have in common? So the first point is quite obvious. It's danger. Both of them are quite dangerous. So if it comes to the Everest, it always depends on the season, but if it's a really bad season for the alpinists, one successful summit attempt is demanded by 10 deaths. And if it comes to acute heart failure, we see in several trials that the one-year mortality rate is between 20 and 25%. Another common feature I want to talk about is sex-specific, is underrepresentation of women, both on the Everest and also in acute heart failure trials. So in many of the trials which are guideline relevant, only 20 to 25% are female. But in this case, we're even doing better than up here because only 9% of successful summit attempts on the Everest are done by women. So after this little excursion to the Everest, I will continue with these sex-specific differences in acute heart failure. So if it comes to the heart failure phenotype, heart failure with preserved ejection fraction is much more common in women, whereas heart failure with reduced ejection fraction is more common in men. In addition, differences in body composition, such as a higher percentage of body fat in women, can lead to differences between pharmacokinetics and pharmacodynamics of applied drug, and this could also result in a sex-specific drug effect. Despite this new evidence, physicians still apply a uniform therapeutic approach in patients with acute heart failure. So, as these sex-specific differences in heart failure are both very important and also under-recognized, it's really of interest to further characterize these differences and also to analyze the risk-benefit ratio of novel therapies individually in women and men. And therefore, we performed a sex-specific analysis of the Galactic randomized trial. It's the largest investigator-initiated randomized trial in acute heart failure, and it investigated a novel strategy of early, intensive, and sustained vasodilation in a broader acute heart failure population. As you can see here in this Kaplan-Meier curve of the first Galactic publication in JAMA, the study overall provided a comparable outcome between this group of intensive vasodilation and usual care. Regarding our following analysis, I already said Galactic is an investigator-initiated, multi-center randomized trial, and patients were either randomized to the strategy of early intensive vasodilation or to usual care throughout the hospitalization. So patients were included if they presented with acute heart failure to the emergency department with a plan for treatment in a general ward. And exclusion criteria were a blood pressure at presentation which was lower than 100 millimeters of mercury, and also severe renal dysfunction with a creatinine greater than 250 micromoles per liter. So just to shortly summarize this strategy of the vasodilation, you see here that we started from hospital admission on, and this strategy consisted of 3 different drugs. It was nitro, which was given sublingual and also transdermal, and first increased and then decreased again. And we also established hydralazine, which was given for 48 hours. And from day 2 on, we started with a rapid up-titration of either an ACE inhibitor, an angiotensin receptor blocker, or sacubitril/valsartan. So the primary endpoint of the Galactic study was a combined one. It was a composite endpoint of acute heart failure rehospitalization and all-cause mortality at 180 days, and this subgroup analysis was pre-specified according to sex. We included about 780 patients. Of these, about 290 were women and 490 were men. And the women were significantly older, they had a lower body weight, and they more often suffered from hypertensive heart failure with preserved ejection fraction. In contrast, the men more often had a history of myocardial infarction, and they more often had this typical cardiovascular risk factors like smoking. And in addition, they more often suffered from heart failure with reduced ejection fraction and ischemic heart disease. Regarding the combined endpoint, we found a statistically significant interaction of sex and this treatment strategy. And therefore, we characterized and analyzed the primary endpoint individually in women and men. And what you can see here in the Kaplan-Meier curve in red are the women, and the vasodilation group is marked by the solid line, and the usual care group is the dashed line. And you see that there's a big difference in the primary endpoint because the women randomized to vasodilation had a really higher proportion of this event compared to usual care. And this difference was also statistically significant in an adjusted hazard ratio analysis in the Cox regression model. In addition, we see this curve here for men, and we see that in men there's a tendency for the other way around. So men randomized to usual care had a trend to experience the combined endpoint more often in comparison to women. However, this difference was not statistically significant in an adjusted hazard ratio analysis. So we performed secondary analysis which could possibly explain this finding. So the first finding was this harmful effect of the vasodilation strategy in women. We saw that women had a lower body weight in comparison to men, but they still received similar doses of hydralazine and also nitro, which could result in a toxic effect. And this can be probably explained by the finding that women had a prolonged index hospitalization due to adverse event already happened in the hospital. The second finding was this trend for benefit of the vasodilation strategy in men, and a possible explanation for that is that the uptitration of an ACE inhibitor was more successful in men compared to women, and also according to guidelines and earlier studies, we would expect that in this population of heart failure with reduced ejection fraction and also ischemic heart disease, a high dose of an ACE inhibitor would have a beneficial effect. Some limitations of this study: we cannot generalize our findings to patients with severe renal dysfunction and also to patients with a systolic blood pressure lower than 100 millimeters of mercury at presentation, because we excluded these patients from the beginning. In addition, we know that the subgroup analysis has lower statistical power. However, the statistically significant result of our subgroup analysis is also present. To conclude the study, as in several earlier trials, we saw this sex-specific heart failure phenotypes, and we also saw that this comprehensive vasodilation strategy harmed women with acute heart failure, and this possibly leads to a need for a sex-specific therapy approach in acute heart failure. So, as the upcoming soccer match is luckily not going to take place in high-altitude conditions, I'm sure that there will be no shortness of breath in our great galactic team, and I thank you for your attention, and I'm open for your questions.
Thank you very much, Desiree, for this very interesting study and results. Here is the first question.
Thanks very much. I was always hoping that Christian would publish the trial would have been positive initially, but I have a question. How long did therapy, the uptitration of the oral therapies occur? Was it just during the inpatient stay?
Yes, so it was started when the patient presented to the ED, and then according to the strategy, it was performed until the discharge of the ward.
It's interesting because your curves are actually the opposite the first 30 days. It looks actually beneficial in women for the first 30 days, which would probably be most related to inpatient therapy. And then after 30 days, when they see their primary care doctor or cardiologist and get other medications adjusted, that's it looked like when the harm occurred. So I wonder if your message is actually vasodilation is more beneficial in women. What happens to them after 30 days is what's in question, right? I mean, your curves are completely opposite. I wouldn't expect if you stopped the therapy at day 8 of hospital discharge that it would impact them at day 60, but it could impact them through day 30. So I wonder if your message could perhaps be the opposite.
Okay, thank you for this comment.
Yeah, I have a similar point, is that the definition of acute heart failure, I don't think is 180 days. I look at this as the first 30 days as max. And if you look at your Kaplan-Meier curves, they are on top of each other for the first week, and it's so long I couldn't tell exactly. But I think that the term acute is done after a week or two, because you're no longer acute heart failure at this point. You got a diagnosis, you're on chronic medicines, and so I don't disagree with your conclusions, but I think it's just chronic heart failure at that point. And there does appear to be a difference in women, and that's fine, but I think the terms need to be examined.
Yeah, thank you for this comment.
The front for...
Yes. Did you analyze if there was any relationship with the effect with systolic blood pressure? because we believe that vasodilators may have a role regardless the sex or the gender, in acute heart failure in very hypertensive patients. Did you analyze if there was a different effect regarding the systolic blood pressure?
You mean a different systolic blood pressure at presentation, or what do you mean?
Presentation, yes.
So between...
sorry, because we try to use a higher level of vasodilators, intravenous or some other way in clinical practice to decrease very high systolic blood pressure. And this seems that can have an effect, a positive effect, which is different when you give transdermal and progressive vasodilator in patients with normal systolic blood pressure. Maybe a completely different scenario.
So overall, these baseline characteristics were really well balanced in the study, and the blood pressure at admission, the systolic blood pressure, was about 135 millimeters of mercury in the whole population. So they were not, it's a median. I mean, there were several patients who had a higher blood pressure, but in the median it was about 130, 135, and it was really well balanced. But we saw a trend that the women who were randomized to the vasodilation strategy later, they had a little bit lower blood pressure compared to the women who were like on the usual care. But this was only kind of a trend.
Any other questions? Thank you very much. We go to the next session.
Our next speaker in this session is, it's actually, we're lucky to have a master lecturer, Sean Collins from America, talking about acute heart failure and
the top one.
Urinary sodium-guided therapy.
Oh yeah, less. Great. Thanks very much. Thanks for the introduction. Thanks to Sal, Christian, and Alex, and Valeria for inviting me, and their great organization as well. We're going to spend a little bit of time talking about urinary sodium, a little bit of a pivot in topics, but I think this may be a cheap and very effective way to measure our response to therapies. We talk about natriuretic peptides and urine output and weight change and diuresis, etc. But I'm hoping after this talk you'll have some liking for considering urinary sodium as a measure of diuretic responsiveness. So we're going to talk about its historical use, which is identifying diuretic responsiveness, and also prognostic utility. You see that net negative sodium during hospitalization is a strong prognostic indicator, a good one. The current recommendations for urine sodium, which are actually quite surprising, and I would suggest the missing pieces are some randomized data. So urine sodium identifies poor diuresis. Spot urine sodium about 2 hours after diuretic is highly predictive of subsequent natriuresis and diuresis. If urine sodium increases, water will follow it, diuresis follows it, decongestion occurs. There's actually extensive data about this. This is just a snapshot from a recent manuscript, but you can see over the last decade several trials all looking at spot urine sodium, many different kinds of outcomes, natriuretic response, cardiovascular outcomes, etc. I highlight one column because I think this is the problem, right? These are a lot of retrospective studies based on prior data. No one has really conducted a randomized or blinded trial looking at if I use urine sodium to drive my therapy, to drive my furosemide dosing, is it better than what clinicians do currently? And I think that's the big unanswered question. How about prognostic value of urine sodium? It's actually quite prognostic. Total sodium balance. Now, granted, this is hard to do. It's hard to measure urinary sodium in the hospital, but in those studies that have done this, total sodium balance is much more prognostic than weight loss, ins and outs, urine output. It's likely because, as we know, the documentation of I's and O's urine output is very challenging, right? Mrs. Jones goes in the toilet, doesn't measure it, flushes it. Mr. Jones goes in the urinal spills. It's just documented as urine output, but we don't know what the quantity was. So very hard to keep good measures of that with 1:4 and 1:6 nursing ratios. So how about natriuretic response and survival? So Jeff Testani is really the pioneer of urine sodium, and they looked at this subset of patients from the ROSE heart failure trial. So 360 patients with acute heart failure were enrolled. All received very high dose loop diuretics following the dose protocol, so 2.5 times their home dose IV. Sodium excretion was actually measured very controlled, as it can only be done probably in a clinical trial. They measured each 24-hour period of urine sodium excretion for 3 days. They analyzed 316 patients, so a subset with complete data for the first 24 hours. We defined a positive sodium balance as when your sodium excreted is less than your dietary intake. So roughly these patients were on 2-gram sodium diets. They measured sodium for 24 hours, and if you peed out less than 2 grams, you had a positive sodium balance. Conversely, the more net negative you were, if you peed out 3 grams of sodium, as you'll see here, that's considered to be a negative sodium balance, which is the most important finding of the study. They looked at 6-month all-cause mortality. 2 figures here. First one just showing negative in sodium balance. So I peed out more sodium than I ate. I didn't pee out more sodium than I ate. Big, big difference in survival. And I put this second figure up to show you that, again, the fluid loss parameter just doesn't matter. It's too hard to correlate. This was in a clinical trial at many, many good centers, right? So fluid loss, net negative I's and O's over the same time period with a positive sodium balance, it was still prognostically poor. Okay, it tells you that this parameter is not very well quantified probably, but those with a net negative balance, again, much better outcomes. So it's interesting if you look at the guideline recommendations for use of urine sodium. This is a position paper. Many of the people in the audience are actually on this paper. And I like it because it actually puts right in the middle here, someone comes in with acute heart failure, gets a dose of diuretic. I quantify their urine sodium or their urine output, and I redose them based on this. If they don't have a good urine output or greater than 50 to 70 milliequivalents per liter, so this is a spot measurement, right, of urine sodium, I actually double their dose of diuretic. So this suggests that this parameter, urine sodium, may be just as good as urine output, and I would argue that it's an easier thing to measure. Are they peeing 150 cc's an hour over 2 hours? This requires a quantity versus I take any drop of sodium, I pull a little sample out of their urine, pull a little sample out, send it to the lab, measure their sodium. Much easier. I don't care if they peed 1 liter or 2 liters. I want to know what their sodium. Initial diuretic, after 2 hours, spot urine sodium, there's that number of 50 to 70 again, right? If you're not peeing out a lot of sodium, the answer is no, double the dose of loop diuretic. So it's in a position statement, it's in the guidelines from 2021, despite there being no randomized data with this. So I would suggest why guideline support, because everything else is quite horrible, right? Urine output, I's and O's, weight change, all really challenging. Someone is net negative 3 liters of urine and they've gained 4 pounds. This makes no sense whatsoever. That's a lot of food they're eating, or one of those two is really inaccurate, right? However, and diuretic resistance from diuretics is obviously not detected till 24 to 48 hours after it began. You don't realize they're getting worse until they've gotten worse. And I think that's where urine sodium will win. It quantifies output initially, and it shows you when they have diuretic breaking. They're peeing out a bunch of sodium, they're above 100 milliequivalents per liter, and all of a sudden it drops to 20. Something else is going on, they need to have their diuretics up titrated. So spot urine sodium really helps us define forward movement and speed from a diuretic efficiency perspective. The big question is, can urine sodium be used to guide diuresis? Okay, well, Jeff Testani put this on the map. It's almost a decade ago now. He published this Sentinel article, and this is where all of this data in the guidelines is coming from. What he has shown in his data is that this is highly really, really good data collection, tight urine collection over a 6-hour time period. But he got a spot urine sodium 2 hours in, and that ability of that 2-hour urine sodium to predict 6 hours total urine sodium, look at that R, 0.91, very, very high. He also found that in patients, many of these patients had Foley catheters in, this spot urine sodium was highly predictive of 6 hours diuresis as well. So a spot urine sodium predicts 6-hour natriuresis and predicts 6-hour diuresis, okay? So he's onto something here, and he went and validated this in a large sample of patients. So kind of a complicated paper, but he used his diuretic titration protocol based on urine sodium and said, I'm going to titrate diuretics if people aren't putting enough sodium out. And I'm going to measure this using this prediction equation he has. Again, spot urine sodium for predicting at 6 hours how much urine sodium they're going to put out. Look at those areas under the curve. Really, really hard to find other test characteristics that are that high. So what he's saying is it doesn't matter whether you pee out a little or a lot, I'm going to be able to identify it with this prediction equation based on a 2-hour spot urine sodium. Okay, one sample 2 hours after the diuretic's done tells you how they're going to do over the subsequent 6 hours. And what happened when he used this formula in the hospital, this is real data. So this is prior to using his formula. You can see peak loop diuretic dosing gets ratcheted up in a major way, and that's not a typo. That's 500 milligrams of furosemide per dose, 3 times a day. So major increases in diuretic, major increases in urine output, major net negative changes, and guess what? Real weight changes as well. Okay, so now he's operationalized this, and this is how it works. Mr. Smith gets a dose of diuretics. 2 hours later, I check a spot urine sample for urine sodium and creatinine in his formula. It goes into this online calculator, which is available online, and it tells you how much total sodium they're going to put out and what your next dose of diuretic should be. And that's how he used this in this real-world example. And then, voila, your diuretics go up a lot. So what happened in his situation? Well, this is the total patients, and 84% of them got discharged, euvolemic, decision to add a thiazide. So the clinicians were getting this data back saying, your patient's either peeing out a lot or not peeing out a lot. And you can see a fair number of patients actually transitioned to a standing order of 500 TID of furosemide. And if you talk to Jeff about this data, what this equation is telling you is that you need to up-titrate your diuretics faster to get to an optimal dose, and when they break and diuretic break again, you need to up-titrate again and overcome the diuretic breaking. And that's how this formula has won. So I think it's compelling preliminary data, but what the next steps are. We have no randomized data. It's in the guideline. It's in a position paper. No randomized data whatsoever. We just started a randomized trial, got funded by NIH, looking at this exact thing. So we randomize patients to what's happened currently. The heart failure team sees the patient, puts them on 120 BID of Lasix for 24 hours. We start measuring their urine, and we titrate. If they get in one group, 120 BID is what they get. If they get in the intervention group, we start ratcheting up their diuretics quickly. The maximum dose in the intervention group is 500 milligrams of furosemide and 500 milligrams of a thiazide, chlorothiazide. So big doses these patients can get to very, very quickly. We stop for important things, symptomatic hypotension, they get decongested and go home. They have a significant bump in their creatinine that the team doesn't want to keep diuresing. Remember, we expect almost everybody to bump their creatinine. In fact, that's a positive prognostic sign when your creatinine goes up during diuresis, because you're probably actually decongesting them. And then our primary outcome is net clinical benefit, which is a combination of symptoms and days on IV diuretics. The whole goal of this is to be efficient as possible, get people off diuretics, transition to PO diuretics, symptoms improved, and not come back to the hospital and get readmitted. Kevin Dahmen and colleagues are doing this right now in the Netherlands. They're about 2 years ahead of us. Their data will probably be out in the next year or so. They look at a little different strategy than we do, but again, randomized, not blinded, usual care versus natriuretic guided treatment. They only go for a couple of days. We go till the end of therapy. Their co-primary endpoint is 24-hour natriuresis, so 24 hours of urinary sodium, and then 6-month all-cause mortality, so quite a ways out. So the main differences in our trial is called Escalate. Push-HF is Dahmen's trial. They are using a dichotomous cut point. If your urine sodium is less than 70, we're using Jeff's equation, which is a little more complicated. It requires a sodium and a creatinine and a calculator, but it's not overly complicated that it can't be used in real time. They don't blind, we do. They transition at 36 hours. We've had patients on our protocol for 10 days, so we go until they're off diuresis. Their max is 5 of Bumex, ours is 500 of Lasix plus a thiazide.
and a little bit different endpoints. But I would say these trials are going to be complementary. I mean, really, Kevin and his team are going to answer a lot of good questions about natriuresis and long-term outcomes and practicality of implementation. And our trial is going to be blinded and looking at a little bit longer course of therapy, but I think very complementary. So in summary, I think urine sodium does quantify response to diuretics. It's associated with better outcomes, especially when you have net negative sodium overall during your hospitalization. And it's to a much greater degree than other measures of diuretic response, urine output, weight change, et cetera. But the real question to be answered, and that hopefully we'll have answers soon, is does a diuretic strategy that targets driving up your urinary sodium as part of the intervention arm really make a difference in your outcomes? Efficient time on IV diuretics, symptoms, readmission, mortality, et cetera. Hopefully we'll have an answer soon. That's it. Thank you.
Any questions? Christian?
Congratulations for putting diuretics again on the center stage, because I think from my perspective they are one of the most underappreciated drugs in cardiovascular care, and I think their benefit in acute heart failure is so obvious, and still some ignorant theoretics argue we should do randomized trials with and without diuretics. Could you comment on how you have chosen the standard of care for your intervention study? Because ultimately, of course, your study will be judged whether the standard of care is really as good as it gets. Now, if I understood it correctly, you use a fixed dose to start with, which is different from what currently guidelines recommend to choose the initial diuretic dose.
So, great question. You're right, because if you compare it to a straw man, your intervention always wins, right? So, I probably misspoke. Usual care is 2 times their home dose of IV diuretic to start with, and then they get that dose open label. Everybody knows that they get 120 to start with. And then what happens is since I'm blinded, I actually order 2 doses. I order what the clinical team wants, which after 120, maybe 120 twice a day, and then what the calculator says they need based on urinary sodium. So our heart failure teams follow the dose strategies, but they actually titrate up fairly aggressively beyond the dose strategies if needed. So, but you're right, the table 1 comparison of doses of diuretics may be dramatically different because of that, because it's physician dependent, but we strongly encourage dose guiding diuretics.
Thank you, Sean. Nice to see that you have this randomized trial coming, and I have 2 questions. What would you advise the colleagues who are seeing patients with hyponatremia already in the beginning? So what will happen to plasma sodium when you do this aggressive, let's say, anti-sodemic treatment? And secondly, what were your tools of assessing the decongestion? Ultrasound of IVC, natriuretic peptides? Please tell me.
You hit on the crux of this study, Veli-Pekka, which is like volume assessment, right? So the volume assessment is really, every day we round with a team, it's JVP, it's their weight loss, it's their leg edema, it's their symptoms, and their net negative I's and O's. It's the old school versions. They do get an echo with IVC collapsibility up front, and ascites and those sort of thing measurements, but it's not done serially. So that's a challenge. I mean, we've been treating patients with a cheap dose, a cheap medication for decades, and we still don't know how to titrate it, but it's limited a lot based on, should we be using ultrasound of the of the internal jugular vein? I think we probably should, but we don't currently. Your first question was about sodium. If it's hypervolemic hyponatremia, which a majority of these patients are, their sodium should get better as you diurese them. However, we have a cut point of 125 serum sodium that you can't get into the trial. If you're lower than that, something else could be going on, and there's definitely a risk that we make him more hyponatremic. Yeah.
Here are the next questions.
How much the sodium add to the diuresis? Because usually after 1 hour, if you see a patient has 100 milliliters of diuresis, sodium is not really, doesn't add anything. Which is the proportion of patients that you think that really sodium is giving the clue that is not responding appropriately?
So how much is that really impacting their diuresis? Yeah, I mean, anecdotally, a lot of people have good urine output and good sodium output early on, and then it's 24 hours in where their sodium really drops off, and that's where it's probably the most helpful, is when they start to break. I should say also, as we did this, we were really careful with how much sodium we gave them, because the blinded bag of diuretic is 100 cc's every 6 hours. It could be a lot of volume, so we give it in D5W for that reason, that we don't want to give them more sodium.
Sean, thank you very much. My question is that many of the heart failure patients are totally volume overloaded. A subset are actually have volume that's redistributed because of vascular resistance. We saw that in all the monitoring we did. And the therapy seems to be very different in both those. The first one, you need to get rid of water. The second one, you need to vasodilate, and they'll get rid of the water. Does this help you in any way discriminating those two types of people?
No, that's a great question. So Richard's talking about the typical HFpEF patient with hypertension and volume redistribution from splanchnic nerve or splanchnic venous sequestration versus the HFrEF patient who's 15 pounds up and has a lot of extravascular volume. And for that reason, so this doesn't help you. And in fact, you could get into trouble if you had a patient who had volume redistribution, wasn't total body fluid overloaded, and started targeting them with urine sodium. You'll pull it off really quickly, and they'll become intravascularly dry. So to get into our study, they have to be 10 pounds above their dry weight, or a physician estimate of at least 10 pounds of volume for that reason. Ideally, we want to have some to be extravascular and some to be intravascular, so we can take off their intravascular component, they can remobilize the stuff from their legs, and we can continue to diurese them. The HFpEF patient with hypertension would be a problem, and we try to avoid those with that 10-pound discrepancy to get in.
Could you comment on a low-sodium diet while in hospital? As you know, there's an overlap between malnutrition in heart failure and the problem of congestion. And just to position myself, I hate low-sodium diet. I was successful getting it rid out of the hospital, and I'd like to know whether this was a good thing or you think is a bad thing.
I think most U.S. patients side with you, Christian, and don't like low-sodium diets either. So we put them on a 2-gram restricted sodium diet, keeping them on that when I walk in the room and there's like cupcakes at the bedside and stuff like that. That's a little challenging, right? In fact, I think that's why the low sodium diet that was just published, right, from European data looked like it didn't work. However, low sodium diet in the US is probably 5 to 6 to 7 grams of sodium when they're out of the hospital. So it's a challenge to keep them on it. And that's the delta we're looking at, though, because if we let them go to 4 grams of sodium, then our diuretic goals are much different. So it's a challenge. I know it's not a fun diet, but we have to keep them a little lower than usual.
I have a question.
Yeah.
In both of your arms, do you have a water restriction? How much they're allowed to drink?
Yes.
What is it?
I'd have to look again because somebody crossed it the other day. I think it is 1,500. It's 1 liter, 1,000 cc's per day. I'd have to look again to be sure. But there is a water restriction because one of them who wasn't on it drank 2.5 liters a couple of days, and so yes, it's a big deal.
Okay. And my second question is, do you really, because of course we know that we should treat heart failure using diuretics, but do you really think that we can maybe guide our therapy using spot urine instead of biomarkers? Because that is definitely where we're going, right?
Yeah,
using biomarkers.
I think it's much more dynamic, and all the preliminary data really suggests, I mean, it's in the guidelines already, that it will be dynamic enough to follow. You know, some of our secondary endpoints are differences in natriuretic peptides between admission and discharge for that reason, but that has been looked at so extensively and so challenging with diurnal variation that daily measurements of peptides are probably not going to be the answer. I'm hoping it's urine sodium.
And maybe whatever you find in your study, this would be something that could be implemented in developing countries where biomarkers are not available.
Correct. I mean, I think lung ultrasound and urinary sodium, right? It's very portable. These butterfly devices for lung ultrasound and urine sodium. It's a test you can do at the bedside almost. So it's like $6 or a few euros to do. Yeah.
Thank you very much.
Now there is a little bit time for a coffee break. I think. Good.
back to the room.
Good morning. We're trying to start the session. Can someone call the people from outside? Good morning, everybody. My name is Christian Nickel. I'm from Basel, Switzerland, and I'm happy to welcome you to the Atrial Fibrillation and Other Arrhythmias session, Young Experts on Stage. One note to the presenters: they're going to receive an email with a download link, so you're going to have your own video. And you can enjoy it twice.
Okay. Good morning. My name is Humberto Villacorta from Rio de Janeiro, Brazil, and I'm very happy to be here co-chairing this important session. Let's move on, and I'd like to introduce our first presenter, Diogo Manhart from Switzerland. He's going to talk about the accuracy and clinical validation of atrial fibrillation detection through smart device-generated single-lead ECGs.
Okay, yeah. Okay, thank you for this introduction. I have no conflicts of interest and nothing to disclose. So imagine this. You have a grandmother or a mother who recently has suffered from a stroke. And her treating physician suggests that the cause of this stroke could be atrial fibrillation. She has recovered really well, and her physician also told her that there are smart devices capable of detecting atrial fibrillation. Now, you as a person being raised on studies, you decide to see what literature has to offer on this subject. Okay, so you do some research and you find out that accuracy varies between the devices available capable of detecting atrial fibrillation. Most of the studies have been conducted in a population that was fairly young and had no underlying heart disease, so probably not someone like your relative. And there have been no comparison of studies within the same patient cohort. Further, you find out that the devices, they report two findings. They either tell you the single-lead EKG that you did with them is of sinus rhythm or of atrial fibrillation. Now, if they cannot decide between either one of those, they give you an inconclusive result. And this might be troublesome for someone like your grandmother. Okay, so we set out to assess the diagnostic accuracy of different devices in detecting atrial fibrillation. We assessed 5 devices: the Apple Watch, the Fitbit Sense, the Cardio Mobile, Samsung Galaxy Watch, and the Widdings Scan Watch. All these devices have a FDA clearance. What did we do in our study? We included patients presenting to the cardiology department of the University Hospital in Basel, and each of those patients received a 12-lead EKG acting as gold standard, followed by 5 consecutive single-lead EKGs from the devices you just have seen. So every patient had 6 EKGs in total. Then all the tracings were given to cardiologists for blind interpretation. And in addition to that, we wanted to see what patients liked the most, which device they preferred. So we did a small survey. Now, for our analysis, we took the diagnosis from the devices. They have an automated algorithm giving you the interpretation, and compared this to the gold standard, the 12-lead EKG. Now, if you remember, we have the issue about the inconclusive tracings mentioned in the beginning. So in order to tackle this, we did a so-called intention to diagnose analysis. This is something where you reallocate inconclusive results to either false negative or false positive. So if a patient had atrial fibrillation in the 12-lead EKG being in the gold standard as positive and had an inconclusive result in one of the single-lead EKG tracings, we reallocated him to false negative and vice versa. How did the devices perform? We included 211 patients. The mean age was 67, and we had about 30% females. So the devices performed pretty similar, as you can see here. And if we reallocated the tracings labeled inconclusive, we got slightly different results. So the Apple and the Samsung performed the same. This is why they are on top of each other, and the other ones as shown here. Okay. As of the inconclusive tracings, there were differences between devices. We had between 16 and 26 of all tracings done by the device being inconclusive. Where does that lead us? From the devices, we didn't see a difference in accuracy that varied too much, was not significant. We came to a 90 to 95% accuracy for all devices. The intention to diagnose analysis reduced this severely, as you have seen in the graph, thus giving a more realistic picture of what the capabilities of this technology are as of today. And if we reviewed the tracings manually, we could reduce the number of inconclusive tracings significantly, down to 1% for every device analyzed. So what can we take from this study for our everyday practice or for our relatives, such as your grandmother or mother? We have a high diagnostic accuracy in all devices. The differences in inconclusive vary substantially. And manual review should be mandatory and is strongly suggested for physicians working with this technology. Now, we need to be aware of pitfalls. Atrial flutter, premature ventricular contractions are really difficult to be detected in a single-lead EKG and could be a major issue if not tackled accordingly. And we should include patient preference to the decision, because in this setting, in this scenario, your grandmother, she chose an Apple Watch. Why did she choose this device? Like many of our patients that we asked, she named two reasons. First, she liked the design. She just liked to look at the watch. And second, she felt comfortable with the brand. She already had an iPhone or a Mac PC, whatever, and she could work with that. So this is what was most important to all the patients in our cohort. Now, if you're not having an Apple Watch right now, or if you need one for your grandmother, we offer you the chance to win one. If you want to see how difficult or how easy it is to assess atrial fibrillation in a single-lead EKG, I invite you to scan this QR code and participate in our quiz. This will be for an additional study, and with some luck, you might just be having an Apple Watch 7 soon. Thank you very much, and I'll be really glad to take questions.
Congratulations, Diego. You're right on time. I would start with one question, then I will open up to the audience. There is no doubt that this smart device can detect atrial fibrillation, but I have a doubt. How much AF do you need to detect to consider it clinically meaningful? Because one study has failed to reduce events with patients with atrial fibrillation detected with the smart device. So do you have a minimal duration? Some argue 6 minutes, some say that the more important is the burden of AF throughout the 24 hours. What are your thoughts about the treatment?
So thank you for this question. I think the smart device is not intended to use as a continuous monitoring device yet to see the burden, for example. I think it could reduce pretest probability. It could be of great use in paroxysmal atrial fibrillation. The patients coming to you and say, I just felt my heart. This does not necessarily have to be atrial fibrillation itself. There are many underlying heart disease in young people, such as we have many in this room today, which can only be detected by chance. And having a smart device capable of this possibility to record a heart rhythm can offer the chance of having something to prove that there was an arrhythmia or something alike. So I think it cannot replace a Holter or a loop recorder yet, but we will see where the development takes us.
All right, thank you. Any questions from the audience? Okay.
If this smartwatch issues an alarm, this could create a lot of confusion or uncertainty or worries for my grandmother or mother. So how would you create some kind of management plan? What would you suggest?
That is an excellent question. Thank you very much. There are applications which you can download in the App Store for the iPhone or Android devices, which offer the possibility to send an EKG recording recorded by one of those devices to a physician or to a medical technician, and for the compensation of a small fee, of course, they look at this tracing and they give you, in addition to what the algorithm from the device or from the phone gives you as interpretation, they give you on top of that a suggestion. Now, we do not have something in Switzerland as of right now, but with the continuous rise of this technology, it is popular, and this is more popular and expected to gain in devices sold totally. We need to have a solution for that, especially for the bigger hospital centers, which could be tackled with this surge of data. Yeah.
If this is not the case, I'm gonna. I'd like to introduce Luc Mosche from Switzerland. He's talking about the association between cognitive performance and present AF on a same-day office ECG in patients with AF. So I'm dreading bad news.
Thank you for the introduction. Hello, everyone, and welcome to my presentation about my doctoral thesis. As you heard, association between cognitive performance and rhythm in same-day ECGs in an AF population. This is an ongoing project, and I'm not done yet, so all results shown are going to be preliminary. Okay, so let's start with the background. As many of you already know, atrial fibrillation is the most common cardiac arrhythmia, especially among older patients. Previous studies have shown a strong association between atrial fibrillation and dementia and cognitive impairment. You can see the mechanisms behind this on this graph or on this figure on the right. However, I want to, in my study, look at the hemodynamic hypothesis more closely. As you can see, part of that hypothesis is that different factors such as beat-to-beat variability and or decreased cardiac output during AF increase the chance of thromboembolic strokes and silent infarcts. I wanted to find out if there was a direct and acute effect of the resulting cerebral hyperperfusion, which could be measured through cognitive testing. So putting this into one sentence, my question is, does the presence of atrial fibrillation at the time of testing impact cognitive function? To answer this, I use data from the Swiss AF cohort. It is an ongoing multi-center prospective observational study with 2,415 patients with atrial fibrillation. These patients are above the age of 65 and received yearly in-person visits at baseline, years 1 to 4, and year 7 if possible. At these in-person visits, patients received a 5-minute ECG and cognitive testing, among other things. For my analysis, I included patients with an ECG in either sinus rhythm or atrial fibrillation, and they had to have a same-day complete cognitive testing at least one in-person visit. Patients with multiple visits were included as repeat measurements. That led us to 1,974 patients, and those patients had 2,821 sinus rhythm ECGs and 2,385 atrial fibrillation ECGs. So now I want to show you how we assessed cognitive function. In this Swiss AF cohort, every patient received every single one of the tests I'm going to show you now. The most commonly known one is the Montreal Cognitive Assessment, which combines different aspects of memory and cognitive function. Then there is the trail-making A and B tests, the digit symbol substitution test, and the semantic fluency test. I won't go into how all of these work due to time constraints. However, all these tests can be combined into a score called the Cognitive Construct Score, or short COCO. It was created in Basel and is a factor score using all neurocognitive tests that I just listed. So, just quickly to the baseline characteristics of this population. First off, you can see that the population was around 72 years old, mostly male, and had a relatively extensive educational background. BMI was around 27, which is slightly overweight, and the CHADS-VAS score was around 3. I divided the population into patients with clinically classified paroxysmal AF and non-paroxysmal, which encapsulates permanent and persistent AF. And as you can see, around 40% were in the paroxysmal group. This is, however, just the patient's clinical classification and not necessarily representative of the rhythm during study visit ECGs. So certain patients with permanent AF could also have sinus rhythm ECGs if they were wrongly classified. Lastly, I wanted to show the patient's cardiologic medication very shortly. As you would expect in an atrial fibrillation cohort, 90% were on oral anticoagulants, and 20% underwent antiarrhythmic drug therapy. So now to my main findings. I used a mixed effects linear regression model, I used two actually, to find a difference in cognitive performance between patients with the same-day sinus rhythm ECG or an atrial fibrillation ECG. The reason I chose a mixed effects model was to accommodate for the multiple repeat measurements in individual patients. The two models I created were a very simple first model correcting only for age, sex, and education, and a more complex one additionally adjusting for risk factors such as previous strokes or hypertension and other things. I won't go into all the cognitive tests in detail due to time constraints, but the two most relevant ones are the MOCA and the COCO. Important to know is that this isn't the classical MOCA that ranges between 0 and 30, but a standardized model, so the values are a bit different. As you can see here, for MOCA and COCO, the beta coefficient, which indicates the effect of sinus rhythm compared to atrial fibrillation on these scores, was very close to 0. And looking at the p-values, it also wasn't statistically significant. This indicates no correlation between cognitive performance and type of rhythm in same-day ECG. Now I want to briefly talk about the strengths and limitations of my study. There are several strengths of this. First, the sample size of around 5,000 data points is very large and consists of well-characterized patients. As we have detailed data on patients' characteristics and medical history, we were able to adjust for several potential confounders. Also, study personnel were trained to perform neurocognitive tests in a consistent way in order to ensure comparability and minimize performance bias. Now to potential limitations. Firstly, even though ECG and cognitive testing was done within a very short time frame, they weren't done simultaneously, which could maybe have been done via a Holter ECG or maybe even a smartwatch. So we can't for sure say what rhythm patients had during cognitive testing. Secondly, we don't have any information on cerebral perfusion during the patient's visit. Finally, I think it is safe to say that the evidence that I have found in my analysis so far indicates no association between cognitive performance and atrial fibrillation in same-day ECG. My project, however, as I said, is not done yet, and all results are preliminary. Also, there are subgroup analyses planned, and it is always possible for there to be better trends in more defined patient groups. Thank you for your attention.
Thank you very much. Are there questions from the audience? Did you record symptoms at time of the presentation that might have an impact on their performance? If I'm dyspneic with a heart rate of 160, maybe my performance on the cognitive testing might be worse?
We have just a very simple, it's the ERA score for atrial fibrillation, where they just say what cardiac symptoms they have, but it's not specific for the day that we ask them. So we ask a very general question. And for a heart rate, for example, we have the heart rate, obviously, because we do a 5-minute ECG. And I'm actually going to adjust my model. It's already planned that I will correct also for heart rate. So, yeah.
Good. Salvatore?
Thank you very much. Very interesting data. Did you analyze also MoCA and the COCO score on the cutoff of a normal or, let's say, values that are similar for cognitive disorder? So did you analyze if there is any difference when you use the cutoff of cognitive the deterioration and the normal MoCA and COCA? Is there any different? Did you analyze that?
Thank you for the question. This very good idea is on one of the subgroup analysis I have planned that I have sadly not done yet, but I will do that for sure. Thank you.
The question, did you analyze if atrial fibrillation had an impact in the cognitive function of patients, or if the paroxysmal atrial fibrillation can impact in the cerebral function in the acute phase? I think it's different aspects, because patients who have paroxysmal atrial fibrillation, they have symptoms related to this, and they may have abnormalities. What did you really analyze with this study?
If I understood correctly, it's more of a question of if this was for the clinically classified or not. So in my analysis, I didn't really look at the classification of the patients. So if they were permanent or persistent or paroxysmal, I just looked at them as atrial fibrillation patients, and therefore it was always only acute. So yeah, I didn't even consider if they were patients with paroxysmal or not. I just looked at the same-day ECG and the cognitive performance.
Okay, thank you very much.
Okay, I'd like to introduce our next presenter, Kathleen Band from Switzerland. She's going to talk about brain lesions and cognitive function in patients with AF, a lesion mapping approach.
Thank you. Thank you for the introduction. Hello, everyone. And hello and welcome to my presentation. I'm doing my doctor thesis also in the same study group as Luke Mosher that you already heard. So I'm working with the same data from the Swiss AF cohort study. The title will be a little bit different. It will be Neuroimaging Predictors of Cognitive Decline in Patients with Atrial Fibrillation now. And it's still work in progress, so I'm going to focus a little bit more on background and study design. As you heard, AF is very common, and it has a lifetime risk of about 1 in 3. And here from the ESC guidelines, you can see AF-related outcomes. There is also cognitive decline mentioned, meaning that AF patients have a higher risk on cognitive decline, and that is potentially due to different mechanisms, as microembolism or white matter lesions, and not only depending on the history of stroke. But there are still many uncertainties about the impact of these different mechanisms on cognitive decline. You already heard about the Swiss AF study, but one important thing to add is that we're also doing brain MRIs in Swiss AF, and I will tell you about that more in a minute. But there are two studies from Swiss AF that I want to mention that found interesting results in these brain MRIs. They could show that in baseline brain MRI, there was quite a high lesion load in patients. And many of these lesions were silent, meaning that the patients did not have a history of stroke. Also, cognitive decline was similarly associated with silent and overt strokes, and this could also be shown in a follow-up period of 2 years. So, to my work, I want to assess the risk of cognitive decline over time, according to whether patients had brain lesions in baseline brain MRI or not. So I really wanted to focus on the long-term cognitive function, meaning up to 7 years of follow-up, based on the baseline brain MRI. So the patients I wanted to have, they had to have baseline brain MRI, a full cognitive testing at baseline. You already heard from my colleague about the tests that we do, and also about the COCO score that combines the cognitive tests together. And all the patients had to have at least one other full cognitive testing at any follow-up visit, so I could see if there was a change in cognitive function over the years. Definition outcome event will be cognitive impairment, defined as a change of cognitive function from baseline to any follow-up, from -1 standard deviation in COCO and MOCA scores, and there will be time to event analysis done. And now just briefly about the brain MRIs in Swiss AF. They were done with a standardized protocol in 4 study centers in Switzerland. We do them at baseline at year 2 and year 7 of follow-up, but I will just focus on the baseline brain MRI. We have 4 lesion types that we look at. These are large infarcts, meaning they have a diameter more than 20 millimeters, smaller infarcts less than 20 millimeters, microbleeds, and white matter lesions. The white matter lesions are graded with the Fonseca scale, and a score of 2 or more is defined as moderate to severe lesion load. So did the patient selection. I took the patients from the Swiss AF cohort, the 2,415 patients, and I excluded the ones without brain MRI at baseline and the ones with no full cognitive testing at baseline. That left around 1,600 patients, and as I already mentioned, they had to have at least one other full cognitive testing at baseline. So my cohort will be 1,536 patients, and I already divided them into 2 groups, the ones with no brain MRI lesions at baseline at all, that was 1/3, and the ones with any of the 4 mentioned brain lesions in baseline brain MRI, that was 1,030 people, so 2/3 of them. So to the baseline characteristics of the 2 groups with no lesion and any lesion at baseline brain MRI. The group with any brain lesions, they are older, they have a higher CHA2DS2-VAS score, they more often have permanent AF, and they perform a little bit weaker in the cognitive testings. So what is planned to do is a multivariate analysis and Cox regression and subgroup analysis using different cognitive tests and differentiating between lesion types. The expected results are an association between lesions in baseline brain MRI and cognitive decline over time, and shorter time to event in the any lesion group, and that infarcts will be more strongly associated with cognitive decline compared to the other lesions. Shortly to strengths and limitations. On the plus side, we have standardized MRI and standardized cognitive testing. I think that leads to quite a high quality of data. We also have a long follow-up period. In the mean, it's 5.8 years. And we have quite a large sample size. And to the limitations, it's an observational cohort study. That means we can only make associations, and we have different number of cognitive tests in the patients. And there is a possible attrition bias, meaning that the patients with more comorbidities or even the weaker cognitive scores leave the study a bit earlier than the other ones. That's it. Thank you very much.
Thanks, Kathleen. Questions from the audience? Daniela.
Congratulations for the nice presentation. I just wanted to ask, are you planning to do some analysis regarding the type of the anticoagulation used and the cognitive decline, or in the MRI, the type of the anticoagulation, and also with these 10% of patients that are not anticoagulated, they probably have some atrial closure device because they bled or something, but regarding the therapy?
Thank you for the question. That will for sure be done, not in my analysis, but that's for sure something that we look at in Swiss AF in the future. Yeah.
Any other questions? Let me ask you one question. The patients with brain lesion, they were older,
yeah.
Correct?
Yeah.
And do you believe that perhaps the lesions that you have found are more related to the atherosclerosis itself rather than atrial fibrillation? What do you think?
Yeah, I think that's really hard question. It's really hard to differentiate between the two as well. But I think that there are various factors that are combined with the brain lesions. And yeah, I think that we have to look at a cohort without atrial fibrillation, do the same. That's what we're doing with Swiss AF right now. We're doing a controlled cohort, so we can just do that now.
Okay, thank you.
It's my pleasure now to introduce Elisa Hennings from Basel, Switzerland. She's going to speak about bone morphogenic protein 10, a novel atrial-specific biomarker to predict adverse outcomes in patients with AFib. Elisa, the floor is yours.
Thank you very much. Yeah, hello. Thank you very much for inviting me. My name is Elisa Hennings, and I work also at the Cardiovascular Research Institute in Basel. I would like to present you our findings about BMP10, a novel and atrial-specific biomarker to predict adverse outcomes in patients with atrial fibrillation. Here you can see that the AF prevalence is expected to double until 2060, which is mostly due to population aging. Why is this a problem? AF is associated with high mortality and morbidity. AF patients have an up to 3.5-fold increased risk for death. They suffer of strokes, heart failure, and they have a higher hospitalization rate compared to patients without AF. Therefore, AF is a major burden to patients, society health, and health economy. However, AF patients are a heterogeneous group, and not all of them have the same risk for these adverse outcomes. The question is now, who's at increased risk for these outcomes? But as Niels Bohr said, a Danish physicist and Nobel Prize winner, it's hard to make predictions, especially about the future. And it's the same with AF. It's not easy to make these predictions. In daily routine, we use clinical scores like the Schatz-Wass score to estimate the stroke risk and to decide whether to establish oral anticoagulation therapy. However, the score is only moderate, and we have no scores for other outcomes than stroke. Biomarkers can contribute to a more precise risk assessment, but currently there's no AF-specific biomarker. Therefore, BMP10 is very interesting for AF patients. BMP10 is a cardiac-specific biomarker expressed in the atrial chambers of the heart. It is important for cardiac development and was associated with cardiomyocyte hypertrophy, fibrosis, and inflammation. All important factors in AF. A research group from Birmingham found out that higher levels of BMP10 were associated with a higher rate of AF recurrence after catheter ablation. Here you can see the Kaplan-Meier curve, and the patients in the highest BMP10 quartile in violet Q4, they had also the highest AF recurrence rate. BMP10 outperformed 11 other cardiovascular biomarkers in their study, and you can see that BMP10 had the highest hazard ratio for AF recurrence, and the other cardiac biomarkers like troponin or NT-proBNP had a lower hazard ratio. So we wanted to challenge this biomarker and evaluate its predictive value for other outcomes. Our first aim was to assess the association of BMP10 to all-cause death and major adverse cardiovascular events in AF patients. MACE was a composite of stroke, systemic embolism, myocardial infarction, cardiovascular death, and hospitalization for heart failure. Our second aim was to compare the predictive value of BMP10 to that of NT-proBNP. So we analyzed patients from Swiss AF. Luke and Katalin have already told you about this multi-center cohort study. It is conducted in 14 centers in Switzerland with more than 2,000 AF patients. Included are AF patients over 65. And we have BMP10 and NT-proBNP levels at baseline and perform yearly follow-up visits. Now to the results. First, a quick overview about the baseline characteristics. Patients are about 73 years old. 30% have coronary artery disease, 70% hypertension, 18% diabetes, and about 20% a history of stroke. So we stratified patients according to BMP10 quartiles, and you can see in dark blue that patients in the highest BMP10 quartile had also the highest cumulative incidence for both outcomes. And in the lightest blue are patients in the lowest BMP10 quartile, and they had also the lowest cumulative incidence for both outcomes. We constructed also multivariable adjusted Cox regression models, and you can see that the hazard ratio of BMP10 was elevated for both outcomes. There was also a strong linear trend across the BMP10 quartiles. I think everyone likes a good race, so the interesting question now, which biomarker is better, BMP10 or NT-proBNP? Here you can see the ROC curves for BMP10, NT-proBNP, and both biomarkers combined. And when we look at the AUCs, all are quite similar with overlapping confidence intervals for both outcomes. In the next step, we group patients according to clinical used NT-proBNP categories for AF patients in low, intermediate, and high, and then further divided patients according to the median of BMP10 in low and high. And you can see that the hazard ratio is elevated. Oh, sorry for the... so you can see that the hazard ratio is elevated for BMP10 in the low and high group of NT-proBNP. To illustrate this, I show you here the Kaplan-Meier curves for both outcomes. So in red are all the patients in the high NT-proBNP group, and the dotted line are patients who have additionally high BMP10 levels, and they have the highest cumulative incidence. The same pattern was observed in the low NT-proBNP group in dark blue, so patients with high BMP10, the dotted line, had also a higher cumulative incidence compared to patients with low BMP10 levels. Our study has several limitations. We have blood levels of BMP10 and NT-proBNP only at baseline and not immediately before or after an event. No distinct BMP10 cutoffs are known so far, and our results only apply to AF patients, and the predictive performance of BMP10 in patients without AF remains to be addressed. And also, we can only provide association due to our study design. So to summarize, BMP10 was strongly associated with all-cause death and MACE in our large cohort of AF patients. The predictive performance was quite comparable to that of NT-proBNP, and BMP10 seems to provide additional information in the low and high NT-proBNP groups. Thank you very much for your attention, and I thank also my whole research team and co-authors.
Thanks for this great presentation, Elisa. Are there questions from the audience? Frank.
Thank you. That was a good job. When you let a biomarker out into the real world, doctors start using it in places you had no intention for them to use it, and the specificity goes in the tank. Have you done any analysis on, I know Christian has the APACE database, frozen blood samples from any other thing besides AF?
Sorry, you mean that if we measured also BMP10 in other...
Any other conditions in the world?
No, not yet, but we are planning to do, like Katalin said, we are in the moment recruiting patients for control group, so SwissAF control, and these are patients without AF but similar risk factors, and there we will also measure BMP10 levels, so this is very important point. Yeah, thank you.
You have time to get out the freezer.
Yeah.
More questions from the audience?
Can I have two questions? Congratulations for your presentation, Elisa. I'm a big fan of biomarkers, and I'm very impressed with BMP10, and seems to be a very good one. You are probably aware of the ABC score, ABC stroke score, and the ABC bleeding score. They use biomarkers. And in the ABC bleeding score, GDF-15 was found to be the most important predictor of bleeding. Did you specifically look into bleeding as a variate to predict a risk?
Mm-hmm. Yes, so we looked also at bleeding, but their BMP10 was not very useful.
Okay. Are you planning to create a score as well? We're combining BMPT and clinical variables?
Yeah, this would be very interesting, but I think first we need more studies about BMP10 and also to see if there are maybe other subgroups where it's useful, because in the direct comparison with NT-proBNP, there was not such a benefit, and NT-proBNP is everywhere available and not so expensive, so I think it's not easy for BMP10 to show its strength.
Is this biomarker already available for clinical practice or only for research?
It's only for research.
For research at this moment. Okay, thank you.
So I'm really excited that you have a control group now. Do you think, what's your best bet? Will this BMP10 be able to predict the occurrence of atrial fibrillation?
Yeah, that's a very good point, and yeah, this is my hope. I think BMP10 might be predictive also of the AF burden, maybe. So we will also compare the AF burden. We have a subgroup also in SwissAF control where we have Holter ECGs, and we will analyze if there's a correlation. So maybe in the control group, we might see that patients who will develop AF, they might have higher BMP10 levels from the beginning, but maybe the doctor just didn't catch it yet. but maybe we can with BMP10. I'm not sure yet.
Okay, there's a question over there.
Thank you very much for the very interesting data. I was just wondering, did you look at the left atrial size and the level of the biomarker?
Mm-hmm. Yeah, that's also very interesting, the correlation. Unfortunately, we don't have the data in Swiss AF for the whole population. We will also, we have like the Swiss AF burden study, the subgroup with the AF burden, and there we have also MRIs from the heart, and we are measuring these kinds of things, and then we will correlate it, but we haven't done it yet. Yeah, that's very important, I think.
Okay, thank you very much.
Thank you.
Okay, let's move on. Our next speaker is Nina Mader from Switzerland, and the topic is the incidence of prolonged HV interval after transcatheter aortic valve replacement.
So, hello everyone, thank you for the introduction. As you can see, I'm also working at the Swiss AF team in the Cardiovascular Research Institute in Basel, but today I want to speak about the incidence of an infranodal conduction delay in patients with a new onset left bundle branch block after TAVI. So the impact of the new 2021 ESC guidelines for cardiac pacing. First, I want to give you a brief background. So transcatheter aortic valve implantation has become a well-established treatment option for patients with symptomatic aortic stenosis, currently still predominantly for patients with a high surgical risk. As you can see here, the aortic valve is right next to the conduction system. For this reason, conduction disturbances in general, and especially infranodal disturbances, are a common problem after TAVI, and the occurrence of a left bundle branch block remains the most frequent complications post-TAVI. But infranodal conduction disturbances, or the difference between intra and infranodal blocks, is not or just is sufficiently detectable on the surface ECG. So, such as the infranodal HV interval. So how do you measure the HV interval? This measurement can be done by an electrophysiological testing using an intracardiac catheter. Here on the left side, you can see an surface ECG and the corresponding His bundle ECG above it. In this way, one can measure the HV interval, which corresponds to the distance from the His bundle to the ventricle. Until recently, no consistent guidelines were available, and the practice varied from side to side. And here you can see the new ESC guidelines for the management of conduction disorders after TAVI, which were published in August 2021. But I will only briefly discuss the new management of the new left bundle branch blocks. So here, an EP testing is recommended with a 2A indication in patients with a new left bundle branch block, with a QRS over 150 milliseconds or a PR over 240 milliseconds. So while in general a baseline HV of over 55 milliseconds is considered as abnormal, now the guidelines recommend to use a cutoff for the HV interval over 70 milliseconds to consider a pacemaker implantation. We analyzed a prospectively included cohort of patients who underwent TAVI at the University Hospital in Basel between June 2020 and May 2022. A surface 12-lead ECG was available before and after the intervention in all patients, and also an EP testing was performed in all patients after the intervention. This means right after the valve was in place. And if the patient developed a new left bundle branch block that persisted over 24 hours in the ECG, they received a repeat EP testing the following day. So there were 185 patients who undergoing TAVI over a period of nearly 2 years at the University Hospital in Basel, and 40 patients were excluded, for example, because of pre-existing valve replacements. Therefore, we were able to analyze 145 patients. The mean age was around 81 years, and nearly 50% were female. Among these 145 patients, 75, which roughly 50%, demonstrated a new onset left bundle branch block right after the intervention. Of these, 25 ended up persisting in the ECG the next day. Of these 25 new left bundle branch blocks, 11 met the new ESC criteria and would receive EP testing under the new guidelines after 3 days. In our case, the standard was an EP study the next day, so where 2 of them showed HV prolongations over 70 milliseconds. Of the 14 that showed a new left bundle branch block, but no further QRS or PR prolongations, none had a HV prolongations above 70 milliseconds, either in the EP testing after 24 hours. So by using these predefined criteria for PR and QRS, we could rule out very likely a HV interval over 70 milliseconds with a sensitivity and a negative predictive value of 100%, and the number needed to test could be reduced by 56%, so in our population. There are some limitations to this study that need to be considered. So first, it was a single-center study with a small study population, since only new left bundle branch blocks were assessed. And also in our case, the EP study was performed 1 day after the intervention, whereas the guidelines recommend this 3 days after TAVI. But this recommendation came out long after we started the study. So in conclusion, TAVI is associated with an increased rate of various conduction disorders, some of which may lead to pacemaker implantation. And a simple surface ECG can be used to identify patients at risk using non-invasive predictors. That is, if these new criteria regarding QRS and PR are not present in patients with a new left bundle branch block, one can rule out the HV prolongations over 70 milliseconds with a high probability. But further larger and prospective studies are needed to validate these findings and evaluate the newly defined cutoff of 70 milliseconds. Also, whether other factors such as gender have an influence and should be considered in future studies. So thank you for your attention.
Any question from the audience?
Nino, fantastic talk, congratulations. Just one question, do you have any information about the type of the valve? Because we could assume that a self-expandable valve leads to disturbances a few days after, and if you do the test quite early, 1 day after the implantation, there may be some differences between a self-expandable or a balloon expandable valve. Do you have any information about the type of valves?
That's a really good question, and that, yes, it's more often in these valves, but I'm not sure if we have this information about this. I have the type of the valve, not self-expandable, but which valve is used in. But I'm not sure if these are self-expandable. Sorry.
Okay, any other question? Dr. Mills.
Thank you. Really interesting study. I may have missed it, but what proportion of the 185 patients required a pacemaker? I have some anxiety that we over-implant pacemakers in these patients due to expediency to get them out of the hospital when this is just transient edema. And in the old days, we'd always wait, 2 weeks after a myocardial infarct before committing to a pacemaker. Are we being too expedient? So the question really is how many had a pacemaker, and do you think we are over-implanting in general in this group of patients?
That's a really good question, and I think that's the whole point of the ESC criteria, which want to minimize the pacemaker implant. And you have to fishing the right patients who needs a pacemaker implantation, but you're right, in a few days, or no, how can I say it? After TAVI, a lot of patients have QRS prolongations, but a lot of them going to a normal QRS in a few days. So maybe it's a good idea to do this EP study after 3 days and not as we did it in 1 day. So maybe some of them can repair.
Any more questions? Okay, thank you.
Okay, now we're switching gears. This is now the Senior Scientist Lecture. I'm happy to introduce Tobias Zimmermann to the stage. He's going to talk about syncope, unmet needs, and future directions.
Thank you very much, Christian, Professor Villacorta. Thank you very much for the kind introduction. Dear colleagues and friends, it is wonderful to be here in the wonderful Florence. And before I start, I just have to take the time and say that the quality of the presentations this year was incredible, and not only from the junior scientists, but also and especially from the senior scientists. So I'm really honored to even be mentioned in the same category as them. My talk today is going to be about syncope, unmet needs, and future directions. And if you're wondering what this young fellow is doing on the first slide here, I will come back to him later, and you will understand. So syncope management, why is it difficult and why is it important? Well, for one, syncope is very frequent, and it accounts for 1 to 2% of all emergency department visits, and around 30% of all people will experience a syncopal event at least once in their lifetime. Furthermore, syncope patients often have a very heterogeneous presentation to the ED, and also if they're suffering from true syncope, they often might not even have memory of the incident, which makes it even harder. But you also can't just put them aside and say, well, they had syncope, they feel fine now, so why do we even bother? Because you might actually be missing a life-threatening cause of syncope, such as cardiac syncope. And as management of these patients is actually really difficult. Unfortunately, we often see residents on the ED like this, which is quite unfortunate, and we should really try to do something about that. Whenever something is difficult and we don't know really what to do, we turn to the guidelines. And we also have guidelines for syncope. So we have the 2018 European guidelines for syncope, and we have the 2017 American guidelines for the evaluation and management of patients with syncope. And we recently published a paper where we retrospectively applied the risk stratification criteria and the admission criteria of both guidelines to the Basel IX cohort. And our findings were actually interesting because we found that the disagreement between the two guidelines was actually quite large. They disagreed regarding the admission decision in around 25% of patients, and also the sensitivity and specificity of both guidelines for the diagnosis of cardiac syncope and also for the prognostication for adverse events was actually quite low. So there's definitely room for improvement with the guidelines. And just to show you one graph out of this paper, you can see that regarding cardiac syncope, both the American and the European guidelines, so in green you see the discharged patients and in red the admitted patients, you can see that both discharged around 6%, so 150 patients who turned out to have had cardiac syncope. Compared to that, the actual physician decision was better in that regard, and they only sent home around 2.6% of patients who turned out to have cardiac syncope, but at the same time at the cost of a overall very high admission rate. So when we have a patient with syncope, what are our pillars of evaluation? So one pillar for sure is the ECG. And we looked at that, we analyzed the ECG criteria from the presenting ECG, and we identified a couple of factors that were predictive for an early diagnosis of cardiac syncope. Their symptoms This paper is still work in progress. Some of you might already have read the first draft, but we were able to identify there criteria such as syncope while exercising, who were predictive for cardiac syncope. And also, just because we talked about this in the previous talks, we also found that women present with more various symptoms, with less specific symptoms when they had syncope. There's biomarkers, and we specifically looked at troponin and NT-proBNP and found that they were helpful in some patients, but overall had moderate performance. And then I also put physician judgment. This is kind of cheating because it integrates a lot of the other points, but I think it's still a very important part of patient evaluation. That's why I put it here. And we looked at that as well, and we found that actually the physician judgment had a very good discriminative performance for cardiac syncope versus other causes. And when you try to integrate all these different pillars or evaluation strategies into one, what you usually get are scores. And we have looked at scores previously, a couple of years ago, and we found that the performance of these scores were moderate at best. So in the guidelines, we have not any scores recommended, and we found the same thing, the performance just wasn't there. But since then, a couple of new scores were derived. So one of them was developed by a friend of the great consortium, Benjamin Sun, and they developed the FAIN score, which is a very easy to use score, consists of only a few variables, has very easy scoring, but already in the derivation, this score had only moderate performance, and we looked at it quickly and also found only moderate performance in our cohort. But then along came the Canadian Syncope Risk Score, and some of you might have already heard about this. This score is interesting because it had a very good performance in the derivation cohort with an area under the curve for 30-day adverse events of almost 0.9, and also in the national validation cohort, its performance was very good. The score consists of different items from clinical evaluation and investigation, such as biomarkers and the ECG, things we mentioned earlier, but also, and most importantly, it includes physician judgment. So it includes the discharge diagnosis from the ED. And that's vasovagal syncope, cardiac syncope, or another cause. And I think studies have shown that scores that include the physician judgment just generally perform better. And what we found when we validated this score, and we recently published this in Annals of Internal Medicine, was, you can see there's a solid line here, the performance of the CSRS of the Canadian Syncope Risk Score was really good in our cohort as well, with an AUC of 0.85. But most interestingly, when you look at the dashed line, here it's denotified as sync class or syncope classification, which is another word for the discharge diagnosis. This was, or had a almost similar performance with an area under the curve of 0.83. So it was almost as good as the whole score. So the question that comes to mind is, why is physician judgment good, but at the same time isn't? So we have the graph on the right where we can see that it has good discrimination. So apparently our physicians, when they discharge patients, have a very good feeling, or when they finish the evaluation of the patient, have a very good feeling about whether the patient is at risk or not. But at the same time, when we look at the graph on the left, we can see that they hospitalize almost 50% of those patients. So how do these two aspects fit together? And I don't know the answer, but I think there's some hypotheses. I called them soft and hard factors. So soft factors, for example, I felt were like when patients were frail or elderly patients presented in the middle of the night. Perhaps you're not going to send them home even though you're pretty sure it's not a high-risk syncope. And also hard factors, if a patient who you're almost certain that he had orthostatic syncope, but he got a concussion because he fell, then you're not going to send him home either. So it's, that might impact these data. And to be honest, our study and also every other syncope study hasn't really paid attribute to these factors. And then I found another study, or a survey that was published 2 years ago, and I found it very interesting because 55% of physicians, were European physicians working in European hospitals, were asked how many patients they hospitalized, and they said over 50% said they hospitalized less than 25% of patients. And we saw that the real number is probably closer to 50. So it's a survey, it's not hard data, so it's probably this answer is more like wishful thinking, and we all may or may not know this from other areas in life. 88% of the physicians said they do not have syncope units, and this didn't, I wasn't wondering much about this because I think in Europe at least syncope units aren't that big of a thing yet. But what was impressive to me was that 55% of physicians said they do not have syncope-specific protocols. And I think that this is actually an issue, because if you have a disease or a presenting symptom, whatever you want to call it, that is very difficult to manage, and then you have the doctors that care for the patients and they do not have a specific protocol how to deal with them, I think this can only lead in failure. So as an example, and I'm not claiming that it is perfect, although Christian might disagree with me, this is our syncope evaluation strategy for syncope patients in Basel. We have a platform called Med Standards where we have different guidelines for different, mainly ED patients. And you can just, if a patient with syncope comes to ED, you can follow these different steps to evaluate them, and you get some help on the way. Now we talked so much about problems with syncope, so while I was doing research for my presentation, I came across this quote, and it was here attributed to John Lennon, who was on the first slide already, and it said there are no problems but only solutions. And I was wondering, because the whole topic of this talk is basically about problems with syncope, so I did some research, and I was thankfully able to find that John Lennon actually never published anything regarding syncope, so I think we're safe to ignore this statement here. So how do we proceed from here? This is not really a conclusion, but more of open questions that I would like to present to you. Do we perhaps need new scores that help us in the evaluation of patients with syncope? We have some scores, they performed well, maybe the Canadian syncope risk score. I'm happy to hear what you think about it. Do we need new biomarkers? We have evaluated some. There are some new biomarkers on the market that were not widely evaluated yet, so perhaps that is a solution. Should we just trust the physician judgment? Is there even a problem? Because we saw that theoretically the physician can discriminate just fine. Do they even need more help, or should we just trust what they decide? Or perhaps do we really need syncope wards? Do we need specific protocols for the evaluation with syncope? Again, unfortunately, I don't have the answer to these questions, but I'm happy to discuss this topic, and I'm happy to answer any question if I can. And with this, I would like to thank every one of you, and thank you for having me.
Thank you, Tobias, for another great senior scientist lecture. Are there questions from the audience? Yes, I see one over there.
You can't ask about type 2 this time.
Sorry, we can't hear you that well.
Is that better?
Yeah.
Yes.
Yeah, a lot of the focus locally has been on wearable devices and patches. And so our syncope protocol has rapidly moved to just sending them home, irrespective of the risk, with a patch on. And we're doing observational and randomized studies there. I'm interested in whether that, I couldn't read your protocol, sadly. Jasper is working on my Swiss, but I couldn't quite read it. Do you use patches? What's your approach to follow up for rhythm disturbance?
So that's a very good question. Thank you very much, Nick. I think this is difficult. We do not use patches or anything like that yet. I think if you use patches and outpatient management in patients where you're unsure if it's cardiac syncope, you have to be very careful, because it's the same if you use Holter monitoring in the hospital, but they're not live monitored, it's just being recorded. So you have someone who are not sure if they have cardiac syncope, you send them on the ward with a device, they arrest, they die, and afterwards you know, well, it was arrhythmia, great, it was cardiac syncope. So that doesn't help very much. So I think if you use patches and devices for outpatient management, which would theoretically be great, I think you have to have the right infrastructure to have a live monitoring of some degree, some alarm systems that go off if the patient has arrhythmia. I think those are very important factors to consider, and I don't know how exactly this system works in other countries, but I think it's probably not very easy to really do this well.
More questions from the audience? Yes?
My question is, if you have a patient with syncope coming to ED and you're monitoring him from the beginning for, let's say, 4 to 6 hours that he is in the midwife, that he is in the ED, like we do in many hospitals in Italy. This adds something, the judgment of having is included in the guidelines.
That is also a very good point, thank you. It's one of the reasons, is what you said, that we excluded patients with an event on the emergency department for the evaluation, for example, of the Canadian syncope risk score. Because the idea of the Canadian syncope risk score, at least, was not an early triage when the patients come to the ED, but have a disposition decision aid for the physicians when they leave the ED, basically, should they be discharged or hospitalized. And when we excluded those patients with an event on the ED, I think it was around 10% of patients who had an event while being monitored on the ED, but the rest of the arrhythmias or whatever events just occurred later. So it definitely has an impact, but those patients were excluded for this study.
Okay, I have a question too. You mentioned some difficulties in the evaluation of older adults. Do you have any information on pre-syncope or almost fainting or near syncope?
So we did not include patients with pre-syncope in our study in Basel, but we, due to the kindness of Professor Sun and in collaboration agreement, we had access to the data of the SRS study, which is a large multi-center US study in patients with pre-syncope and syncope. And I cannot give you any exact numbers because it's quite some time ago that we looked at it. But actually patients with pre-syncope, the outcome of them wasn't that much better compared to patients with real syncope, so it was quite similar.
Okay. Last question from the audience? No? Okay. Thank you very much.
Good. My pleasure to introduce our next speaker, Frank Peacock from Houston, United States. Frank, your dirty stethoscope is killing patients. What do you mean?
Yeah, okay. Thank you. And it's a real pleasure to be here. I don't know, this is like my 15th year, and this has been one of my favorite meetings ever, and I'm happy to come and proud to be part of it. So about 25 years ago, this guy calls me in my office and says, "Hey, I got this new blood test. It's a hormone for heart failure." And I said, another one of these crackpots is calling me. And it turned out that it wasn't a crackpot. And some of you know him, it's Scott Mader. And the hormone was BNP, which is now the gold standard diagnostic for heart failure. And he called me about 5 years ago again. And he said, "Your stethoscope is killing my patients." I said, this crackpot's back again. But you got to listen to some guy who invented BNP. So this is me in my hospital. This is pre-COVID, and I'm about to see a 14-year-old girl who's got chronic lung disease, and I'm required by my hospital policy to do this. And so I put on my gloves, and I put on my mask, and I put on my gown. But if you look real closely, you see my stethoscope is just hanging out there with just going to go rub it on her, like we always do. And that's what my hospital policy, and this is me in COVID, and it's no different in COVID, except I wear this silly mask. My stethoscope is still hanging out there in the wind to touch people. And so I started looking at the data on this, and this is the data on your hands, and the blue numbers are total aerobic bacteria counts, and the red are MRSA, methicillin-resistant Staph aureus. And you can see there's a whole bunch on your fingertips. And we wash our hands between every single patient. In fact, I'd get fired if I didn't do that. But if you look on your stethoscope, the total counts exceed everything except the fingertips on the diaphragm of your stethoscope. And I'm thinking, well, I've never washed well, that's not true. I've washed my stethoscope sometimes. But if you think about it, the hand is a glove, but we don't have gloves for the stethoscope. And I want to ask you, how many of you guys wash your stethoscope? How many wash it between every patient? Okay, so I'm going to show you some data on that. So this was a study we did. It's our ambush study. And we literally would walk down the hall and ambush a doctor or a nurse or a medical student and say, "When did you wash your stethoscope?" And they say, "Oh, I just did it." 86.5% of them said they just did it. And they did it according to the CDC guidelines, which if you read them, you're supposed to wash it for 60 seconds with an alcohol swab with isopropyl alcohol on it. And I'm thinking, really, you did that? So we cultured it right there. Well, it turned out that 76% of the medical students had bacteria on their stethoscope, and 91% of the doctors did. So we've proven that doctors are dirtier than medical students. But the truth is, either they are lying to me about cleaning their stethoscope, or washing doesn't work. And I don't care about the answer of the truth here because it's dirty, and that's the bottom line. These are two studies that we did, and one in my emergency department, one in the VA hospital in San Diego. And what we did is we wandered up there, and I had a medical student with a clipboard and a white jacket run around and just watch people interact with the patients. And they did it a lot. There's 400 patients. And at the end of that, and this was in the ICU and the ER and labor and delivery in the OR, places where you'd think they'd be washing things, the total number of washing stethoscopes between patients by the CDC guidelines was 4%. 96 of them didn't do it. And then we repeated this study at the VA hospital, it was the same thing. So 800 patients, you're more likely to get stung by a bee than get a washed stethoscope. And I talk to people that and go, well, do I really need to wash it? Are there any randomized controlled trials showing that it causes diseases? And I'm sitting there going, randomized controlled trial. Okay, so you're going to walk up to a patient and say, hey, dude, I'm doing this study where we're going to rub pathogens on you and see if you get sick or not. Will you sign the consent form? And there's nobody going to sign that consent form. It's the same thing as the parachute. We don't have a randomized controlled trial. The parachute works. So we're never going to have one on stethoscopes either. We can only do registry data or things like this. And this is where this guy named Thaker took cauliflower mosaic viral DNA and stuck it on the stethoscope, and then went to a mannequin. They examined the mannequin, and then they went to the next door mannequin, and they examined that mannequin, and then they cultured the second mannequin, and 28.3%, 41 of the mannequins had cauliflower mosaic virus on them from the first mannequin. So it's clear about 28% of the time you can do a pretty good job of moving bugs around with your stethoscope. This is just a couple papers on that. Connect says, Connect was looking at bacterial populations, and it shows that you can't clean them off your stethoscope, and the guy on the right, Palmer, did it with 65% alcohol and then cultured the stethoscope, and it's 28% still. You cannot clean your stethoscope even when you do a good job of it with alcohol. So clean it all you want. Unfortunately, it doesn't make much difference. And I'm pulling out C. diff here specifically because C. diff doesn't get killed by alcohol. It goes into spore form and it sits there, so you have to use a special C. diff killer on it, and if you don't, where's Luella? This is from her hospital. They went and cultured a bunch of stethoscopes from doctors and found out about 5% of them had C. diff on them. The crazy thing about C. diff, it can last for a year on a surface as a spore. So if you've seen one C. diff patient in the last year, you might be one of the 5% who's got C. diff on it, and that kills about 39,000 people in the US a year. This is a trial where they put C. diff on stethoscopes, put them on a mannequin, went down to the next door mannequin, cultured them out there, and somewhere between 25 to 75% of the mannequins had C. diff on them from the first mannequin. So it's pretty clear that I don't have a randomized controlled trial that you can infect people with your stethoscope, but it's pretty clear you could. So this is what the crazy idea that Scott came to me with, was that device up there. You walk up to it, you wave your stethoscope, a little barrier comes out, you stick it on there, and you go see your patient. It takes about a second. You don't have to wash your stethoscope anymore because it takes 2 seconds and you throw it away when you're done. It's acoustically invisible. There's 400 in a box, and that's what it looks like. So I did a study on this. I took a bunch of stethoscopes, and I put stool and infected urine, you get this stuff out of the freezer of lab friends, sputum, infected blood, and smeared it on the stethoscope, and it didn't smell good at all. And we set it there, and we put them into the incubator, randomizing some to barriers and some to not. And we pulled them out every few hours and up to a week. And a week later, this is what you get. Those are all the controls and the actual cultures on there, so there's bugs on them. We put them there. And the ones that had the barrier had no bugs. They were sterile. Up to a week. Now that barrier is supposed to be disposable. You're not supposed to use it for a whole week, but it just shows it works. And the next question is how much does it screw up your stethoscope? Because if it screws up your stethoscope, what's the point? So I have a friend who's a residency director. We ran his entire residency class through the simulation mannequin. They either used a $627 Littman 3200 recording stethoscope with or without a barrier, or they used a disposable stethoscope. And we just saw how well they did. And these guys were surprisingly good. There are 800 auscultations. In the red there was no difference with the retort. They got 100% right, which I was really surprised because some of these diastolic murmurs are difficult. They got 100% right if they use a digital stethoscope. With or without the barrier, it didn't matter. If they use that crappy disposable toy stethoscope, which I hate and I find in my ER all the time in the negative suction rooms, you missed 1 out of 10. So the number needed to harm is 10. Every 10 patients, you blow the diagnosis. And they always blew the diastolic murmurs. So they missed the heart failure patients, and that's the problem. So then I did a study here to see if this thing worked at all. And so it was pretty easy. I put a iPad next to the box and said, here, when you're done using this, just fill out the iPad. And this is what they said. So did they like it? Well, 93% of the people thought it was better than cleaning their stethoscope for 60 seconds with an alcohol swab. And they felt it was an improvement, especially over the disposable stethoscopes, which we all know aren't very good. And then they thought it had at least a benefit to their workflow, because if you really do clean your stethoscope, it takes time. I see 50 patients in a busy ER shift. That's 100 minutes of stethoscope cleaning that I just don't have. I barely have enough time to wash my hands. And they also believe it improves stethoscope hygiene. And they believe it will improve patient safety, and you can see the C. diff number there. Cost-wise, this thing's a quarter, 25 cents. I guess in euros it would be 30, almost the same nowadays, since we've sort of equalized. But if you get one case of C. diff in your hospital, it's 50 grand, $50,000. So you stop one case, you just save that much money. That's enough money to buy these things for a whole year. This was the call to action that was published about 6 months ago, asking the CDC to update its guidelines. I can't predict what the CDC is going to do, but this is an option that we never had before. Their old guidelines say, clean your stethoscope once a week unless it's visibly soiled. And it's like, visibly soiled? Because I have, microscopic vision. So hopefully the CDC is going to upgrade that soon, and we'll see a change in this. But I'll apologize now, because the next time your doctor comes to you with a stethoscope, you're going to wonder, did you wash it this year, buddy? Every time. So let me summarize. That's Ignaz Semmelweis on the left there, the bald-headed guy with the QR code on his forehead. The QR code is where to get the box. But Ignaz Semmelweis was the guy who came up with the idea you should wash your hands or you'll kill your patients. That was 150 years ago. And if you ever study this guy, he was completely ostracized, told he was a kook. All the famous people hated him. He ended up dying in an insane asylum about 5 years later. So I'm not going to the insane asylum. But it's pretty clear that stethoscopes can transmit bugs. It's pretty clear that nobody cleans their stethoscope between every single patient. And even when they do, 28% of the time there are bugs on it. These barriers look like they seem to work. We've published enough. I think it probably is. So thank you much.
Very good, Frank. Any questions from the audience? Professor Mills.
Brilliant talk, Frank. Always make me think differently. So did I hear you right, that you are going to use these for the next year in your hospital? Is that the outcome of this?
So what I did is I got a portable box and I put it in my trauma area because we get blood. When like some guy comes in, you tube him, you have to know where the tube is immediately. Everybody says, well, I don't use my stethoscope more. I use ultrasound. It's like, there are things you cannot use ultrasound for. Yeah. So, and that's our bloodiest place. Our stethoscope is bloody all the time. It had 400 stickers in it, and it was gone like in 2 days. Yeah. And I had the residents chasing me down the hall and say, we need this thing because I'm tired of cleaning my stethoscope. They actually do clean their stethoscopes, as we showed. Residents are cleaner than attendings. But and so that is expanding in my hospital. But that's where we are right now. At the moment, there's one because that's all I could get from the company. But they'll change that.
It would be great to look at hospital-acquired infections before and after implementing it, if you do introduce it widely, because you present a compelling case and it makes perfect sense. But I think if I were to go back to my hospital and say we need to do this, they'll raise an eyebrow and say, really?
it needs to get enough market penetration that we can show that hospitals that use it have lower rates of iatrogenic nosocomial infections than hospitals that don't. That's the critical switch in the clinical practice.
You said it's the third hand of the clinician. Our fourth hand is the ultrasound probe.
Okay, so I'll tell you, I took this box and I put it on the ultrasound probe, and it's invisible. You can't tell it's there. So you can, like your butterfly, just that works fine. The sonocyte, on certain probe covers, it causes lines that that interfere with the interpretation of the view. So, but if you don't have a sonocyte, it seems to be okay. And I talked to the company, Scott Mader's company, about doing this with the ultrasound, and they're looking at different, because it's going to be a different latex thing to cover it. Technically, it can't be latex, but it'll be some other kind of plastic. But that's coming, apparently.
Frank, congratulations. Always very innovative. One point is now in COVID patients, we are making so attention to try to reduce the infection. Do you have any evidence in COVID? But at the end of the day, when we are putting the stethoscope, we are putting the real stethoscope on the chest. And do you think this is also a way to spread the COVID infections, or you can also reduce the virus? Because in your paper, you show that having bacteria reductions. What
Right.
about virus?
Yeah, so I tried to do a COVID trial, and it just was so difficult to get people to go into COVID rooms and have them cough on the stethoscope and go back and do it, which is the way to do that. But Alan Mizell has published the case of a cardiologist I think she was from Saudi Arabia, who was wearing the full gown, had to open her gown up to get her stethoscope to listen to this person she'd intubated, then pulled it back and closed it. It was her only exposure, and she got COVID. And so that's in the literature. It's not really a great trial. It's some guy's opinion of a case report, but that's all that's in the literature.
Okay, do we have more questions? I think this is the last presentation, right? Professor Musio couldn't make it to the meeting. Yeah, okay, so I'd like to thank everybody, all speakers, audience, my co-chair. Thank you very much. Yeah, we'll be back at 2.
CHF or some anxiety, depression, prior PE, so a fairly sick population at Vanderbilt. This is the bulk of the slide. So we had about 830 patients with PE. About 28% of them had a concomitant DVT with their diagnosis of PE. And in the pre-period, prior to institution of this pathway, we only discharged about 14 patients within a 2-year period, about 3.9% of our patients. And the post-period, we discharged 22, which is about 5%, consistent with what Dr. Westhofer had published, and for a total about 4.3%. So we're kind of where the US is with the rest of the population in the US, but we're not doing a great job of instituting this. And just showing you here, S-PESI was kind of equal across the categories. So for the pre and post, the patients were just as sick. Now, if I were smart, I would have put in here what we really want to know, which is for those who were admitted to the hospital, how many of those patients had an S-PESI of 0 or an S-PESI less than 1? And the answer to that is about half. So in the pre-period and the post-period and altogether, about half the patients had an S-PESI of less than 0. Does that mean that we did a terrible job? You know, these patients with S-PESI 0 should have gone home. We missed a lot of folks who could have been discharged? Maybe. I mean, Gestalt is king, so the physician may have looked at that patient and said, even though they're S-PESI negative, they have some other rule failures that might be associated with a bad outcome at 30 days, so they decided to admit them. But I think it means that there's still room to go, even at an ivory tower medical center like Vanderbilt, where I think we have good clinicians practicing evidence-based medicine. So some of the limitations of this study were that we identify patients by ICD-9 and 10 codes. This is a terrible way to identify patients we found. So we've developed now this natural language processing algorithm to kind of scan the radiology reports and identify patients like that. So I get a page every time a patient with a PE comes to our emergency department, which is a nice added benefit for prospective trials, which we're doing. And then this is a retrospective estimation of the S-PESI, which is never perfect. The ED engagement with the EMR S-PESI tool was essentially nothing. No one was calculating that on their own, so we retrospectively calculated it. And then this is an incomplete analysis that I showed you. So we're doing regression models and Cox regressions and some aggregated data analysis, which I haven't shown you yet. So these are some initial data we have from this. And the conclusions are that we saw similar discharge rates of acute PE when compared to other US hospitals. There were more patients discharged after initiation of the protocol, although it wasn't statistically significant, so we were doing a better job, but it's still not making a large difference. And then this is really, this project is we use to develop a database, a prospective kind of registry, where we can pull lots of covariates from the EMR, any covariate you could think of you want in a patient with acute pulmonary embolism, which we can use for both retrospective cohorts and prospective cohorts. So the registry we're creating is going to be super beneficial, and I've talked to a few people here today about maybe moving that to other sites and seeing how it does in terms of pulling data in acute pulmonary embolism in sort of a facile way to gather large data banks. Thank you.
Thank you for this excellent presentation. Now it's time for discussion. There is one.
I'd love to hear, before you ask your question, I'd love to hear how many patients you send home with pulmonary embolism. I'm just curious. I'm not supposed to ask questions immediately to the audience, but I'd be curious to hear from your country.
Okay, so in our I'm from Florence, from here, Careggio University Hospital. We do a lot of studies with Perugia, Professor Beccattini and Agnelli about pulmonary embolism. So in my hospital, we discharge 45% of patients with PE, but I think it depends for mainly two things. I don't know if you have an observation unit with the emergency department, so this discharge would be at least 24 hours, 48 hours, including emergency department time. And we have an outpatient clinic managed by emergency physicians. So our discharge rate is this one. In Tuscany is around, we are a little bit higher, but in Tuscany is 25%, more or less the discharge of PE patients. And my question is, why do you think you have so less discharge compared with at least Italy is more or less 10%, I would say. I guess it's not, I have not the numbers, but it's like this.
Yeah, I think my answer to the question would be that it's all relative. So if you're looking at the rest of the United States, we're doing about average, right? Maybe a little bit lower, but on average. I would say that probably our clinicians are a little more conservative, But certainly it's concerning because we're in an academic institution where in the community I would imagine it's even lower than what we're doing, right? So I think there's a conservative sort of nature to discharging these patients in the United States, which people always cite. And when we surveyed clinicians, in 2016 about what were their reservations about sending these patients home, many of them said, we want to know that they're going to get good follow-up. So we do have a problem with primary care in the United States, and these patients oftentimes don't get good follow-up, and so that's one of the largest sort of drawbacks to being able to send these folks home. And that's what we've seen, at least.
Thanks, it was an excellent talk. Can you tell us any more? You said that you had an automated system where you got a page if someone had embolism on a report. Can you tell us a bit more about that? And what are the approvals for that? Is that a research tool or is it a clinical tool?
Yeah, it's kind of both. So what we found when I was initially doing this analysis were we were pulling patients by ICD-9-10 codes, which turned out to have like a positive predictive value of like 80%, 70%. It's like really terrible, quite terrible. So I was speaking with some of our data guys, and we developed this natural language processing to scan the radiology reports for specific words. And what happens is when it pings, it sends a page to me, and just a pager, an old school pager, that alerts me there's a PE in the emergency department. It was relatively easy to do. I'm happy to share that with you. But we're kind of moving this to hopefully publish in the next couple months here about this algorithm and how it was done. We'll make it open source. A couple other ones have been published in Canada and in the US in Salt Lake City using a similar natural language processing, but it hadn't been done in a prospective way like this. So we're actually using the prospective component of it to enroll patients for the HI-PEITHO trial, which is site-directed thrombolysis versus heparin for intermediate high-risk PE. So we're using it in that capacity, and now we're applying it retrospectively to really gain a great cohort of patients. It's like 98% positive predictive value for this population. So in order to withdraw these covariates, you first have to know you have the right population, right? So that's kind of the first step, and we realized we weren't getting that, but now we are. So.
Thank you. Thank you very much. It was really interesting. Now, we move on next speech from Angie Reid from Italy, still in the field of pulmonary embolism, a new score of TC scan of thorax to detect myocardial injury in pulmonary embolism in the emergency department. Please, Angie.
Hi to everybody. My name is Angie Riad, and I'm an emergency.
Switch on.
Era spento. Okay. So, hi to everybody. My name is Angie Riad, and I am an emergency physician in Rome. And I am here to discuss with you about a new score of CTPA for detecting myocardial injury in pulmonary embolism in the emergency department. So we already know from the current guidelines that the level of cardiac non-high sensibility troponin have a low specificity for early mortality in patients with acute pulmonary embolism. But this value can be improved in combination with clinical and imaging findings. Our problem was the imaging findings because all the current radiologic CTPA score are really difficult to be used in an emergency department. Let me explain better why. Look, for example, at the Canedley score. In the Canedley score, all the pulmonary arteries are subdivided into 10 segmental arteries in each length. Then the presence of an embolus in a segmental artery is scored as 1, and all the other emboli are scored a value equal to the number of the segmental branches arising from the affected vessel. And at the end, you have to multiply it by 0 or 1 or 2 according to the estimated degree of vascular occlusion. The same thing, we can say the same thing even for Ganima score, where the pulmonary artery tree is divided in 4 components. If we find an embolus at in the mediastinal arteries, it's scored 4 points, lobar arteries 3, segmental arteries 2, and subsegmental arteries 1 point. But then you have to make the mean score of the largest affected vessel in each lung and adjust it to the higher wall number. So if we look at these simple images, that it's clear that we have a total occlusion of all the right inferior lobal vessel and all the branches arising from it, it's really difficult to try to calculate the Canedley score or Ganima score. So our aim was to find a score usable in an emergency department and try to understand if it's correlate with myocardial injury. Our study design is composed from two parts. We have a retrospective observational one with patients collected between 2016 and 2019 in two different hospitals, Sant'Andrea and San Giovanni, with a total number of 355 patients. In the prospective observational one, our patients are collected between March 2018 and March 2019 only in San Giovanni Hospital. We used exactly the same kind of troponin I by Abbott, and our inclusion criteria is the diagnosis of acute pulmonary embolism in the emergency department. The exclusion criteria is an age lower than 18 years old and the presence of an acute coronary syndrome. Then we hypothesized a score where we have to consider only two things. So the bilateral or monolateral involvement and the artery involved. So we can make like 1 point for the bilateral involvement, 2 points for the monolateral involvement, 1 point if the artery involved is a principal one, 2 if it's segmentary, and 3 if only subsegmentary. And then we defined 4 different severity index. So we have a mild lung involvement with 5 points, moderate lung involvement with 4 points, severe lung involvement with 3 points, and very severe lung involvement with 2 points. As you can see, the severity of pulmonary embolism was inversely related to the score point. However, I can try to calculate with you our score TAC. So here we can find the first images, and it's easy to see that we have a lack of signal here and here. So it's bilateral. And from the second and the third images, we can see even that the vessels involved are the principal right and left artery pulmonary. So if we are going to try to calculate our score, we have 1 point for bilateral involvement, 1 point for principal artery, and the result is a very severe lung involvement. Then we compared our TAC score with the troponin. And if you can see, if the score TAC is really severe, the troponin is higher too, especially if the TAC score is between 2 and 3. 62.8% of the troponin is high too, so it's significant because we have a real myocardial injury. The same thing, we can observe the same thing even in the prospective study, where 65% of troponin is higher too. So, at the end, in the literature, we know that there are no conclusive data on the priority of one prognostic score over another, of one biomarker over another, and there are insufficient studies dedicated to high sensibility troponin and pulmonary embolism. Studies in the literature that analyze radiologic score are not suitable for the emergency room context. And it seems that an independent evaluation of CTPA scan from an emergency physician in the emergency room could be used as a risk stratification of severity of pulmonary embolism. And especially the score we propose is easily calculated by the emergency physician and correlate with the presence of myocardial injury according to high-sensitive troponin I. But we still need multicentric studies in larger cohorts of patients to understand better if it's okay. Thank you for your attention.
Thank you. Thank you, Angie. Very interesting presentation. The tower is open for discussion. Any questions? Belli-Pekka.
Thank you. Very important paper because we are struggling with these CT scan findings and what to do with the minor distal emboli, subsegmental, and so on. But my question concerns, what about the finding of heart? So the right ventricular dilation in the same CT scan. So what about the right ventricular dilation? Did you look at that? Would that be more important than the amount of embolic burden?
So you are asking about the myocardial injury? No.
Dimension. The right ventricle dimension, if we calculate right ventricle dimension.
At the beginning of our study, we tried to calculate it, but we concentrate more on our CT score, because we need something that can be easy and very fast to be set in an emergency department. Sometimes it's more important to understand the severity in a fast time than, for example, stay there with an echography and try to understand the volume of the heart, or so for this.
Just also to address a little bit what Veli-Pekka is asking, we tried to have the right ventricular imaging for this scan, but you know, this is not really perfect. Sometimes to detect, it's more dedicated to see the lung involvement, right? So if you do the right ventricle, you can have probably not the right imaging. So we think that at the end of the day, just to make quick diagnosis, to do high sensitive troponin and the number of vessels immediately in the emergency room is what we can have the best achievement in the imaging and the laboratory testing. Yeah. But anyway, the involvement of right ventricle should be an interesting point to see if there is any relationship. I agree.
Very nice talk. I enjoyed it. Can you hear me? It's interesting because I would agree with him in that, you know, right ventricular dysfunction has been associated with mortality at 30 days, but thrombus burden has never been associated as an independent predictor of mortality. So I think specifically about Greg Piazza's study in Seattle too, where he lysed people and looked at right heart recovery and didn't see a large decrease in central thrombus burden, but was seeing more of the peripheral kind of thrombus being dissolved. And so I'm curious, you know, when you say lung involvement, you mean, I'm worried, are you talking specifically about thrombus burden, or you're talking about just different portions of the lung that's involved? I don't think I quite understood that.
I'm talking about the vessel involved, so how much of this artery are involved from an embolus.
Mm-hmm. Okay.
So.
And do you think there's a way to maybe get at more of the peripheral kind of vessels, or to assess that in a meaningful way rather than just central kind of thrombus burden or main vessel disease?
That is possible, I think.
Yeah.
That's probably what we should do in the future.
Exactly. Okay.
Any other question?
Okay. If there are no more questions, thank you very much for your presentation. Let's go to the next presentation. It is going to be by Johanna Harjola from Finland, and he will present pre-hospital thrombolysis in pulmonary embolism.
Yeah. Yeah, okay. And is this on? Yeah. Dear colleagues, dear chairman, my name is Johanna Harjola, and the topic of my study is pre-hospital thrombolysis in high-risk pulmonary embolism and the clinical picture and outcome. High-risk pulmonary embolism is the most dangerous complication of venous thromboembolism with high risk of early mortality. PE should be suspected in patients with dyspnea, chest pain, pre-syncope, syncope, or hemoptysis. High-risk PE is manifested by hypotension, obstructive shock, or cardiac arrest. It requires emergency diagnostic workup upon suspicion and immediate treatment without any unnecessary delay. The primary treatment of choice is reperfusion with systemic thrombolysis. Aim of the study was to assess the prevalency, safety, and outcome of the pre-hospital thrombolysis of suspected PE. It is a retrospective analysis from Helsinki EMS registry and hospital database between years 2007 and through 2019. The inclusion criteria were high-risk PE suspected by EMS, treatment without hospital intravenous thromboembolism, and diagnosis confirmed by in-hospital imaging or in autopsy. The EMS also used ECG and point-of-care ultrasound as the part of the assessment. Then to the results. 22 patients were included in our study. 17 patients had cardiac arrest, and 5 patients had cardiogenic shock as the clinical manifestation. 53% of patients presenting with cardiac arrest upon EMS arrival, and every patient with cardiogenic shock survived to the hospital. The mean time to return of the spontaneous circulation was 35 minutes. 2 patients had major bleeding complications, but none of them were fatal. The in-hospital death rate was 28%. All of the patients discharged alive from the hospital were alive at 1-year follow-up. This table shows you more in detail. As you can see, the mean age was 57 years old. 18% of the patients had clinical history of immobilization and previous VTE, and 9% had clinical history of pneumonia. Furthermore, you can see in these columns, the first one is all the patients, the second one is survived, and the last one is dead. So the most common symptom of clinical symptom on the field was dyspnea, whereas chest pain, syncope, and cardiogenic shock occurred in 1 out of 5 patients. Regarding to onset cardiac arrest, it was observed initially in 5 patients, and 2 out of them survived. After arrival of EMS, 12 patients had cardiac arrest. This picture shows you the outcome of out-hospital and in-hospital, as well as the 3-month survival of patients who were discharged alive from the hospital. So the total number of the patients was 22, where 17 had cardiac arrest. 8 of them died at the scene, and 9 of them were transferred alive to the hospital. In the hospital, 4 of them died, whereas 5 were alive 3 months later on. In cardiogenic shock, none of them died at the scene, and all of the patients were transferred alive to the hospital and were alive in the 3-month follow-up. In conclusion, out-hospital high-risk PE is associated with high mortality, and this small patient series shows that pre-hospital thrombolysis may improve survival, and the benefit seems to overcome the risk of fatal bleeding. However, these findings need to be confirmed in a proper randomized controlled trial. Thank you.
Thank you for this very nice presentation. Now it's time for discussion. Any question from the...
I have one question.
I have one. I guess it could be quite difficult to do the diagnosis of pulmonary embolism out of the hospital in cardiac arrest patients.
Yeah.
How did all the patients were with pulmonary embolism, or perhaps you had some patients that you gave thrombolysis were finally not pulmonary embolism?
No, all of the 22 patients that we had, they were confirmed the diagnosis by, if they died, by autopsy. So all of the patients, that's why our study is so small, because we wanted that all of the patients have the diagnosis of pulmonary embolism.
And how was the diagnosis in this patient that pulmonary embolism out of the hospital?
Out of hospital.
Yes.
You couldn't do out of hospital, but it was confirmed afterwards by the autopsy if they died, or in the hospital by the imaging. But at the scene, there was this kind of findings that we had to make the decision to give the thrombolysis or not. But the findings were made by the vitals and the ultrasound and these kind of things.
Very interesting presentation. I have a question about survivability here. These numbers you're reporting seem to be more than what's reported in the literature for patients who get thrombolysis who are cardiac shock or who are arrested. So it's very interesting. Do you have a control group for patients who did not have PE who came in like this?
No, we don't.
Because in prior studies, when they really look at all of this, it seems like it didn't seem to matter whether or not they got lysis in terms of survivability. So it would be interesting.
Yeah.
Right? Thank you.
Thank you.
Another point would be the evaluation of BNP that is considered as stress or right ventricular level. Do you have any data comparing the two groups? How was the BNP as mirroring the right ventricular involvement? Because that was also an hypothesis to see if there is a difference in right ventricular dysfunction.
Yeah, we didn't.
Or NT-proBNP.
Yeah. That's a good point. We could go backwards and look from the patient's laboratory results and that kind of, but we didn't in this. But maybe in the future we can.
If no other question, thank you very much, Joanna. Next talk is from Marianna Nigro, again from Italy. She's talking about, is there a value of immediately detecting hemolysis in the emergency department for point-of-care blood gas analysis and high-sensitive troponin assessment? Please, Marianna.
Good evening, everybody, and thank to Professor Salvatore Di Somma for the kind introduction. I'm Dr. Marianna Nigro, and I'm part of the school, postgraduate school of emergency medicine in Rome, and I will be answering with my presentation to the question, is there a value of immediately detecting hemolysis in the emergency department for POCT blood gas analysis and high-sensitive troponin assessment? So, laboratory errors are the main reason of delay laboratory response and so difficulty in managing of patients in the emergency department. We know, in fact, that hemolysis is the most common preanalytical error from a laboratory analysis, and also that the vast majority of hemolytic specimens come from the emergency department. So ENCHEC has developed this tool. There is a point-of-care system to detect immediately hemolysis in the emergency department. We designed a study that has three aims. The first one is to analyze the prevalence of hemolysis in blood gas, arterial blood gas samples and venous withdrawal in emergency department. The second aim was to do a method comparison between ENCHEC and our laboratory, and then to evaluate the influence that hemolysis has in the blood gas sampling, arterial or venous. This is our method of collecting samples. We had a target of 700 samples obtained in ED. We performed the arterial or venous withdrawal and then analyzed with the sample with ENCHEC and then send it to the laboratory or analyzed it with the POCT for blood gas analyzation, and then collect the data and also the action that the clinicians had taken after the response of an hemolytic specimen. So we collected all the samples in three different emergency departments that are Sant'Eugenio, Sandro Pertini, and San Giovanni Addolorata in Rome in a period between 17th of March 2021 and 13th of April 2022. We collected 726 patients, 524 were arterial blood gas samples, and 202 were venous. We had to exclude, for statistical reasons, 140 samples, but we were able to analyze 384 samples from the arterial part, and we found that the 13% of them were hemolyzed. As well, for the venous part, we found that there is 14% of samples that were hemolyzed. these are our results for the arterial part. There is a large operator variance, of course, but we can see that potassium, calcium, and PO2 are impacted by hemolysis. In particular, we can see the distribution of potassium in the hemolyzed samples. This column that is in this graphic shows that the majority of the sampling, in the majority of the withdrawal, the potassium was in the range, but we know that potassium in hemolyzed samples is higher. So there is the strong possibility that in this in these patients, we could have found an hypopotassemia. So it can be crucial to identify hemolysis to avoid an incorrect therapeutical choice. These are our venous results. We can see that we have a lot of different triad symptoms, but for the hemolysis, neither triad symptoms or gender impacted significantly the presence of hemolysis. We have done also a comparison between the two methods, and we found that there is a moderate concordance between MCHEC as central lab in detection of hemolysis, and also that MCHEC has a 76% of sensitivity and a 93% of specificity. We found that LDH, potassium, and sodium are significantly impacted by hemolysis, not as much as troponin, but as we can see from this graphic, 14 patients had a significant value of troponin, but a lot of them stays in a gray area. We believe that we need more study to understand the real impact of troponin in this case, to do a correct rule-in and rule-out in case of a suspect of a myocardial infarction, because our database had a small sample. We know also that if hemolysis is found immediately in emergency department, it's potentially time-saving. In fact, hemolysis delayed the response from laboratory between 40 or 50 minutes. So, in conclusion, MCHEC seems to be a useful tool for rapid detection of arterial and venous hemolyzed samples in ED. Using MCHEC, we can reduce the time of waiting for lab results. Obviously, the most impacted lab results was potassium, and with the use of POCT in blood gas analysis in ED, it is possible not to underestimate the presence of hypopotassemia in hemolyzed samples, and so to avoid incorrect therapeutical choices. Also, MCHEC seems to be able to detect immediately the presence of hemolysis for high-sensitive troponin evaluation, reducing the time and the necessity of further additional sampling in ED, accelerating rule-out and rule-in process in suspected acute coronary syndrome patients. Obviously, our study has some limitations, such as strong operator variance. Also, we missed to unnote the VO2 in the final questionnaire. There is absence of a control sample for the BGA after the hemolysis response. But most important, the venous samples are few for now, so we need more data, and further studies are needed. Thank you.
Thank you, Marianna. Now the presentation is open for discussion. Okay, if no one, I have a question for you. So I think that should be important for you when you use a point of care system in the emergency room, any kind of point of care, to detect the possibility that pre-analytical error is there. So you can speculate that this is something that, because if you send the samples in central lab, that's okay, you have no problem.
Yeah.
Could you please speculate on this?
Yeah, because, for example, in emergency department, we don't use a point of care that detect hemolysis for arterial samples. So it is important to have a tool that says that that sample is not available and could lead to an incorrect therapeutical choice. Because obviously, as Professor Di Somma was saying, in laboratory, when you send a sample in laboratory, you have not an immediate response, unfortunately, but you have the response that the sample was not available, was not good for analyzing.
Thank you again.
Let's go for the next presentation. It's going to be by Dario Marin from Italy. Dario Marin from Italy. Because in Spanish it's Dario.
Sorry.
And the title is Point of Care Bioadrenomedulin and Proencephalin Utility in Risk Stratification of Patients with Sepsis in the Emergency Department.
Yes. Good afternoon, everybody. I'm Dario Marin, and today I want to discuss our study regarding point-of-care tests bioadrenomedulin and proencephalin utility in risk stratification of patients with sepsis in the emergency department. The main aim of our study was to evaluate the prognostic value of bioadrenomedulin, from now on BioDM, and proencephalin A, PENKID, in patients with sepsis in the emergency department. BioADM is a novel biomarker involved in the vascular integrity with an already established in literature role in acute heart failure and septic shock in sepsis. It also has therapeutic implication as it has already been developed aducanumab, a human antibody targeted against BioADM. PENKID is also a novel biomarker involved in the kidney damage and acute kidney injury. Both of those biomarkers have been mainly studied in the setting of ICU and not in the emergency department. We enrolled 177 patients, consecutive patients, referring to emergency department of San Giovanni Hospital in Rome. We excluded only the patients that didn't give us consent and those who were less than 18 years old of age. For each patient referring at emergency department, we obtained clinical history, physical examination, and routine laboratory tests. We calculated QSOFA and SOFA scores. We obtained BioDM and PENKID whole blood concentration using point-of-care test machines. We obtained imaging results, either X-ray or CT scan, depending on the case. For each one of them, evaluated the diuresis and their eventual need for inotropes. And then we conducted a 30 days phone call follow-up in order to evaluate later events. We ran the whole blood samples through Sphingotec Nexus EB10 point-of-care test immunoanalyzer. The whole process takes no more than 20 minutes, and it's very easy to replicate. By far quicker than the normal laboratory tests, which takes up to an hour and a half. In those tables, we can see the characteristics of our patients. The most common symptoms of the patient we faced were fever, dyspnea, or both, followed by abdominal pain, confusion, or other less common symptoms. We found out, maybe unsurprisingly, that an older age increases significantly the risk of death within 30 days. We also got confirmation of the importance of oligonuria, the level of consciousness, and the mean arterial pressure in the initial assessment of the patients. We also found out that widely used parameters like body temperature, heart rate, or arterial saturation of oxygens were less significant than we expected. Both PENKID and BODM are good predictors of death within 30 days. We also got confirmation of the invaluable importance of high-sensitivity troponin I and BNP in the emergency department. We also found out that there is a good correlation between PENKID and creatinine and the diuresis of the patients, which increase its usefulness in evaluating kidney damage in septic patients. We also found a good correlation between lactates obtained from arterial blood gas analysis and BODM. Since arterial blood gas analysis is also very quick and very easy to obtain in emergency department, it could prove to be useful. SOFA, while still being an important clinical tool in the emergency department, it's a little slower to obtain since it needs normal laboratory results. Those are the Kaplan-Meier survival plots of our biomarkers. PENKID and BODM are both good qualitative and quantitative predictors of death within 30 days. Not dissimilar from creatinine, a very well-established biomarker of kidney damage. Also, high-sensitivity troponin I was confirmed to be very important in the evaluation of septic patients in emergency department. In conclusions, BODM, PENKID, and high-sensitivity troponin A are useful biomarkers for predictions of 30 days mortality in patients with sepsis in the emergency department. The three biomarkers mirror three ongoing different physiopathological damages in patients with sepsis, respectively BODM for vascular damage, PENKID for kidney damage, and high-sensitivity troponin I for myocardial injury. This suggests potential personalized therapeutic decision-making for this subject. Point-of-care testing, BODM, and PENKID seem to be useful for fast decision-making at patients' bedside in the emergency department, of course to be integrated with SOFA score. Thank you for the attention. I'm available for any questions. Thank you.
Thank you, Dario. Now it's time for questions. Richard Norwood.
No, thank you very much. The biomarkers are interesting, but to me, they seem to have more broader implication. And I bring that up because you said you entered patients with suspected sepsis. You didn't say they were confirmed. And then if you look at your presenting complaints, pretty wide in terms of what the diseases may have been. I don't know. So is it possible that if you don't know that they were all confirmed sepsis, that these biomarkers in combination may be good generally in patients that appear sick?
It is a very good question, a very good point.
A very good question.
For example, we found out that just like we do arterial blood gas analysis on a wide array of patients, on a wide, let's say, set of patients, we could also try to run point-of-care testing for a wider set of patients. For example, many times our clinical suspicion of sepsis was challenged by the results of the point-of-care testing results, and more than sometimes, let's say, the point-of-care testing had a better judgment, let's say, of the clinical impression of the physician. It could be useful, yes.
If I can add something on the Richard question, I think the same system does also procalcitonin. I know that procalcitonin is not worldwide accepted as a good biomarker of sepsis per se, but again, when we in the clinical practice we look at patients we look like this, we have clinical judgment that is always important. So these are more prognostic biomarkers, and diagnostic biomarker procalcitonin is the best we have, but it's not really accepted. So I agree with you that we can use for wide body of patients. Then when sepsis is confirmed, then we can use also for make risk stratification. This is a good idea, I mean.
one of the main issues is the fluid administration in septic patients, and now with restriction or not. Do you think that with biomarkers we can select patients, candidates for restriction or for more wide administration?
Yes. In the later stage of the study, when we had a little more confidence with Pankid, for example, we found out that Pankid predicted with a good, let's say, with a good confidence that a patient will need a more aggressive fluid therapy than another one. Let's say, while, for example, we usually use creatinine in the emergency department to evaluate the function of the kidneys. With Pankid, we could have a good estimate of the kidneys function in a really quicker time. Time is key. So we could start with a more aggressive fluid therapy with an hour of advantage against the normal blood testing in laboratory. Yes.
Good, thank you.
Thank you.
Last presentation of this session in the emergency department is from Ceylan Taggart from Scotland. He's going to talk about consensus on type 2 myocardial infarction. Please.
Hi, my name is Keelan Taggart. I'm a cardiology research fellow in Edinburgh. I'm just going to give a quick talk today on developing a consensus for the assessment and management of patients with type 2 MI. That's just my funding from the British Heart Foundation. So, as we know, type 1 myocardial infarction has now got favourable outcomes with about 2/3 of patients alive at 5 years. There's good evidence-based guidelines and therapies from the AHA, ESC, etc., and many, many RCTs to inform and guide our care. Type 2 MI, on the other hand, has got extremely poor outcomes with only about 1/3 of patients alive at 5 years, and there's no guidelines on assessment and management or any RCTs to inform or guide our care. But more importantly, there's never been an effort made to gain consensus on how we should assess and manage these patients. Which brings us to our aim. So we decided to try and get a panel of experts together and develop consensus on assessment and management of these patients. So we decided to do this by doing a Delphi study. So you're probably asking, what's a Delphi study? It comes from the concept that the opinion of many is better than the opinion of one. And it basically is the circulation of a questionnaire to a panel of experts, deductive analysis, and recirculation until we can get agreement on a point, in this case, management recommendations. So just to kind of go through the study in more detail, how we did it. So we picked a panel by doing a systematic review of the literature, identifying clinicians with expertise in the area. We then circulated an open round and question and key themes in the condition, trying to get them to talk a bit about what we would do and what recommendations we could make. And then going on, then we made these recommendations into statements, and we assessed agreement on a Likert scale, 1 to 5. When 80% agreement was achieved, we put these forward for a recommendation, and when 80% disagreed, we put it in the bin. So, and when there wasn't any disagreement, we put this for one further round, and that way we can assess whether or not what we want to take forward. So we've done a systematic review of the literature in type 2 myocardial infarction and revealed 424 key articles in the last kind of 15 years, ever since it was first introduced. Once we removed what articles weren't pertaining to key original research in it, we ended up with around 150, and once we excluded repeats, editorials, etc., we ended up with kind of 114 key papers in this area. From these key papers, we identified 78 potential collaborators from 43 teams throughout the world, and we removed 10 who weren't clinicians, and we, from our steering panel, identified 5 more, leaving us with 73 potential collaborators to be contacted for our study. So we kind of had to have a think about what themes do we want to try and get to the bottom of in this condition. Very little is known about it, so I think it's very important that any patient with type 2 MI, the first kind of questions you're asking is, what's their coronary artery status? How do we assess for coronary disease and cardiac function? We want to know, should we be revascularizing these patients? What secondary prevention measures do we want to implement? What sort of risk stratification measures can we take? And a very important one, I think, is what do patients understand and what can we communicate to them about this condition? So from our first, we got 38 responders out of 67, I think. Actually, the emails worked. Generated about 80 pages of pure text just on discussion about it. And from this, we had 697 statements, which we narrowed down to 67 unique statements on management recommendations about this condition. So we've done an interim analysis of round 2. We still have to do round 3. It's still in progress at the moment. But from these 67 unique statements, we have reached agreement on 25 thus far. 40, there's still not agreement has been achieved, and 2, there was disagreement not to be carried forward. So just to kind of show you where we're agreeing here, where the panel, the expert panel is agreeing and where they're not agreeing, the green, as you can see, indicates agreement, orange doesn't. So there's no agreement on cardiac, how we assess for cardiac function. However, there's some good agreement on what secondary prevention measures we want to implement, such as aspirins and statins, and also on how we should risk stratify these patients as well. So I'm trying to make things maybe a wee bit interactive. So I know there's a broad range of specialties here today, but I would just encourage everyone to have a go. Can I have a raise of hands if you think that the current definition of type 2 should be reviewed? Yeah, so the expert panel mainly agreed, but again, there's about 30% of those who didn't, thought it's great, it doesn't need to be changed. Another one is all patients with type 2 MI should have an echo. Does show of hands, who thinks that should happen? No? Interesting. Well, the panel thought mainly so, but again, I think they wanted more on a patient-to-patient basis. These are some other ones that we've got so far. So we wanted to find out what clinicians think if patients have a good understanding of this condition or not, and 100% disagreed. But you think that we would know what we're talking about here, and clinicians, we asked them, do we understand what we're talking about? And again, 100% disagreed that we don't know anything about type 2 myocardial infarction. So yeah, that's to conclude, really, I think the management at the moment really comes down to risk stratification, assessment for cardiac function and coronary status, and then the initiation of cardioprotective therapies. We think that the expert consensus on this may inform guidelines and aid in the trial designs, because there's no RCTs in this area, so it's all good information going forward. And I think also we need to do more work and qualitative work in the consensus from patients on what they understand about this condition, because we think that understanding is pretty poor at the moment. I'd just like to thank Dr. Amy Ferry, who helped me design this study, and our steering panel of Andrew, Professor Mills, Professor Tigas, and Lindell and Eggers from Sweden as well. Thank you.
Thank you. Thank you so much. Also, this last presentation is now open to the floor. Questions? Richard? Dr. Novak here.
Thank you. It's a very difficult topic, and we're trying to get some idea what this all means, and I understand that. The expert panel is a consensus of limited data, and it's almost an opinion thing. So I'm just curious that when you finally put this together, are you also going to report the dissenting minority opinion and why? Because if you don't, you're just giving the overall overview, which may or may not be right, and there may be some very good points in the dissenting opinions. I'm just wondering how you're going to handle all that. Because you have bright people who have differences of opinion, and I don't know if you're going to present both sides of what the discussion was or just one side.
Yeah, so that's a really good question, and I think that's why we chose to use a Likert scale in the second round to kind of grade agreement, and we'll report each of the statements in the agreement on each using kind of a covariate kind of analysis, and that'll kind of show us, where there's been really strong agreement or really poor agreement. And you'll see ones where there's not been great agreement that, yeah, there is a difference of opinion. We also gave all the collaborators a chance that even they're just selecting agree or disagree to make comments, which we carry on to the third round, and we're trying to adapt and change at each round to make it better as well.
Okay, just one last question. If not, thank you very much again. And now we conclude this session just in 1 hour timing, so we were not taking more delay, and ask the Nick Mills and Liz Wamley to come to the podium to chair this next session.
Okay. Thanks, everyone. Welcome to this next session. I'm joined by Lim Swee Han from Singapore, and we have one absentee due to COVID, which is not bad. So there'll be 4 presentations. We'll try and finish in good time for coffee. We're covering a range of concepts, including chronic coronary syndromes, cardiac troponin, and acute myocardial infarction. So we'll have to wait for Ryan's entertaining presentation next year. And I'll hand over to my colleague to start the session.
Hi, thank you, Nick. My name is Swee Han. I'm from Singapore. Thanks for the invitation. And the first presentation will be machine learning and myocardial infarction from Dimitris Diodidis from Scotland. Please.
Well, hello everyone. It is my first time presenting in the great conference, so it is a pleasure. So I'm a postdoctoral researcher at the University of Edinburgh, having recently completed my PhD under the excellent supervision of Professor Mills. And today I'm going to talk about machine learning and myocardial infarction. So the background, it's very common to us. As we know, guidelines recommend fixed troponin threshold for the assessment of patients with acute coronary syndrome. However, these approaches rely on thresholds that do not acknowledge that troponin is a continuous measure and varies within individual. As a result, performance varies in important patient subgroups such as age, sex, and those with comorbidities. However, this limitation can be addressed with the use of machine learning algorithms. So we created CoDCS, which stands for Collaboration for the Diagnosis and Evaluation of Acute Coronary Syndrome. As a derivation dataset, we use the high-stakes registry in Scotland and 10,000 patients with a median age of 70 years and 52% being males. And for the model development, we combine the baseline characteristics of each patient, such as age, sex, previous medical history, along with variables that can be collected from the clinical examination of the patient, such as heart rate, systolic pressure, and ischemia and ECG, of course, one of the most important variables. And we combine those with the laboratory tests like eGFR and hemoglobin, and the most important one, of course, of all, troponin. And in this case, troponin I. And with all these variables, we created CoDCS. So CoDCS compute an output, which is a score from 0 to 100, which expresses the likelihood of a patient having type 1 myocardial infarction. Then we moved on to externally validate an algorithm in 6 countries from all over the world in more than 10,000 patients with a median age of 60 years and 65% to be men. So when we externally validate CoDCS, managed to achieve an excellent discrimination with an area under the care of 0.95, while it calibrated well to the whole range of CoDCS score. So what we did was like to evaluate CoDCS as a clinical pathway. So moving on, when we developed the model, we identified 2 thresholds, one for rule out and one for rule in, that it can be used if you want to use CoDCS as a triage pathway. So for the rule out threshold, we set the bar as high of negative predictive value of 99.5%, while for the rule in threshold, we set the bar as high as PPV greater than 75%. So when we applied those thresholds in those 10,000 patients, CoDCS managed to rule out 56% of patients with a sensitivity of 98% and a negative predictive value of 99.5%, while it ruled in 11% of patients with the specificity of 97% and a positive predictive value of 76%. This leaves 1/3 in the middle, and this is the observed zone. And this is where we made a change in terms of like providing information for those patients in the observed zone. However, by incorporating a serial measurement to a very flexible time point later on, CoDCS managed to further rule out 38% of those patients in the observed zone with a sensitivity again of 98.6 and an excellent negative predictive value of 99.5%, while it further ruled in 90% of these patients that were in the middle with a specificity of 96% and a PPV of 65%. So overall, from these 10,000, more than 10,000 patients, CoDCS ruled out safely 69% of patients and ruled in 13% of patients. And it it reduced almost by 50% the observed zone at presentation from 33% to 18%. Now, an important aspect as we discuss is the subgroup performance, how consistent this will be in important patient subgroups. So I will present the results at presentation with only one serial measurement. So the negative predictive value at presentation was quite consistent across all groups. And the last group is the early presenters, so CoDCS can be applied to early presenters as well. And the same applies for PPV. And as a last thing, I would like to show you the prototype app that we have developed, which can be used as a decision support tool from clinicians at the patient bedside. So now I'm going to click play, and hopefully will play. It plays. A 60-year-old female with 8-hour symptoms, no chest pain, slightly elevated heart rate, systolic blood pressure, and eGFR values of 75, hemoglobin of 12, and a presentation troponin of 10, a quite difficult case. However, when you press submit, you get the intermediate probability of that particular patient, but in addition, the diagnostic metrics of that. So we don't just leave a patient in the observed zone, we provide further information for that patient, and hopefully we hope to guide the care and the treatment of that patient. So in conclusion, so CoDCS can rule out and rule in patient with a single troponin measurement at presentation. It can provide individual probabilities for those in the observed zone, while with the incorporation of the serial measurement in a very flexible time point, it can further rule out and rule in patients that are in the observed zone. It has a homogeneous subgroup performance, and last, and one of the most important advantages of CoDCS is that each hospital can adjust the rule out and rule in criteria to meet their needs. So what we set as threshold in this case was just for demonstration. NPV and PPV can be adjusted, and the observed zones can be as big or small each hospital setting would like to be. Last, I would like to thank the High Stakes team and, of course, the CoDCS research team, in particular Professor Mills, Professor Mueller, my colleague Jasper, and, of course, our founders for their kindly support to that. Thank you very much.
Thank you for the excellent presentation. Now we open the questions to the floor. Any? Yes, please.
Yeah, very work. Not yet. Yes, very interesting presentation, and you have a beautiful Scottish accent. So one question on the observed zone and doing the second measurement, is that time dependent?
No. So it is about the serial measurement or at presentation?
The second measurement for the
So the second
zone.
measurement can be as early as 1 hour after admission, or 2 hours or 3 hours. We know how busy an ED department can be, and different hospital has different resources. So this is one of the greatest advantages of CoDCS. It requires a serial measurement. It not only can work with one measurement, but also when it requires a serial measurement, this can be at any time point, because we calculate the rate of the change of in troponin.
Beautiful, thanks.
Any further questions? If not, may I ask, are you going to do a similar one for the prediction of MACE using the prediction? Are you going to do a study on prediction of MACE? Major advanced cardiac event.
Not a clinician.
Yes, so the outcomes, are we going to evaluate whether this tool also provides insights, not just to the diagnosis, but the event rate at 1 year of recurrent myocardial infarction or death?
Yeah, we have a lot of secondary outcome and safety outcome, like survival of the patient, and if they come back again to the hospital, yeah, we're going to evaluate all these common practice safety endpoints.
So if I understand this correctly, this is mostly from a predominantly white Anglo-Saxon population. And do you have plans to put some African Americans in here and some Asians, the rest of the world?
So, the development of codices was primarily from population in Scotland, but our external validation was from Europe and Australia and New Zealand. We don't know about other.
It's not known for having a lot of African Americans in our heart studies.
I don't know that.
Or Asians.
Sorry, I don't understand exactly the question.
You've got to go around the world, because this is going to work really for white people, but the world's not mostly white people.
Yeah, that's correct, and we need to find more collaboration and do this international stage. Texas.
If no further questions, let's thank Dimitris again for the presentation. I'd like to call upon the second presenter of this session, Clara Rumara from Switzerland. Topic is do heart events lead to better lipid control versus procedures? Please.
Thank you, Professor Lehmann, for an introduction, and dear colleagues. Yes. I'm a member of Christian's team from Basel, and I'm happy to present the results of the study, do heart events lead to better lipid control versus procedures? So as we all know, the management of dyslipidemia is one of the cornerstones of cardiovascular risk reduction. And low-density lipoprotein cholesterol, or LDL-C, is a well-established causal risk factor for coronary artery disease and stroke, and it's also the primary therapy target. The guidelines, the European guidelines, they define very strict same goals for all patients in secondary prevention. However, as a consequence of more intensive secondary prevention programs that follow acute heart events such as acute myocardial infarction and stroke, the lipid control in patients that only have a coronary vascularization procedure in the past medical history could be suboptimal. However, this difference between those two groups of patients have not been well investigated. I'll now turn to the future aspects of dyslipidemia management, and that is the lipoprotein A. It's also a risk factor for development of atherosclerosis, and it's a potential therapeutic target for further reduction of residual cardiovascular risk. But compared to LDL, the target values have not been well determined, and also there's no evidence that selective lipoprotein A lowering therapy brings any benefit. Structurally, it is very similar to LDL, so it possesses an atherogenic effect. But apart from that, it's believed to have some pro-inflammatory and pro-thrombotic properties, which could potentially provoke plaque rupture and thus occurrence of a heart event. So this leads me to the aims of the study is first to compare the LDL levels of patients with history of heart event versus history of procedures, and to test the hypothesis that lipoprotein A is elevated in patients with a history of heart event compared to patients with only history of procedures, and that is in view of the prothrombotic and pro-inflammatory characteristics. And lastly, to investigate the impact of these two atherogenic lipoproteins on the major adverse cardiovascular events. So this was a prospective single-center observational study that was performed at the University Hospital Basel, and it was designed to evaluate diagnostic and prognostic value of a lot of biomarkers for functional coronary artery disease. And we enrolled patients consecutively that were referred for myocardial perfusion scintigraphy, and they were divided into 3 groups, so heart events, only coronary revascularization procedures, and non-CED and stroke, but with cardiovascular risk factors. We performed follow-up after 1, 2, and 5 years, and the primary composite outcome consisted of acute myocardial infarction, cardiovascular death, and stroke. We enrolled in total 4,090 patients with baseline lipid measurements between 2010 and 2016. And a short overview of their baseline characteristics, we can observe that the population was predominantly male and also old, relatively old, with a median age of 68. And what is important is that the statin usage in the patients with heart event and patients with only coronary revascularization procedures were comparable, around 82%. So at baseline, we found that LDL levels in patients with a history of heart event was significantly lower compared to patients with history of only coronary revascularization. And furthermore, the adherence to the current guidelines to the at the time point of enrollment was significantly higher in the patient group with history of heart event. And at the time, the recommended value was 1.8 millimole per liter, which is represented with this horizontal dashed line. So as for lipoprotein A, we detected no difference between patients with heart event versus procedures. However, we found that the patients with no known CAD and stroke had significantly lower values. And of note, the inclusion threshold for ongoing phase 3 clinical trial that tested the selective lipoprotein lowering therapy corresponds to the 19th percentile of our cohort. So we were able to achieve a very good follow-up rate of more than 95%, and we observed primary outcome events in around 15% of patients, with the highest incidence in patients with the history of heart event. And in this multivariable adjusted survivor curve, we can see that the LDL has not shown to be an independent risk predictor of composite MACE outcome overall. In this graph, the LDL was stratified by quartiles. Furthermore, we didn't observe any difference between the group. As for lipoprotein A, in the Kaplan-Meier analysis, patient groups that were stratified by lipoprotein A had approximately similar incidence of MACE. And in particular, patients with extremely elevated lipoprotein A did not appear to be at higher risk of MACE. That was also confirmed in the Cox regression analysis with multivariable adjustment. However, interestingly, in patients without statin therapy at baseline, we found that lipoprotein A could have a modest prognostic value with multivariable hazard ratio of 1.12, and this is the effect of doubling the lipoprotein A. So I'll mention some limitations of the study. First of all, this was a single-center study, so we should test this in a multi-center setting. Second, only baseline LDL measurements were available, so we didn't account for possible statin initiation in the follow-up time. And to conclude, history of heart events was associated with better lipid control. Lipoprotein A was not elevated in patients with a history of heart event compared to only procedures. And LDL was not shown to be a good predictor of MACE, and lipoprotein A was a modest predictor of MACE in patients without statin therapy. So thank you for your attention, and I'm ready to take questions.
Thank you for your excellent presentation. Now we invite questions from the floor.
Thank you, Clara. Very nice presentation. Why do you think that the group with the highest lipoprotein A don't have a higher risk for MACE? Do you have a theory about that?
No. So we don't have, actually, this is only at 19% of our population, so maybe it's not enough number of patients that comprise that group. And also these patients, when we look at the baseline characteristics of the patients, they have a higher statin usage compared to other patients, so maybe that's made a difference, but at the end we don't know.
But you do have an idea.
I have an idea.
Thank you.
Very interesting data. Do you want to jump in?
Did you consider that a heart event is not necessarily correlates with extension of atherosclerosis, because sometimes you can have a higher degree of atherosclerosis in patients without any heart event. This could be disturbing when you consider the prediction of these biomarkers, lipoprotein or A or LDL, different.
I'm not sure if I understood the question.
To have a heart event is not really an expression of extension of atherosclerosis. Do you consider this?
We just look what is the lipid control between patients. We didn't go into what is the pathomechanism of these heart events. What we suppose that the patient care for patients with a heart event is better. So this was the main idea for this analysis.
Yeah, interesting data. I wouldn't be too disheartened by the prognostic data. Statins obviously are the major confounder, with statins increasing Lp(a) and decreasing LDL cholesterol, which is almost certainly making it very difficult to see a true relationship between the biomarker and events. And my question is, did you consider adjusting for statin use and statin intensity in that model to see whether that would reveal the true underlying relationship, probably, between the biomarkers and events?
Unfortunately, we didn't have this information, what is the dosage of statin, but that would be certainly important to look at, yes.
And I thought at the heart of this project was quite an important question, which is, does the presentation, whether it's with an acute life-threatening event or just coming up for a procedure, which cardiologists love to do, impact on either adherence to preventative therapies or lifestyle measures? And to that end, have you looked at broader lifestyle measures to determine whether smoking rates are lower in those with heart events, or activity levels or weight were lower? Did any other important prognostic risk factors differ between the two groups?
Yes, that would be also be interesting to see. However, we didn't have this data about the smoking habits after those events and other lifestyle factors.
Okay.
Yeah, thank you.
Okay, thank you, Clara. So our next speaker is Ibrahim Schaefer from Switzerland, who's going to talk about another challenging area, which is how to rule out functionally relevant coronary disease in patients without known coronary artery disease using a biomarker approach. It's always been a big challenge.
Yeah, dear Professor Mills, dear Professor Hahn, dear colleagues and friends, thank you for the introduction and thank you for having me on this really great meeting. It's an honor and my pleasure to present to you today our work from Basel on the use of high-sensitivity cardiac troponin T and I for the early exclusion of functionally relevant coronary artery disease. Well, coronary artery disease continues to be a major cause of cardiovascular burden, and it is still accounting for a vast number of hospitalizations, millions of deaths, and excess healthcare costs worldwide. And its dynamic nature that may result in a variety of clinical presentations with different risks for future cardiovascular events. And given this, the early and safe exclusion of functionally relevant coronary artery disease is really a crucial but yet unmet clinical need. Because in current practice, risk stratification is mainly based on clinical assessment and exercise stress testing or cardiac imaging. And indeed, these methods may be beneficial in many patients, but however, they seem to be increasingly inappropriately used, and they are frequently associated with either modest predictive value or with restricted availability, radiation exposure, and additional costs. And it is in this context that, as you certainly know, biomarker-based strategies have gained increasing attention, and in particular, cardiac troponin seems to be attractive as it is becoming an increasingly sensitive biomarker and is already well established in the early rule-out of acute coronary syndromes. So we aim to derive and internally validate optimal cutoffs for different high-sensitivity cardiac troponin assays for the early and safe exclusion of functionally relevant coronary artery disease in patients without known coronary artery disease. And we aim to assess a prognostic value of high-sensitivity cardiac troponin when it comes to adverse cardiovascular outcomes. This analysis is part of the Basel 8 trial. Basel 8 is an ongoing and large single-center prospective diagnostic cohort study which actually was designed to advance the early detection of functionally relevant coronary artery disease. We enrolled patients with symptoms possibly related to AFCAT who were referred to the University Hospital Basel between Jan 2010 and May 2016 for a rest and stress myocardial perfusion imaging. And after collection of all relevant clinical information, the patients received a blood draw for the measurement of high sensitivity cardiac troponin concentrations before stress testing. 2 independent cardiologists who were blinded to those troponin measurements then adjudicated the presence of AFCAT based on expert interpretation of the MPI SPECT-CT images and on coronary angiography whenever available. And after 5 years, we performed the follow-up to collect information about adverse cardiovascular events. We excluded in this analysis patients who had previously known coronary artery disease, patients with missing high-sensitivity cardiac troponin concentrations, and patients with renal failure on chronic dialysis. We used 2 different widely applied high-sensitivity cardiac troponin assays, namely the Roche Elexis high-sensitivity cardiac troponin T assay and the Abbott Architect high-sensitivity cardiac troponin I assay, for each of which we assessed the safety and efficacy of different cutoffs. And we predefined the sensitivity and negative predictive value, each of at least 90% as acceptable performance criteria. We used the bootstrapping procedure to assess in the next step the internal validity of the cutoffs for a realistic estimate in future similar patients, and we used a multivariable Cox regression model for the survival analysis. So 2,111 patients without previously known coronary artery disease were eligible, of whom 23.6% had a final adjudicated diagnosis of AFCAT. The baseline characteristics in our cohort were similar to those of other cohorts of suspicion with AFCAT, with a median age of 68 years and 44% being female. 71% had at least one cardiovascular risk factor, and 40.7% were already on aspirin, and 35.5% were taking statins. So for the Elexis high sensitivity cardiac troponin T assay, the optimal cutoff that reached the predefined target for sensitivity, which is shown here as the blue line, and MPV, which is shown as the red line of 90%, was 5 nanogram per liter. And this cutoff actually reached a sensitivity of 90.8%, and an MPV of 90.2%, triaging 468 patients, that is 22.2% directly towards rule out. For the high sensitivity cardiac troponin I assay from Abbott, we identified an optimal cutoff of 2 nanogram per liter, which reached a sensitivity of 91.6% and an MPV of 90%, triaging a similar number of 422 patients. That is, again, 1/5 of the patients directly TORS ruled out without the need of cardiac imaging. We obtained very similar results for both high-sensitivity cardiac troponin assays in our bootstrap internal validation, which shows robustness of our findings when it comes to similar future patients. For the prognostic outcome, we constructed those response plots which model the adjusted continuous relationship between cardiac troponin and the outcome, which is here all-cause death, within 5 years of follow-up. Troponin was handled in a continuous manner, and in order to avoid imposing linearity, we used restricted cubic splines. We computed the hazard ratio with a multivariable Cox regression model, adjusting for age, sex, BMI, cardiovascular risk factors, as well as past medical history. And what you can see is that for both high-sensitivity cardiac troponin T and high-sensitivity cardiac troponin I, an increase of the cardiac troponin concentration is associated with an increase of the hazard ratio. However, this was significant for high-sensitivity cardiac troponin T, whereas it was not for high-sensitivity cardiac troponin I. And I think that's in line with yesterday's presentation of Luca Köchlin, who has shown that the prognostic accuracy of high-sensitivity cardiac troponin T is higher for all-cause death than the one of high-sensitivity cardiac troponin I, and he has shown this in an independent cohort to ours. We obtained similar results when it comes to the outcome of cardiovascular death. Limitations of our study are the single-center design, but MPI SPECT-CT was applied as the standard imaging method to patients with a wide range of pretest probabilities, so this may have counterbalanced a potential referral bias. And also, we really used a very stringent method to finally adjudicate the presence or absence of FCAT. We cannot exclude that we potentially misclassified a small number of patients. So to conclude, our analysis has shown that in symptomatic patients without previously known coronary artery disease, very low high-sensitivity cardiac troponin concentrations, below 5 nanogram per liter for high-sensitivity cardiac troponin T, and below 2 nanogram per liter for high-sensitivity cardiac troponin I, may generally allow to safely exclude functionally relevant coronary artery disease in a relevant number of patients. And in addition, our results indicate that high-sensitivity cardiac troponin concentrations above the derived cutoffs had a prognostic value as they were associated with substantially higher cumulative incidence of all-cause death and cardiovascular death within 5 years of follow-up. With that, I want to express my deep thanks to the fantastic research group of the Cardiovascular Research Institute in Basel, and to you as the audience for your attention, and I'm happy to take your questions.
Very nice presentation. Just while we're waiting for some questions, some thoughts. So we heard in the previous presentation that lipid markers can let you down. So it's great that we moved back to troponin, which never lets you down in terms of prediction. And not just one troponin, 2 troponins, just for safe measure. This is the biggest challenge, though, I think, for troponin, how to use it effectively in this setting. And I'm interested in how you arrived at the threshold of 90% negative predictive value as your target, and whether you had any discussion with patients or clinicians about how happy they would be being told that I can, with 90% confidence, say you don't need to go on and have a functional test, but 1 in 10 of the times I'll get that wrong. How did you derive that threshold, and do you think that clinicians and patients will accept that in practice?
So we actually, this is a very good comment, thank you. We actually decided on this predefined performance criteria based on previous literature, which has made similar studies also using those performance criteria. But it's a very good point, yeah, if you want, you can think about elevating this criteria.
Yeah, I think for the prediction of MACE, usually it's a combination of troponin as well as coronary risk factor, like age, diabetes, and all that, smoking. And do you use that model? Maybe you can get a better prediction if you combine troponin value as well as the coronary risk factor. Have you tried that model in your data?
Very good question, thank you, but we didn't look at this until now. Yeah.
One more point. So you focused on rule out, but patients who've possibly got important coronary disease often have higher values. Did you interrogate whether there was any role for using higher values to defer functional testing to go straight for invasive angiography? Because there are a group of patients whom functional testing is probably not necessary, and you could go straight to definitive anatomical testing. Did you explore that at all in the data set?
Thank you again for this question, but no, we didn't until now.
Okay. It'd be interesting to see whether there's additional value beyond rule out in this setting. Okay, if there are no other questions from the floor, then we'll move on to the next presentation. Thank you for an excellent talk. Brilliant. So our next presentation is from Zuzana Komorova from the Czech Republic on cardiac biomarkers and outcomes in patients with ST segment elevation myocardial infarction. Welcome.
Good afternoon, ladies and gentlemen. I would like to present you my PhD thesis titled Impact of Cardiac Markers Values and Ischemic Time on Mortality in Patients with ST segment elevation myocardial infarction treated with primary angioplasty, analysis of 270 patients. Cardiovascular events are among the leading causes of death worldwide. Our department treats between 250 and 300 patients with ST segment elevation myocardial infarction every year. The aim of this study was to analyze 30 days hospital and 1 year mortality of patients with acute STEMI treated at our department with primary coronary angioplasty, and the influence of factors, shock, troponin, natriuretic peptides, creatine kinase, and ischemic time on patients' mortality. We analyzed a group of 270 patients treated with primary PCI between April 1st, 2018 and March 31st, 2019. Here is a table with the detailed characteristic of a whole group. We can see that mean age was around 67 years, 70% were male. If we are talking about coronary occlusion and culprit lesion, in first place it was ramus interventricularis anterior, left anterior descendant, around 46%. In the second position, it was arteria coronaria dextra, right coronary artery, 37%. And in third position, it was left circumflex, 12%. Mean ischemic time to revascularization was 203 minutes. 18% of patients were in cardiogenic shock. Mean ejection fraction of left ventricle was 46.4%. 62% had hypertension, 37% had diabetes. Mean BMI was around 28. Mean LDL cholesterol was around 3. And if we are talking about laboratory parameters, median of creatine kinase was 14.9. Median of troponin was 2,444, and median of natriuretic peptide was 538. 1 year mortality was analyzed using Kaplan-Meier method. On the left side, we can see a Kaplan-Meier curve. Group 0, blue one, no-shock patients. Group 1, cardiogenic shock patients. And 1-year mortality between cardiogenic shock and no-shock patients who was statistically significant at the level 0.05. In these two tables, we can see hospital and 30 days mortality. The numbers are very similar. We use Fisher-Exact two-tail test. And again, 30 days and hospital mortality between cardiogenic shock and no-shock patients was statistically significant at the level 0.05. Comparison of selected parameters, again, shock versus no-shock patients. In this table, we have some parameters: age, sex, left ventricle ejection fraction, ischemic time, creatine kinase, troponin, and natriuretic peptides. And we can see that statistically significant at the level 0.05 were left ventricle ejection fraction, ischemic time, and natriuretic peptides. We already know that shock patients had worse survival than no-shock patients. Shock is associated with survival, and we wanted to know if there are other parameters which could be also associated with survival. And we can see here that statistically significant was age. Age is associated with survival, then sex is associated with survival. Female gender is more risky than male. Cardiogenic shock, left ventricle ejection fraction, and natriuretic peptides. Troponin came out with borderline significance, but not significant at the level 0.05. And ischemic time is not associated with survival because it's not an independent factor, but depends on patient's condition. Discussion and conclusion. In all cases, 30 days hospital and 1-year mortality. Shock patients had worse survival than no-shock patients. Shock and no-shock patients different in mortality and a number of other parameters: natriuretic peptides, ischemic time, and left ventricle ejection fraction. And if we are talking about influence on survival, age, sex, left ventricle ejection fraction, natriuretic peptides were associated with survival. Troponin T came out with borderline significance. And ischemic time, it's not associated with survival because it's not an independent factor, but depends on patient's condition. Thank you for your attention.
Excellent presentation, super important condition, and really interesting data. Just while we're waiting for questions, I have a question as to how you define time, ischemic time. Was that the time from the diagnosis to revascularization, or time from symptom onset?
Ischemic time begins with chest pain, and it's until insufflation balloon in coronary artery in cath lab.
So it does encompass pre-hospital chest pain. Okay, that's great. And I guess my general question is, based on your findings, has this influenced your practice in your center? Do you still measure this panel of biomarkers in all patients with STEMI, or have you refined your thinking as a consequence of your findings?
We use it in our clinic.
And which ones do you find most helpful in practice? Most
helpful, troponin, and maybe the creatine kinase, if we are talking about myocardial infarction, how big it is.
Okay, so you still like creatine kinase. That's fine. Everyone's allowed to have their favorite biomarker. Any questions from the floor? Well, if there are no more questions, we'll draw that session to a close. Thank you very much for an excellent presentation to all the speakers. 10 past. We'll reconvene at 10 past. or to try and get back on time, or should we give it a little longer? Quick coffee, 10 past. Yeah. Sounds good. Okay.
Ding-a-ringy.
Ladies and gentlemen. Well, I think I need to go there.
One ringy-dingy. So I will set this, and it's 7 minutes. They're supposed to be done. And if they look like they're not getting done, the young investigators are much more better.
Indeed.
The masters just go on. You ready? Okay, Charles de Roquetillard, or however you say your name. You'll have to pronounce it for me. Oh, good. Dr. Mebazaa said I have to introduce all the French people. He just did that to torture me. All right, cytokine response to aggression from sepsis to viruses, a meta-analysis.
Thank you very much. Thank you for giving me the opportunity to discuss my work with you. My name is Charles de Roquetillard. I am an intensivist and a PhD student in Alexandre Mebazaa's lab. And today we'll talk about cytokines in various infectious aggression. So, as you certainly know, several studies have reported elevated level of cytokines in various infectious diseases, from COVID to sepsis through influenza and other viruses. Nevertheless, there is no clear pattern identified for each disease, since they were never compared between each others. The report of the correlation between elevated cytokines and severity is inconsistently found by studies and inconsistently reported. And when authors found elevated cytokine level, they feel free to call it cytokine storms, since there is no clear definition of it. But this has therapeutic implications, since it commends the use for anti-cytokine therapy. So far, the anti-cytokine therapy was mainly tried in COVID and a few times in sepsis, with quite disappointing results. And the comparison between diseases is required and was only assessed one time in a study published in Lancet Respiratory Medicine in 2019. But this study has several limitations, since it was not a proper meta-analysis and not a complete literature review. It included preprints, and it analyzed syndromes rather than pathogens, which may be misleading. So we sought to analyze the existing literature on the reported cytokine levels in various infectious conditions. We sought to analyze if the cytokine levels can discriminate severe from non-severe forms in those diseases. And at last, we thought to identify if the cytokine pattern can discriminate between diseases. So we conducted a meta-analysis based on literature review. We searched for PubMed, Medline, and Embase databases. We included, as I told you, various infectious diseases from COVID-19, but also bacterial sepsis, influenza, Ebola. And off the record, we also screened for SARS-CoV infection and breakbone fever disease, but none of the identified studies met the quality criteria for final inclusion. We extracted from those research and from those papers the levels of the IL-6, IL-1, IL-10, IL-8, TNF, and interferon gamma, so the six more oftenly dosed cytokines and reported cytokines. And we chose to include studies and articles published from 1990 to April 2021. We chose to restrict to this 30-year period, since the method for the dosing of the cytokines before this period were quite imprecise and subject to numerous bias. We included observational studies, interventional studies, and case series, and we chose to exclude case reports, preprints, non-English studies. We excluded also the studies for which the mean and standard error of the mean could not be obtained, and we excluded the studies which included less than 20 patients. So based on this algorithm of cytokine and of those cytokines on those diseases, we found 9,231 studies which could be screened for eligibility. Among them, only 241 were finally assessed by full reading of the manuscript. For the above-mentioned reason, we excluded 151 articles, so we finally retained 90 studies for our analysis, which accounted for something like between 15 and 16,000 patients. So for the reported cytokines, let's start with IL-6, which is the more often reported cytokine. So we clearly demonstrate here that sepsis is the main IL-6 driven disease. This is a logarithmic scale, so as you can see, even severe sepsis exert a higher level of cytokine of IL-6 than COVID, with an association between severity. The most severe cases tended to exert higher level of IL-6. Influenza and Ebola had lower levels for the cytokine. We found quite the same pattern for IL-8, which is a similar, very inflammatory cytokine. Sepsis was the major disease with the higher level of IL-8. And we found a clear correlation between higher levels and higher severity for COVID, but also for sepsis. IL-10 was found quite elevated in sepsis as well, but this was previously reported, and the association with severity was found together. Interestingly, we found that Ebola a patient suffering from Ebola exerted very high level of IL-10, which was not described in the literature before, which certainly deserves further investigation. As you can see, there is quite a few patients, only 75, so this may be a bias also, which should deserve further investigation. There is no clear association between disease and TNF levels, so difficult to exert conclusion on this, but we can see that patients with influenza had the higher level of TNF, and this may have implication on the ability to patient to clear the virus. And the interferon, very interestingly, the interferon gamma level was much lower in critical COVID compared to the severe ones, which may have something to see with the aberrant macrophage activation that we see in the critical case of COVID. And we'll discuss this later, but this may have something to see with the incapacity of macrophage to clear the virus in the lung. And at last, the IL-1 beta reported levels were inconclusive and very scarce. So the main findings is we need more data on IL-1 beta levels. So to conclude, we can say that COVID-19 inflammation is far inferior to sepsis inflammation. So sepsis could say, who's the cytokine storm now? Because I think this is the leading infectious cause of cytokine storm. But this study is also hypothesis generating. We found that influenza was associated with high level of TNF. This is consistent with preclinical studies and fundamental studies. We found that TNF was very important for lung epithelia to clear the virus. So one can hypothesize that patients who are not able to synthesize TNF may have higher burden of pathogen. We found that low interferon gamma was associated with critical COVID compared to severe COVID. This is consistent with aberrant macrophage activation. This was reported in several reports previously, and several authors have found that people with the lower level of interferon gamma are the most at risk for subsequent development of lung fibrosis. And we also found very high levels of IL-10 in Ebola, which may deserve more investigation. Of course, our studies suffers several limitations. The studies were very heterogeneous. The method of measurements were not always the same. And the weighting of the studies is also subject to discussion. But the main thing here is the perspectives opened by the study. And I think that cytokine measurements should, we have the element to say that cytokine measurements should be implemented in routine clinical use. It can serve as a risk stratification. And Adria Pico recently demonstrated that among all patients admitted in intensive care, whatever the motive of admission, from infectious cause but also cardiac failure, the level of IL-6 measured on admission was linearly correlated with 3 months mortality. So and this was superior to other biomarkers such as PCT, CRP, and even the severity scores. And maybe in the future, immune monitoring and assessment of cytokines level may lead to tailored immune therapy, but this is maybe in several years. And at last, since we clearly see, and we are not the only one to see that sepsis is the leading IL-6 driven disease, maybe it's time to try anti-IL-6 receptor therapy in the setting of sepsis. I thank you for your attention.
Okay, anybody have questions? While they're thinking, I've got one for you. I've done a few meta-analyses, and when you put your first search terms in and it comes back 9,000, what did you do?
We screened every one. No, we extracted it on a CSV file, and then we screened every title first. And when the title was imprecise, we read the abstract. And we did it for the 10,000 studies. I was not alone.
I would have thought it takes 3 years. All right, anybody with questions? Did you submit this for publication somewhere?
Not yet, okay. But I'm looking for maybe a senior statistician to read again my work, because I'm not a senior statistician. But
perfect.
If someone is interested.
Luella's volunteering right there. Do you have a question? She has a question.
Microphone, please. Grazie mille.
Prego, prego. So, of course, this begs the question of why steroids doesn't work for sepsis when it works so well for COVID.
I'm not sure I understand, but you.
So you've presented. So you've presented data which shows that the cytokines levels are higher in sepsis than in COVID,
yes.
And we know that dexamethasone worked extraordinarily well for COVID. Is there any hint in the data that you've seen as to why steroids don't work so well in sepsis as they do in COVID?
So you assume that steroids doesn't work in sepsis? Yes. Well, I'm not sure everybody agrees on that, but okay. But I mean, dexamethasone is very wide range anti-inflammatory drug, so there's nothing comparable with anti-cytokine therapy. I'm not sure I understand well your question, I'm sorry, but dexamethasone is not immune therapy. I mean, it's wide range therapy, but it exerts mainly cardiovascular effects, at least in sepsis. So I agree with you, it doesn't work for its anti-inflammatory properties. And the reason why it works in COVID is I'm not sure we clearly understand well why, but maybe it has something to see with the aberrant macrophage activation, because the pathophysiology of COVID in the lung is very similar to macrophage activation syndrome in the tissue. I mean, so this is not the same pathophysiology than sepsis. Maybe it's the reason why.
All right, thank you.
It's my turn to call Christoph Kaufmann.
No,
Christoph is not here. Okay, then it's Frank.
Okay. That means it's Noma Assad, source and mechanism of dipeptidyl peptidase 3 release in pathological situations.
Okay, see himself. Yeah, just like this and here. Okay, thank you. Okay, hello to you all. My name is Noma Assad and I am doing a PhD. I'm in the first year of my thesis now in the team of Professor Mebazaa. So my project is more translational research more than it's clinical, concentrating on dipeptidyl peptidase 3, the source and the mechanism of release in pathological situations. So to start with, DPP3 is a metallopeptidase which cleaves dipeptides sequentially from the N-terminus. It has several substrates such as angiotensin, enkephalin, and endomorphin. It is intracellular, mainly cytosolic, but it is also detected extracellularly in body fluids and in the plasma of healthy and sick individuals. So clinical data show that increased levels of circulating DPP3 were associated with increased mortality risk in patients with cardiogenic shock, hemorrhagic shock, and septic shock, showing DPP3 as a biomarker of prognostic interest. Moving to preclinical sets, actually injecting healthy mice with human DPP3 led to a significant decrease in left ventricular shortening fraction, showing DPP3 as a myocardial depressant factor. So as you see here, DPP3 is ubiquitously expressed in all of the cells and the tissue of the body. And we see that its expression is differential based on the type of cell. Here we are speaking in physiological situations. However, in pathological situations, it's not yet understood or not well documented the expression of DPP3. So from here comes the objective of our study, to first detect the DPP3 expression in pathological situation, second, detect the source of this protein, and then third, how it is liberated from tissues into the circulation. We have several hypotheses regarding the source and regarding the release mechanisms, cell lyses, exosomes, shedases enzyme, but I will concentrate today on the first objective, which is the DPP3 expression in pathological situations. So to do so, we used two animal models, two validated cardiac dysfunction model. The first is by injecting isoproteinol 300 milligram per kilogram for 2 days, 2 times per day, and then the third day we sacrificed the animals. And doxorubicin model, 4 milligram per kilogram per day for 6 days, and then after 1 week we sacrifice. So at the end of both of the models, we harvest the organs, the blood for obtaining plasma and leukocytes, and bone marrow for obtaining bone marrow cell pellet and the supernatant, the stroma in this microenvironment. And then we extract proteins and we extract mRNA and we study the expression of DPP3 on protein level and on the mRNA level. So our results was, here we see the results in the isoproteinol model. In each organ we have mRNA and protein expression. We will concentrate more on the protein in analyzing the results. We see here in these 4 organs, the heart, liver, kidney, and lung, we see the tendency to decrease or to increase, but no significant results. And it's always different between the different organs. Now, what we have seen a significant change is in the spleen. We have seen a decrease in the expression of this protein in the iso group of mice compared to the control group. What was quite interesting for us is the increase in bone marrow cells and in the bone marrow supernatant surrounding these cells in this microenvironment. Now moving to the doxorubicin model, we have here the results on the protein level. We have seen that there was a decrease, significant decrease in the heart and the lung in the group of doxorubicin mice compared to the control. No significant changes in liver and kidney. In the spleen, we see increased expression of DPP3, and in the bone marrow cells and supernatant, we see like a tendency to increase, but it's not significant. So actually here, by that, we detected the expression of DPP3 in 2 different animal models. And if we want to analyze these results and see how they can orient us in our next objective, which is detecting the source of this protein, we have actually 3 hypotheses. So first of all, either the tissue or the organ that highly express DPP3 in this certain pathological situation, it is the organ that liberates DPP3 into the circulation, which in this case scenario we have in the iso model bone marrow cells as a like a candidate, let's say, for releasing DPP3, and in the doxo model we have the spleen. Or the tissue that we see that it's a decreased expression of the protein means that it already released the protein into the circulation, which leaves us with the spleen in the iso model and the heart and the lung in the doxo model. Or there is no correlation between the expression and the release into the circulation, which leaves us with all organs actually. Now we are currently in process of continuing additional experiments. We are analyzing the activity of DPP3 in plasma samples and in bone marrow supernatant by collaboration with 14-4 company, and we are studying also the localization of DPP3 by immunofluorescence. So as we have seen, we've seen different expression of DPP3 among the two models. So it is maybe due to the fact that it's expressed differently based on the mechanism of each pathology or mechanism of the model. For example, in isoproteinol model, we see ischemia, we see hypoxia, necrosis, we see oxidative stress. In doxorubicin model, we have also oxidative stress, but we see more cardiomyocyte damage, endothelial dysfunction, mitochondrial dysfunction, and apoptosis. Plus, the fact of the systemic implication in each model. For example, in the ISO, the heart is the main target, while in the doxorubicin, there is more systemic implication as a manifestation. Second, the different time points between the two models, the duration of the model and the time we sacrifice the animals, because for us, the validation of the model is always based on the cardiac function, but for the modification on the tissue or on the molecular level, it doesn't have to follow the same time pattern of the cardiac function, actually. So now we have more specific experiments in the next step to know exactly the source of DPP3. Just I have a couple of words regarding the mechanism of liberation. We have just a very preliminary start. As studies show that in pathological situations, DPP3, the increase of its level is associated with increase of cardiac and heart cell lysis markers. So what we have started to do to validate or to examine this hypothesis that DPP3 is liberated by cell mortality or cell lysis, we started in vitro experiments on cardiomyocytes and we stressed the cells. And we have seen that the more we stress the cells, the more we starvate them, the more we see mortality and the more we detect DPP3 in the supernatant of the cells. And we are currently now trying different stress conditions, hypoxia, doxorubicin treatment, etc. And the next, it will be working on animal model and cohorts and trying to measure DPP3 in plasma, in tissue, cell lysis markers, and mortality rates, and try to find if there's a correlation between these parameters to know if it's related by cell lysis. And thank you for your attention.
Okay, do we have any questions? Or do I get to ask them all? Apparently me. Okay. So I'm sitting here and Alex is whispering to me that this is going to be a really big marker someday. Yeah. So as an ER doc, I have some questions about things that are going to be markers, because the first thing is I want to know how stable is it when I draw it out of the patient? Does it fall apart in 2 minutes and I have to put it on ice and get it analyzed quickly, or can I set it on the table for an hour? Is it, because my experience is most of these kind of things don't last very long in the serum.
For me, when I worked on it actually in vitro, when I treated the cells, because I had previous experiments, we worked on ice. I know the half-life in the body, but actually I don't have a specific idea of it's. For me, I work on ice, but I don't know the degradation of DPP3 specifically. I don't have an idea of this information actually.
Do you have a feel for the half-life in the body?
It's 20 minutes.
Okay.
Yeah.
And it's eaten by the blood?
It's actually, when we were trying to put the hypothesis regarding this project, we had also another axe in our mind, which is the degradation or clearance from the body. So we don't have specific now data regarding this, if it's the liver, if it's the kidney, if it's both, if it's...
Okay. And the last question I have is, what are the measurement units? Is this a milligram per deciliter, a nanogram per liter? What is the endogenous concentrations that you're working with?
Actually, in the clinical data, it was nanogram per milliliter.
Okay.
For a normal in the plasma, and for the activity, we measure the enzymatic activity. Yeah.
So it might be an ER candidate one day. All right. Anybody else? Yes, back here.
Thank you for this very good presentation. I'm not a troponin expert, but I'll just try to imitate the guys that do all the troponin work. You showed that an elevation of DPP3 is associated with an elevation in cardiac troponin I. And you also said that the isoform was a more cardiac-specific injury, perhaps in docs it was a more systemic inflammation. or the systemic reaction. So do you have any information about if an elevation in DPP3 is also associated with an elevation in troponin T? And if perhaps in the DOX variant there's even more association with troponin T compared to troponin I?
Actually, we didn't measure yet the troponin in the samples. It was also one of the steps that we wanted to do next. In these two animals models in the samples, in addition to measuring DPP3 activity in the plasma, we wanted to measure troponin, but we don't have yet data regarding the increase of the troponin.
Okay, thank you.
Thank you.
And next up we have Ayu Askagi. Oh, really? An association between LF-ABP and poor outcomes in the ICU, an ancillary study of the frog ICU.
Okay, now, hello everyone, I'm Aya Sakage. Thank you. Currently a researcher in CERN in France and an emergency doctor in Japan. And I'd like to thank you for giving me the chance to speak here today, and to thank Professor Mebazaa and the next presenter, Dr. Dunio, for mentoring me. Now, my presentation is the association between LF-ABP and poor outcome in ICU. The traditional parameters for diagnosing for AKI have a number of problems in terms of rapidity and influence from other factors, and novel biomarkers have long been noted as a solution to this problem. Our particular focus is on the liver fatty acid binding protein, LF-ABP, which is present in proximal tubule in kidney. Our question is very simple. Is LF-ABP really useful as a biomarker? All biomarkers in this study are urinary biomarkers. To discuss this question, we compared LF-ABP with NGAL and cystatin C, also novel biomarker for kidney injury, and their predictive values for this patient outcome. Initially, our study is a necessary study of frog ICU cohort, and our primary outcome is the occurrence of AKI during ICU stay, and our secondary outcome, the mortality at 28 days after ICU admission and at 1 year after ICU discharge. This study included 1,760 patients. Among them, the patient who had AKI during the ICU stay was 41%. There box plot a value of each biomarker at ICU admission for the occurrence with or without AKI during ICU stay. For all biomarkers, the values are significantly higher in the group of AKI. That means the gray boxes. This box plot for death at 28 days after ICU admission. These are similarly found to be higher in the group of poor outcome. That means in the group of patients who died. This very interesting box plot shows that LF-ABP and NGAL values at admission were significantly higher according to the severity of AKI. Okay, let's move on to long-term outcome. There are survival curves of each biomarkers at ICU discharge for 1 year all-cause mortality. Of course, these alone are enough to suggest that the higher biomarker levels significantly increase the mortality, but even more interesting is this plot here. This curve is created by 4 groups. All biomarkers is lower than median, 1 of them higher, 2 of them higher, and all of them higher. What we can see from this is that if 2 or more biomarkers are elevated, the risk of death at 1 year after ICU discharge, the risk of the discharge is increased. Thus, the increase of 2 of these urinary biomarkers could be a warning signal for physicians, although the patient is leaving ICU. From here, I'll tell you about the predictive values for each outcomes. One of the strengths of our study is the fact that we compared 3 urinary biomarkers for both short-term and long-term outcomes, like this. And concerning the predictive values for the occurrence of AKI during ICU stay and for death at 20 days after ICU admission, LF-ABP is significantly inferior to NGAL. On the other hand, the predictive value of LF-ABP was significantly higher to, superior to cystatin C. Concerning for the death at 1 year after ICU discharge, it was also inferior to NGAL, but similar, comparable to cystatin C. So, consequently, unfortunately, it can be argued that the usefulness of LF-ABP is very limited as a biomarker. In conclusion, LF-ABP is associated with AKI, 28 days mortality, and 1 year mortality. However, its predictive values is inferior to NGAL, but superior or comparable to cystatin C. Thank you for your attention.
Okay, we're open for questions. While they're thinking, I have one. Why did you use urine instead of blood?
I'm sorry, could you repeat?
Why did you use urine?
Usually.
Pee instead of blood? Because my experience in the emergency room is people, it's sometimes hard to get them to pee, but I can always get blood out of them.
Are you sure?
Yeah, unless they're dead.
That means comparison the results, the sang entre urinary.
Pourquoi les biomarqueurs sont urinaires?
Parce que, because I think that that is not more. Excuse me.
You can already you can say that urine is coming from the kidneys. Already he will stop asking questions.
It's not, but I'm not sure because a poor study, the comparison between sang, comment on dit en France, comment on dit en anglais sang.
Japonais, je sais pas bon. Go ahead, answer in Japanese.
Brought blood and urinary LFABP, so it's not sure. But so for determine the injury, kidney injury, it's more useful than blood test.
Urinary biomarkers are better to look on injury of the kidney than plasma biomarker. I mean, this is true.
Okay.
That's what she said.
Anybody else? All righty. Thank you. Okay. And next is Benjamin Denel, cardiac biomarkers and postpartum hemorrhage, a prospective multi-center trial.
No. Yes, okay. Good evening. Thank you for your introduction and thank you for giving me the opportunity to present my work. My name is Benjamin Denel. I am physician in anesthesiology and critical care in Saint-Louis Hospital, and I work in SAM Unity 942, directed by Alexandre Mebazaa. Today we will talk about the cardiovascular biomarkers in postpartum hemorrhage. Postpartum hemorrhage is a worldwide health problem. It's defined as a cumulative blood loss above 1,000 milliliters between the delivery and 24 hours after delivery. Postpartum hemorrhage is the first cause of death of a woman in the world, with a rate death between 8 in developed country to 20% in underdeveloped countries. The etiologies of postpartum hemorrhage are summarized in the 40 group. The first T for stone anomaly, uterine atony, traumatism like laceration or rupture uterine, tissue anomaly like retained placenta or clots, and the last one is thrombin anomaly with clotting factor deficiency. The management of postpartum hemorrhage is based on resuscitation measures like fundal massage, the use of uterotonic drugs like oxytocin and sulprostone, resuscitation measures like transfusion, catecholamine, mechanical ventilation if needed, and surgery, artery embolization. But postpartum hemorrhage is followed by a high rate of morbidity, and PPH represents a traumatic childbirth experience, namely with the occurrence of post-traumatic stress disorder, anxiety, and depression. Up to 20% of women who experienced PPH develop traumatic childbirth and mental illness. PPH is leading to avoidance of maternity care and long-term consequences. Unfortunately, risk factors of postpartum hemorrhage to develop mental illness are poorly studied, and the association between cardiovascular biomarkers and postpartum mental illness have never been studied. So, the aim of this study was to assess the association between cardiovascular biomarkers in postpartum hemorrhage and the occurrence of mental illness at 6 months after delivery. This is the HealthMob study. HealthMob study is a prospective multi-center and national study done between November 14 and November 15, and each patient were managed according to the international guideline for PPH management. Here, this is the flow chart of the study. Women were included when the diagnosis of PPH was made, defined as a bleeding above 1,000 milliliters of blood and the use of sulprostone, and 2 time points of biomarkers, of measurement of biomarkers have been done at inclusion and hospital discharge. 4 biomarkers have been measured. The first one is DPP3. DPP3 is a biomarker of shock. Troponin T, NT-proBNP, and GDF-15. GDF-15 is a cardiovascular biomarker increased in acute heart failure. After hospital discharge, patients have been followed up during 6 months, and a psychological evaluation was made to detect the occurrence of anxiety by using HADS score, post-traumatic stress disorder by using EOS score, and the occurrence of depression by using the EPDS score. The results. 332 patients were included in the HelpMob study, and 2,038 patients were followed up until 6 months. The median age of the patient was 34, parity was 2, and pre-existent mental disorder in 9 patients. The main mode of delivery was vaginal and followed by cesarean delivery. In the HelpMob study, the main cause of PPH was uterine atony, followed by abnormal placenta insertion, uterine rupture, and vaginal laceration. Interestingly, 163 patients developed psychological disorder at 6 months, namely anxiety, depression, and post-traumatic disorders. This slide summarizes the level of biomarkers at inclusion, that is to say, at the moment of the PPH. The level of DPP3 was 39 nanograms per milliliter, TNT 14, NT-proBNP 88, and GDF-15 18,000 picograms by milliliter. Interestingly, we found that NT-proBNP was higher in patients who developed psychological disorder at 6 months, and in multivariate analysis, you can see that high NT-proBNP at the moment of the bleeding was associated to a higher risk to develop psychological impact at 6 months. Concerning biomarkers at hospital discharge, the same biomarkers, DPP3, TNT, NT-proBNP, and GDF-15, and the same way, we found that NT-proBNP was higher at hospital discharge in patients who develop psychological disorders at 6 months, and when NT-proBNP was high, the risk to develop psychological disorder is high. So, to conclude, we found that high NT-proBNP levels during postpartum hemorrhage and discharge were associated with a higher risk to develop psychological impact at 6 months. This is the first time these results were observed. Levels of NT-proBNP negatively influence score of quality of life in heart failure and coronary artery disease patients, but it has never been found in hemorrhagic shock during postpartum hemorrhage. Interestingly, biomarkers of shock, namely DPP3 and troponin T and GDF-15, were not associated with higher risk to develop psychological disorder at 6 months after hospital discharge, and further studies are needed to confirm this result. Thank you for your attention.
Yes, Dr. Collins.
Great job. It's a very interesting presentation. I always think of troponin and natriuretic peptides as markers of problems. When they're elevated, whether it's sepsis or ACS or heart failure. I had never thought about it in postpartum hemorrhage, but those numbers are fairly dramatically different in negatives versus positives. What do you think the causal link is between elevated natriuretic peptides and postpartum depression? Do you think they have subclinical heart failure, which is associated with poor quality of life and depression? Like, I can't make the mechanistic link.
This is a really good question. Thank you so much. I don't have the answer of this question. but it's probably due. The rate of heart failure in this cohort is the same between patients who develop psychological impact or not. But we have to analyze if the volume of the bleeding is associated with a risk to develop psychological disorder. These results are the second analysis of HELPMOM. We will publish very quickly the first analysis of HELPMOM study, and we found that the lowest hemoglobin value is associated with a risk to develop psychological disorder at 6 months. Okay, but I don't know why there is no signal of cardiovascular biomarkers. I don't know why.
Interesting, or even looking at another functional outcome to see if that was a difference, like a walk test, or in heart failure it's the KCCQ, but something else to link that imaging functional outcomes would be interesting to see.
I think one of the answer could be the volume of fluid therapy, for example. Maybe the fluid therapy is important, maybe the patient is very, very severe, and the impact at 6 months is higher.
Dr. Massive.
You analyze the 6 months mental alterations, but I think one of the most risky complications of postpartum hemorrhage is hypophysis damage, and some patients that may develop hormonal problems. Did you analyze this?
This is preliminary. Thank you for this question. This is a preliminary analysis of HELPMOM study, and the duration of follow-up in HELPMOM study is 5 years. So I think I will answer to this question next year.
We have another question.
Thank you for addressing this condition, which only affects maternal health. It's very important. Do you know how the blood pressure was in these women? Because we know that women that have postpartum hypertension have elevated NT-proBNP. But on the other hand, with blood loss, you would assume that they had low blood pressure, probably directly after birth. Were they maybe overly compensated in terms of volume, maybe?
Thank you for your question. Systolic blood pressure and mean blood pressure is the same between the two groups. Diastolic blood pressure was lower in patients who develop psychological disorder at 6 months. Okay, and interestingly, we found that the use of norepinephrine is identical in each group.
Okay. And also, I think that just in general, women who have had a traumatic event related to their birth, we see this also with postpartum hypertension, preeclampsia help, they have a tendency to develop depression after. I mean, that link is well known as well. But thank you very much.
Thank you.
I got a question. So I love these things that don't make any sense, and this makes no sense to me, why the NT-pro would go up. There are markers of psychiatric dysfunction, and so the first question I have for you is, do you have any blood frozen for future analysis?
Absolutely.
Good. Because S100 beta has been shown to be a correlate with suicidality, and patients with low S100 beta don't have it. Post-traumatic brain injury, there's a lot of biomarkers. There's like 200 of them, and that would make sense. And they are correlated strongly with post-traumatic stress disorder, which could be absolutely what this woman almost died, and you'd expect her to have some PTSD after that. And those markers it may turn out that the BNP is just sort of red herring that's dragged along with these other more predictive markers. But congratulations on a great,
Thank you so much.
Study. Okay, next is Louis Boutin. Comparison of renal biomarker for prognostic of subclinical AKI.
Okay. Hello. So I'm sorry, we spoke about a lot of things for this session. We're going back to kidney, my patient. We're talking about the HFpEF of the nephrology, which is subclinical acute kidney injury. And we will try to compare the biomarker we can use from plasma or urine for the prognostic of these patients. First of all, as a quick introduction, the definition of acute kidney injury has evolved a lot since the last decade, and Cadigo proposed a new definition based on 3 different entities. The first one is kidney attack. Kidney attack is a situation at risk for the kidney, but you don't have any damage, you don't have any renal loss function. Kidney damage is the HFpEF of the nephrology. We can call it subclinical acute kidney injury. You have a renal damage, but you don't have any renal loss function. I think you all know that you have 2 kidneys, and when you have injuries, you will go below 200% of your normal GFR, but you won't get under this GFR limit. Here, in this context, the use of creatinine, which is a reference biomarker for diagnostic of acute kidney injury, won't increase. So you won't be able to diagnose the damage of the kidney because you don't have any renal loss function. And the last stage, which is acute kidney injury, now we define it with damage which is too much important, so now you're getting under your GFR normal limit, and you will have a renal loss function. In this context, you get an increase of the plasmatic creatinine, and you have renal loss function, we can call it acute kidney injury. The problem that the use of plasmatic creatinine as an ICU physician, it's too late. The kidney is already in dysfunction. We need to be earlier to assess specific treatment and nephroprotective treatment. That's the reason why in 2020 at QI Group proposed a new definition based on biomarker for the diagnostic of kidney damage. They introduced subclinical acute kidney injury stage, which is 1S stage. Here, you don't have any increase of plasmatic creatinine, but you have an increase of a biomarker, which we can call it the HFpEF of the nephrologist. The objective of this study is to correlate a little bit with this definition. You know that we don't know any cutoff of the biomarker, which biomarker to use, and what is the difference between all the biomarkers. Using Frog ICU, we have the chance to get 8 different kidney biomarkers at the admission. We will use it to assess the correlation with the prognostic, the mortality, of patients with subclinical acute kidney injury. First result is quite interesting. In blue, it's patient with subclinical acute kidney injury. In green, it's patient with acute kidney injury. So here, there's an increase of plasmatic creatinine. Only 4 biomarkers was quite discriminated for the mortality. NGAL, galectin-3, cystatin C, PENKID, and urinary NGAL were associated with the mortality, and there were no difference between subclinical acute kidney injury and acute kidney injury. So these biomarkers help us to discriminate severe patients without increase of plasmatic creatinine. If we try to go further, we will assess the correlation using different and the number of positive biomarkers. In non-acute kidney injury patients, so no increase of plasmatic creatinine, we have a gradual increase of the mortality with the number of the positive biomarker, and until 2 positive biomarkers, you have an association with the mortality. Which is very interesting is that if you're looking when the plasma creatinine is increased, you don't have this association with the mortality, you don't have this gradual increase of mortality. Probably because plasma creatinine is already increased, so patients have a renal loss function, it's too late. Now let's talk about phenotype. We have 8 different biomarkers. They are not saying the same thing. I think we get, for 2 days, a lot of talk about biomarkers, and probably they don't have the same pathophysiology. Here, we ask ourselves, what kind of phenotype do they represent? Cystatin C, NGAL, galectin-3 are well correlated to eGFR. They are also well correlated all together. They probably represent a decrease of the eGFR, but they are not associated with the urinary biomarker, which is urinary cystatin C, urinary NGAL, and urinary LFA-BP, and they are not as correlated with eGFR. So here probably we have two different groups of biomarkers. One is here to diagnose EGFR loss, and the other is here to diagnose the specific tubular phenotype, for example. Now we ask ourselves, what if we clustered patients using this biomarker? And it's only the beginning of this study. We found 3 different clusters using principal component analysis with a hierarchical clustering. And we found the first cluster, which was patient, non-severe patient, no positive biomarker. Cluster 2, patient with urinary positive biomarker, and they also are non-severe. At the admission, they were more associated with post-surgical complication, neurological complication, and acute respiratory failure. On the other hand, the last cluster, which has plasmatic biomarker positive, urinary biomarker positive, were associated with mortality and sepsis and shock. This is only the beginning, and I conclude this introduction of this project that probably plasma biomarker help us to identify patients with an EGFR loss without an increase of plasma creatinine. On the other hand, we're going to need to go a little bit further. We want to phenotype patients and to know precisely if it's a glomerular, if it's interstitial, if it's tubular, or if it's everything. And that's the reason why we will assess the urinary proteomic to identify specific pathway to probably prevent some damage and assess some nephroprotective treatment. Thank you very much for your attention. I would like to thank all these 3 units that I'm working with. Thank you very much.
Okay, does anybody have a question? Okay, then I'll ask them. It looks to me like you have 8 markers. I don't want 8 markers. It looks to me like any one marker carries about 80% of the weight. And adding a second marker, we get closer, and I don't need any more markers after that.
I understand you don't want 8 biomarkers, but to start and to learn a little bit about the pathophysiology, we need to assess the 8 biomarkers. Probably after, we will only select 1. That's the definition of IQI group. They propose a biomarker, but we don't know which one. There's a lot of literature about kidney biomarkers. We can do another congress about it. But we need to assess specific biomarker for this definition. And after all, probably we can use 8 biomarkers only to classify patients, but it's only for studies, not for clinical pathway.
So a lot of these biomarkers have been on the market, like NGAL, and it died because it doesn't do much. And cystatin C has been used, but mostly for research projects. And one of the biggest problems is creatinine costs about $2, and you're done. And it's a terrible marker, but people are very comfortable with it. So it's been very challenging to make progress in the renal biomarker area, not because they're not valuable, but because they're going up against a cheap, okay marker. Mina, you have a question?
Thank you for your presentation. I'm curious which EGF equation you used.
CKD-APE.
CKD-APE. Yeah. But actually, CKD-APE equation was renewed last year, so it will be also interesting to apply a new CKD-APE equation.
The problem of the new CKD-APE equation is it could be corrected with cystatin C level. As we are studying cystatin C, it's a confusion process. So we use the old CKD-APE equation because as we're studying cystatin C, it wouldn't be it would be well correlated with EGFR, but
yeah, but all the CKD-APE equation also have a cystatin C component. It has 3 sub-equations. Yeah. So the new equation without cystatin C can be compared with your
we can assess this without any problem. I guess we just have to change the algorithm. Yeah.
Yeah.
Okay. Anybody else? I think we're good. Thank you. And last up, we have Elsa Manquat, cerebral perfusion monitoring by electroencephalogram signaling.
So thank you, Professor. I'm a PhD student in biotechnology,
And I also would like to thank the scientific committees for this wonderful opportunity to present some of the results of my PhD. So first, let's see why cerebral perfusion is a key parameter to consider in order to prevent postoperative complications and reduce hospital costs. So 7 million of patients undergo general anesthesia every year only in France, and 40% of them are over 60 years old. And 5 years ago, a randomized controlled trial was conducted among this category of elderly people. In the group where hemodynamic optimization was performed to keep blood pressure at a higher level, the risk of postoperative neurological and renal dysfunction was reduced. So with this data, it appears that millions of patients worldwide would potentially benefit from personalized brain perfusion optimization. So EEG is a good candidate for brain perfusion monitoring because it is already widely available in the operating room to monitor sedation level. It has also a very stable signal that reflects directly brain function. So the challenge here is to repurpose raw EEG data routinely collected in the OR for monitoring cerebral perfusion level. Before going any further, I would like to expose you two very important postulates. The first postulate is that cerebral autoregulation thresholds vary widely. As you know, there is protective mechanism in main organs called blood flow autoregulation, and as we see on this graph, thanks to an active microvascular component, cerebral blood flow is maintained constant for a certain range of blood pressure. So blood pressure is not correlated to arterial pressure when, blood flow is not correlated to arterial pressure when autoregulation is efficient. However, vascular tone adaptation is limited by numerous factors, and at some point, some correlation appears between blood pressure and cerebral blood flow, and every change in blood pressure is impacted on cerebral blood flow. And the second postulate, as we see on the right panel, is that cerebral blood flow is reflected on the Fourier transform analysis of EEG signal. So we see that impairment of cerebral blood flow is first characterized on EEG signal by loss of faster frequency, called alpha frequencies, and then increasing slower frequencies, called delta frequencies. So based on these two postulates, we published a pilot study on a cohort of 36 patients admitted for a neuroradiology procedure under general anesthesia. We created two groups based on the value of correlation coefficient between blood flow velocity collected by transcranial Doppler and mean arterial pressure, called the mean flow index. In fact, as we saw on postulate number 1, if cerebral autoregulation is efficient, there is no correlation between cerebral blood flow and arterial pressure, so the mean flow index would be inferior to 0.3. On the contrary, if autoregulation is impaired, there is high correlation between these two variables. So on the left box plot, we see that age is similar between groups, but that patients with poor autoregulation need more vasopressor support to maintain same blood pressure level. And interestingly, on Fourier transform analysis, on EEG signal, we see that patients with poor autoregulation have a slower dominant alpha frequency, which is called alpha peak frequency. And in multivariate analysis, the association between EEG signal and perfusion is independent of major confounding factors such as ASA score, vasopressor rate administration, and age. So this means that alpha peak frequency could be a good candidate biomarker to detect impaired brain perfusion. So at this point, we can sum up the result by saying, by saying that there is a significant relationship between intraoperative EEG and perfusion assessed by the mean flow index. But the next step is to know if it is possible to optimize cerebral perfusion intraoperatively. And I also would say that, of course, this result must be tempered by some limitation. First, it's a pilot study, so it's a small cohort, and it concerns only one field of surgery, which is the neuroradiology procedure. So here is a little window on the next step of this research. So here we see mean arterial pressure and mean blood flow velocity time series on upper panels, and the percentage of delta and alpha frequency power of EEG signal during the same period of time. So these data are consistent with postulate number 2, which means that improvement of cerebral blood flow induced by hemodynamic optimization is characterized on EEG signals by an attenuation of slower frequencies and an increase in alpha frequency. So, of course, this is preliminary result here for only one patient, and we plan to extrapolate this result to a larger cohort of approximately 70 patients. So, as conclusion, I would like to thank all the people I'm collaborating with during this PhD, and that make this a wonderful journey, and thank you all for your attention.
We're open for questions. So what kind of montage, what's the placement of the leads on this? Is it standard, or is it, how many do you have to put on?
It's only frontal EEG, so it's only 4 electrodes.
Okay. Yeah, putting on a real EEG is a total pain. It takes a long time and is not worth it, quite honestly. But if you can do it in 4, that's great. There's also a company called Forest. They make a hat that you put on. The advantage of it is it's all pre-specified leads, and they're using it for ambulance to identify people with large vessel occlusion. It's not a flow parameter analysis. It's strictly as one side of the brain having output that matches the other, and they have some AI analysis. But it's a similar technology that you might be able to copy. Because the hat makes it so simple. You put the hat on, it looks like a beanie, and it says, go to the hospital now,
Yes.
or go to the clinic.
Yeah, the aim here is to make something very simple and very useful, so that's exactly that.
Yeah, great. Anybody else? If not, then I think that's it, and we're going to turn this over to Dr. Collins.
I did it very well.
You did a great job.
Buon pomeriggio a tutti. I'm Peyman Nazarian. I'm from the ED of Karachi University Hospital, and with the Dr. Todd Collins, everybody knows him. We are very glad to introduce this section that is a 45 minutes new concept section. We will have 3 speakers, 2 senior lectures, and a master lecture. Very glad to introduce the first speaker. That is Professor Mina Hur from Seoul, South Korea. The title of this senior scientific lecture is COVID-19 and Presepsin.
Thank you, Lehman, for your kind introduction. Good afternoon, everyone. My talk is COVID-19 and Presepsin. So we are now using the sepsis 3 criteria, and the sepsis is newly defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. And to define septic shock, we have to measure mean arterial pressure and the serum lactate level. And the triad of sepsis is so infection, host response, and organ dysfunction. And we are using SOPA score to describe multiple organ failures in sepsis, which is based on 6 different subscores. But it is ironical, we use still SOPA score, which was introduced already 25 years ago to newly define sepsis. And then from this original investigation, it had some limitations in terms of cardiovascular status and coagulation system evaluation. And it also has several limitations in terms of cardiovascular subscore, which is dependent on the adrenergic support, and the renal subscore, which is still using serum creatinine level with a lot of limitations. So in addition to the clinical diagnosis of sepsis, there is always room for further improvement using biomarker approach in sepsis. So WBC, CRP, and procalcitonin are well-known inflammatory variables in sepsis, and procalcitonin was first reported in 1993 with its association with bacterial infection. Compared with CRP, procalcitonin may show better specificity, time advantage, and close correlation with septic severity and outcome. And presepsin is a soluble protein fragment by cleavage through proteases from bacteria, which is specific for sepsis. And presepsin can be produced via monocyte macrophage system, and later it would stimulate the production of IL-6, procalcitonin, and CRP. And compared with procalcitonin and CRP, presepsin is known to be more infection-specific with short response time after onset and short half-life in blood. And it is used clinically under the coverage of National Health Insurance in Japan since 2014, as well as procalcitonin. And several large clinical trials have shown its better performance, a better prognostic performance compared with procalcitonin. And in that Albios trial, differently from procalcitonin level, at all the 3 time points of day 1, day 2, and day 7, presepsin levels were significantly higher in the descendant than in the survivors. And the same finding was also observed in septic shock patients. So we also tried a multi-marker approach in sepsis using procalcitonin, presepsin, soluble ST2, and galectin-3 with Salvatore, and we could show that this multi-marker approach predicted 30-day mortality better than SOPA score. And in our analysis, except for procalcitonin, the other biomarkers showed good prognostic performance like SOPA score. And this multi-marker approach added on SOPA score showed improved predictive ability in sepsis. So we could conclude that compared with procalcitonin, the other novel biomarkers showed superior prognostic performance, and their combined use reflected the clinical outcome. And we also compared the presepsin and procalcitonin in early diagnosis of neonatal sepsis and could show the diagnostic superiority of presepsin over procalcitonin. And in our meta-analysis with Professor Yang, we investigated the prognostic value of presepsin in adult septic patients and in terms of overall mortality and mortality with the short-term follow-up interval. And in our subgroup meta-analysis by sepsis severity and study site, we could show the prognostic value of presepsin in septic patients. Now let's talk about COVID-19. As we know, the main root of COVID-19 SARS-CoV virus is ACE2 receptor, which is prevalent in the lung and in the heart. But in addition to the heart and lung, ACE2 is expressed in the intestinal epithelium, vascular endothelium, and kidneys, providing a mechanism for the multi-organ dysfunction. So according to the disease progression, the host response is changed, resulting in the alteration of main biochemical parameters. And this table shows those main biochemical parameters alteration. And in addition to these conventional parameters, presepsin and MDW. MDW means monocyte distribution width, another US FDA-approved sepsis biomarker, and these biomarkers are regarded potential for the early identification of patients at increased risk of complications. So this is the first study that showed the utility of presepsin and risk stratification of SARS-CoV-2 patients. After this first small study, several studies explored the utility of presepsin in terms of prognosis prediction. So actually, COVID-19 has a mirror image of sepsis. So the main cause of death by COVID-19 include respiratory failure and the onset of sepsis. And sepsis has been observed in nearly all deceased patients in many of the reported cohorts with significant changes in the host immune response. And monocyte macrophages are the principal players in orchestrating the host inflammatory response. Actually, COVID-19 is a dynamic disease, and in its early phase, the innate immune system is related to the cytokine storm, and we can see IL-6 here, and its late phase is related to the adaptive immune system, and then the immune tolerance and reduced T helper 1 response and cytotoxic activity can be found. So for the clinical assessment of COVID-19, the WHO severity system is regarded as a gold standard, and sepsis and septic shock are included in the critical disease category. But a recent paper compared several proposed scoring systems, but unfortunately, this comparison didn't include the gold standard WHO severity score as well as SOPA score. And we know that age appears to be a relevant and strong predictive factor of in-hospital mortality in cases of severe or critical SARS-CoV-2 infection. And then a recent paper also proposed another VACO index based on a large data from the States. And VACO index could differentiate the risk of 30-day mortality among those of similar age. And then the prognostic utility of VACO index for predicting short-term mortality was again proven in the successive study. With such a background, we explored the prognostic utility of procalcitonin, presepsin, and the VACO index for predicting 30-day mortality in hospitalized COVID-19 patients, and could show the utility of these biomarkers and VACO index. And the Kaplan-Meier survival analysis, presepsin showed the highest hazard ratio, and that value was again confirmed using the reclassification analysis. So presepsin and procalcitonin, in addition to the VACO index, may be a more reliable prognostic approach than using the VACO index alone. But interestingly, procalcitonin, although most patients presented with sepsis or septic shock in this study, the median procalcitonin levels in survivors and non-survivors were all below 0.5 nanogram per milliliter. So the prognostic utility of procalcitonin in COVID-19 is arguable because it is in the normal range in most patients. Now we can think about the other emerging biomarkers of KL6 and interferon lambda 3. So post-COVID-19 pulmonary fibrosis is a novel sequelae of the current pandemic, and pulmonary fibrosis is a subset of interstitial lung disease. Actually, fibrosis is a pathologic feature of disease in virtually all organs, sharing common pathogenic pathways. And KL6 is a novel biomarker for interstitial lung disease. And a recent study showed that KL6 could predict COVID-19 disease severity. So we explored the usefulness of KL6 and compared that with age and Charlson Comorbidity Index and WHO disease severity. And we measured initial and follow-up KL6 level. So KL6 level quartiles were associated with ICU admission, ventilator use, and ECMO use, except 30-day mortality, and initial KL6 level differed significantly according to ICU admission, ventilator use, and ECMO use. And follow-up KL6 level was significantly higher in non-survivors than in survivors. And in ROC curve analysis, initial KL6 level predicted ICU admission, ventilator use, and ECMO use better than age, CCI, and critical disease. And these parameters predicted 30-day mortality comparably. And using the Kaplan-Meier survival analysis, only age and initial KL6 level showed significant findings. So KL6 could be an objective biomarker for predicting clinical outcomes in hospitalized COVID-19 patients. Interferons are the potent multifunctional cytokines secreted by various cell types. And in SARS-CoV-2 infection, viral proteins block type 1 and type 3 interferon responses by inhibiting innate recognition of the virus, the production of interferons, and interferon signaling pathway. And interferon lambda is known to be against viral load and hyperinflammation. And a recent paper showed that interferon lambda 3 could predict COVID-19 disease severity. And another system named COVID-19 Severity Index was proposed as a triage tool. So we wanted to explore the prognostic utility of presepsin, interferon lambda 3, and COVID-19 severity index in hospitalized COVID-19 patients. And in 60 hospitalized COVID-19 patients, the 30-day mortality rate was nearly 12%. And both interferon lambda 3 and COVID-19 severity index were significantly higher in ICU patients than in general ward patients. And presepsin and COVID-19 severity index were significantly higher in non-survivors than in survivors. So presepsin could predict renal replacement therapy and 30-day mortality significantly, while interferon lambda 3 could predict ICU admission and renal replacement therapy significantly. So presepsin and interferon lambda 3 could be used complementarily in clinical practice to predict clinical outcomes in COVID-19 patients. So multi-marker approach using conventional emerging biomarkers would be quite useful in critical care, and presepsin can be a good and potential biomarker for sepsis and COVID-19 patients. Thank you very much for your kind attention.
Any question from the audience?
That was fantastic, thank you. So when presepsin is involved with like a gram-negative bacterial sepsis, it's very clear how it gets activated and why you get presepsin release from the CD14. How does that work for other pathogens? I mean, what would be the mechanism by which the CD14 would be cleaved and released in COVID or, gram-positive?
Well, as we could see that I think monocyte macrophage system is very important related to bacterial infection or any virus infection. So it can do the orchestrating role and the host immune response. So I think regarding that, although I commented MDW, monocyte distribution with this, that is freely obtained parameter using hematology analyzer, and it has also US FDA approval as a sepsis biomarker. So that is also from monocyte. So like presepsin and MDW, I think monocyte macrophage system plays a key role preventing host from other bacteria or viral invasion. So, yeah.
Thank you for your interesting presentation. I was just wondering, you were using presepsin and you compare it to several biomarkers to predict mortality in patients with sepsis, but did you consider comparing with high-sensitivity troponin? Is this better than the high-sensitivity troponin for prediction of mortality in patients with sepsis? Your AUCs are all 0.7 or?
Unfortunately, I couldn't have such a chance to compare presepsin with troponin, but I think it will reflect some different aspect of disease severity in the host. Yeah, so that would be a good chance to compare those biomarkers together. Yeah. But compared with the procalcitonin, I think anyway, based on my own experience and based on the literature, for the diagnostic ability, I think those biomarkers are a little bit equal, but the prognostic performance, I think presepsin is stronger than procalcitonin.
Thank you very much. Thank you very much.
Okay, thank you.
It's my pleasure to introduce our next speaker. Yun-Suk Yang will talk about HDL cholesterol and 10-year MACE in a nationwide cohort study.
Thank you, Chairman. Thanks especially to Professor Di Somma for inviting us to this wonderful meeting. It's great to meet in person, not just online. I have nothing to disclose. High-density lipoprotein cholesterol is a well-known negative predictor of atherosclerotic cardiovascular diseases, ASCVD. The lower optimal cutoffs are universally established. The 2019 ACC/AHA guideline on primary prevention defined low HDL cholesterol levels, men less than 40, women less than 50, as one of the risk-enhancing factors. However, possible risks from extremely high HDL cholesterol are unclear. The 2019 ESC guidelines stated that extremely high HDL cholesterol levels greater than 90 increases risk of ASCVD without mentioning sex. In 2009, the Korean National Insurance Service began to check HDL cholesterol levels. 10 years have passed, so we could track actual 10-year major cardiovascular events, MACE, through this nationwide cohort. We explored the relationship between HDL cholesterol levels and 10-year MACE, providing sex-specific upper reference points for primary prevention. It is a retrospective nationwide population-based cohort study. Data sources are the Korean National Health Insurance Sharing Service and the National Death Registry of Korea. About 22% of the South Korean population underwent a national health checkup in 2009, the index year. Among them, we enrolled subjects who were at least 40 years old with eligible HDL cholesterol result. We excluded subjects with any prior history of ASCVD. Finally, we analyzed 5.7 million ASCVD-free subjects. We categorized the HDL cholesterol in two schemes. One is 10 milligram per deciliter intervals. The other, classic three-group model, low, high, extremely high, which is based on the two guidelines, 2019 ACC and 2019 ESC. We followed MACE occurrences over 10 years. In this study, MACE was defined new onset angina, acute myocardial infarction, cardiac arrest, stroke, or all-cause mortality. Here are the baseline characteristics. Males 52%, mean age 53 years. As we expected, the HDL cholesterol was significantly lower in males than in females. The low HDL cholesterol was seen in 22%, the extremely high HDL cholesterol in 2%. We followed the MACE occurrence for 10 years, and the 10-year MACE was observed at 1.3 million people. The 10-year MACE was significantly higher in males than in females. In all subjects, the percentage distribution bars of subjects with 10-year MACE stratified by HDL cholesterol 10 milligram per deciliter demonstrated a U shape. The nadir was 70 to 79. In males, the nadir was 50 to 59. In females, the nadir was 80 to 99. Both sexes had a U shape, but with later inflection in females than in males. Likewise, cubic splines in a Cox proportional hazard regression model revealed U shapes with later upward inflection in females. We compared the 10-year MACE with the three classic groups. In all subjects and in females fit to our traditional concept, the low HDL cholesterol group showed the worst outcome, and the extremely high HDL cholesterol group, the best outcome. However, if you see here in males, the extremely high HDL cholesterol group demonstrated the risk comparable to the low HDL cholesterol group. At this point, it seemed important to figure out the appropriate sex-specific upper references. So, using the 10 milligram per deciliter interval, we explore the upper references after the nadir. In males, please focus the risk of the extremely high HDL cholesterol group. If we set it to greater than 60, the risk is the same as the high group. But greater than 70, the risk increases to just exceed the high group, and set to greater than 90 milligram per deciliter, the risk increases further to be comparable to the low group. In females, if we're using the traditional 90 milligram per deciliter, the extremely high group shows the best outcome. But if we set it to greater than 110, the risk increased to just exceed the high group. And set to greater than 130, the risk increases further to be comparable to the low group risk. Here is the hazard ratios of 10-year MACE by reference ranges in each sex. We adjusted for age, BMI, LDL cholesterol, triglyceride, hypertension, DM, smoking, and alcohol consumption. There are some limitations. The categorization of HDL cholesterol level results in some loss of information. There were practical data access limits that precluded a continuous variable analysis. And also, we analyzed all-cause mortality instead of a cardiovascular mortality in a composite endpoint of a MACE, since the National Death Registry of Korea provided only the date without the cause of death. Summarizing, in a large South Korean population without prior ASCVD, 10-year MACE showed a U-shaped association with HDL cholesterol levels with later inflection in females. We suggested sex-specific levels. In males, the extremely high greater than 90. In females, the extremely high greater than 130. These findings strongly suggest that sex-specific extremely high HDL cholesterol levels should be used in a pooled cohort ASCVD calculator or non-HDL cholesterol calculation. Thank you for your attention.
Very provocative talk. Great job. Questions from the audience? All right, well, Sal, go ahead.
Congratulations. Really very nice data. Of course, the most important question, are these data applicable with other population cohort?
Yes, it is a really great question. Actually, I was motivated this study from the 2018 Dr. Medicine published in the ESC, European Society of Cardiology. What he said is extreme high HDL cholesterol paradoxically increased the all-cause mortality in men and women. That was the title. And in that description, he suggests it could be different in different demographics. So he suggested to do this study. So I was motivated with that result. So I tried to pull out this big 5.7 million people data and show the same pattern. The number might be different, but the pattern is in women, you couldn't put the same number as a man. So not just to say more than 90, we cannot use the pooled data set or increase the ASCVD. We could separately sex-specific numbers. In our data, in males, it was 90, and in female, it was 130. And the same data can be found worldwide. In Japan, 2018, the Japan EPOCH study, even small number, showed the extremely high HDL cholesterol level is associated with the ASCVD mortality in Japan group. and as well as a veteran study, 2017, 1.7 million veterans in America showed extremely high HDL cholesterol increased all-cause mortality. So we could find this data all worldwide, but we should find out which number in specific groups.
Joseph.
Thank you for the presentation. Could be that these very high levels of HDL are associated to very high levels of total cholesterol. Is it possible to have an explanation for this increased risk?
Yes, it's a good question because total cholesterol includes HDL cholesterol plus TG divided 5, so there may be some association, but we couldn't find the kind of mass increase in total HDL cholesterol. So I think it's not just one component of total cholesterol, it specifically reflects some MACE or all-cause mortality.
And now you have all the data. Are you going to analyze non-HDL cholesterol? Because unfortunately we don't have good therapeutic measures for HDL, but we have good therapeutic measures for non-HDL cholesterol.
Yeah, that is very good question. Nowadays, we are just to say non-HDL cholesterol 130, something like that, but we should specifically separate, especially, it's very small, 2% of population, but especially in case of extremely high HDL cholesterol, we just cannot say if it is non-HDL cholesterol is the same in male and female. So I think it is a next subject to analysis. Sex-specific non-HDL cholesterol calculation. Thank you so much.
One final question. Are you getting ready to publish this, submit it for publication? I sure hope you are.
Actually, we published this month.
Oh, great.
July 2022, ALM. Actually, Mina Her is the editor-in-chief. And we published it just this month.
Great.
And so if you're interested in that, and also I did upload the supplement data. It is much more than that. So it would be interesting to have an idea. Thank you so much.
Yeah. Very powerful database.
So we have our third speaker of this section. Is Professor Richard Novak, an icon for me and every emergency physician, with hundreds and hundreds of articles that we read before going to bed.
Thank you very much for the kind invitation. I'd just like to say that the great meeting is always great, and it's always in great places, which is why it's always great to be at the great meeting. I think this would be a good line for you in the future for promoting the meeting. So I am an emergency physician, and I want to talk a little bit about the indeterminate observed zone of the ESC guidelines. And I'm going to start out by doing this in non-COVID patients, and then I want to diverse a little bit and look specifically at COVID patients. And this is unpublished as of yet, and it's stuff we've been doing and we're very interested in. So I just want to say that as an emergency doc, I'm not fond of the term observe. When you're in the ER and you come in and you have a problem and you have an indeterminate troponin, we don't put you in the corner and observe you, we work you up. And so I like the term indeterminate or continued evaluations, and that's just as an ER guy. It's not simply observing somebody. I mean, maybe they need imaging, maybe they got a dissection, maybe they got other stuff. So I just wanted to bring that up. And so in the slide, you'll see a lot more indeterminate zone, which I kind of like better, but I respect the current ESC guidelines. So I worked a lot with different companies on the whole sensitivity, high sensitivity troponin stuff, and this is just some of them. These are not necessarily current, but I've been involved in this area for a long time. And the only other disclosure is that as you get older, you like serenity. And so when I write or when I'm analyzing stuff, I like to be in a place we have up north. You just need some quiet. When you're younger, you don't mind the noise. These are the ESC guidelines, and obviously you've seen these many times, and we're going to be looking at that indeterminate observe, continue evaluation zone. What do you do with them, and how do you manage them? The indeterminate zone cut points are different from different assays. This slide's been shown before, so you need to obviously to know what your institution is using and what is very low, what is high, and what the high delta is, and then what's left in the middle, which is the indeterminate zone. So we started out doing this and looking at a large U.S. trial, which the theory was that we could harmonize the cut points that were used in the ESC guidelines, predominantly from a European population, and see if that applied to an American population, which arguably is a little bit different, not a lot, but it is, and we did that. And we actually showed that there was a great correlation, and you could take the cut points that were used in the ESC based on a European population to an American population. So we did this in the US, and we had 29 sites there, and these are listed here, so they're academic, non-academic, a variety of places. So when you look at the primary results, you've seen these sort of slides many times before. It's the number that you could rule out, that you could rule in, and the number that were left in the observation zone. What hasn't happened up until now is I don't think that people have looked at what actually happened and how the patients were managed in the ED after they were placed in these zones. So we recently published a paper that was published in the American Heart Journal looking at what happened to the people that were rapidly ruled out. So a number of them still got admitted because they had coronary disease and everyone was worried because the mother died early, et cetera. And a number of them did get some revascularization after workup. We argue in that paper that based on these low troponins, that probably they could be optimized medically and could have been managed as outpatients, but that's a whole different topic from what I'm going to talk about now. But if you read the paper, I think it might make a lot of sense. So we actually looked in detail, and what I'm going to present today is what happened to all those people that were managed by clinicians using contemporary troponins and whatever else they felt they should do. What did they do with those people? How were they managed, and what were their outcomes? And I don't think that's been looked at very much, and I think it gives you some insight into what the possibilities may be for this. This has been presented at our academic emergency medicine meeting and nowhere else. So that's what we're doing. And in our study, you had 783 people who were put in that zone. So that's a significant number of people. You know, it's about a third of the population that we actually studied. So what was very interesting, the first thing you look at, well, how were they managed by clinicians? Remember, they didn't have the high sensitivity troponin. Well, it varied by institution, which really kind of does make sense that different places have different rates of you're going home or you're staying or you're being evaluated. Whether that's based on the patient population or based on the practice of those individual places, I'm not sure, but clearly it is quite different depending on what institution you go to. These are the listing of the patient's characteristics of the ones that were sent home by the ED docs versus the ones that were sent to OBS or admission by the ED docs. And if you look at it, I mean, the ones that were admitted to observation or to the hospital clearly had a lot more comorbidities. But if you also look at it and you look at the ones that ED docs sent home, there are a significant number that had really, I would argue, significant comorbidities like previous MI, previous revascularization, peripheral artery disease, I mean, obvious vascular problems. And so of those that were in the indeterminate zone, about a third went home and the other ones got worked up. So when you look at this, you go, well, that's kind of interesting. They made a decision to send people home. How did they do it? When we look back, the ED docs who made these decisions actually only missed 2 adjudicated AMIs in the ones that they sent home. And I think that they were probably early presenters. But I would argue that's a pretty low number. That's 0.9%. And I'll also show you, they didn't send them home. They admitted them. You could argue that they missed an adjudicated AMI, but they did not send the patient home. So I think it's pretty impressive that actually without the high sensitivity troponin, docs were able to accurately, for the most part, determine who should go home based on things they didn't have before the high sensitivity cardiac troponin. And what did they use? So we looked at all these things, and these are the things that they used mostly to determine who you were going to put in the unit. And it's sort of classic in terms of age, hypertension, renal function, abnormal EKG, previous revascularization. In this study, there were no formal risk scores that were used or documented. So it was the ED guys thinking of what am I going to do with the patient and making a decision. I don't know what the weight of each of these is, but these are the things they looked at. And in individual patients, they may have looked at one of these more than another. I don't know. So then you get into the discussion of, okay, so of the ones we put in observation, what happened to them? It's interesting that different institutions had different approaches as to who should get stress tested and then who should have therapy based on the results of the stress test. And it kind of gets into an interesting discussion when you're talking a little bit about MACE events is, how do you even define them or who determines them? So we actually spent quite a bit of time looking at what happened to these people relative to their cardiac workup after they were admitted or placed in observation in the institution. And I don't do this, but I have seen over my career many times that the decision on who to stress and who not to stress is very much cardiology or hospitalist dependent. One day a cardiologist may say, we're going to stress them, and the next day a different cardiologist comes by and says, we're not going to stress them. And then when you look at this, you go, well, I don't know, about a quarter of them got a stress test. Of those, the people that had an abnormal stress test, some didn't get coronary angiography. Of the people that had a normal stress test, some did get coronary angiography. The findings are sort of diffuse. Of the people that got no stress test, and I assume it's people with previous heart attacks or coronary disease, actually some of them didn't get angiography, but some of them did, and the results are sort of diffuse. So the only point I'm making about this is when you look at the definition of MACE and how it occurs, it's not as objective as you think. I mean, there's a lot of subjective decisions that go into that, and you use that as a hard endpoint for bad outcome. So I just bring that to your attention, and I think that this part of the workup, if we could actually maybe objectify it a little more, would be much better. So when you look at the people, so then you say, okay, so we sent them home, so what happened to them? Well, if you look at the green line, I think we were pretty good in the sense that we had one AMI at 26 days. I don't think my job in the ER is to do something that prevents something that might happen to you 26 days later. I think that's an outpatient decision and a follow-up. And if you look at the people we put in OBS, the two missed adjudicated AMIs were not sent home. They were put in the hospital and were worked up. And the ones that were clinically decided to go into OBS, actually they had a worse overall outcome, I assume because they had more comorbidities that the emergency physicians recognized at that time. If you look at this over a year, I mean, it's a sick patient population if you have all these comorbidities. And over a year, you're generally not going to do well in the ones that were put into OBS as opposed to the ones that we sent home. But both of them have some significant poor outcomes. We looked at these high sensitivity troponin levels within this zone. And no matter how hard we tried, whether we looked at the initial troponin, the delta, or anything, we could not use those to predict what actually happened and the decisions that were made by the clinicians to send people home or not to send them home. We couldn't do it. And so what we say in non-COVID patients is that it's still a challenging area to determine what to do to people who, how to manage them that are indeterminate troponin zone. And I do think that there is something with some, it's an old-fashioned term, it's gestalt, meaning that after you've seen a lot of patients, you get a sense of what you might want to do with them or what's optimal for them. And I think that's what this represents, because they did not have the high sensitivity troponin. They had to make decisions. People had all these comorbidities. What are you going to do with them? And actually, I would argue they did pretty well, looking both at missed MIs that didn't go home and then looking at 30-day outcomes. So I think that there's still something to be said for using the overall clinician's assessment. I'm not sure you have to use a risk score. I would argue you need to have an experienced doc and not a junior doc, but I think this data would suggest that prior to having high sensitivity troponin, the decision-making was pretty good on how to manage people who later were put in the indeterminate zone of the high sensitivity cardiac troponin thing. So I'm going to switch just a little bit here and go to COVID. So we had a horrible problem with COVID, as many did in the Detroit area. And as has been mentioned here, there are many studies that say that if you're hospitalized with COVID, the higher the level of the high sensitivity troponin, the more likely it is you're going to die. And there's actually a very good review of that in the American Journal of Cardiology. But the troponins in these studies were mostly contemporary, and they were either drawn in the ED a day after admission, 2 days after admission. It really varied. So what we wanted to do was look at all ED COVID positive patients and look at their 28-day survival based on the initial high sensitivity cardiac troponin I that was drawn and reported in the ED. So every one of these patients had a troponin at presentation in the ED. We did this by creating our own database because we didn't trust the institutional one because some of the data from the ER wasn't in that. We were interested in acute COVID, not chronic COVID. So you had to have a positive PCR test either at the visit when you came in or within the week prior to coming in. And then we looked at troponin levels and we divided them and we used the Beckman high sensitivity assays because that's what we use at our institution. So when we looked at troponin to see how it would help us to look at 28-day survivability, we divided it into zones. But what we actually did do is divide zones in the indeterminate zone. And you can see them that they're red in red. We had lower indeterminate and higher indeterminate. And we followed everyone for 28 days, whether they went home before the 28 days and then may have died at home or were readmitted or whatever. But we had the data on everyone who was with a positive COVID, and we followed them for 28 days. So it turns out that about three-quarters of the patients actually had a high sensitivity cardiac troponin. Why? They come shortness of breath, chest pain, stuff you go, well, I don't know, I guess we should be seeing if there's any myocardial injury or something like that. And actually, if you look at it, I mean, the comorbidities are common that you see in COVID, and the presenting complaints are also common ones that you'd see in COVID. And we admitted most of the patients, discharged much less, and 2 died in the emergency department. Of the 900 patients that were hospitalized, 147 were placed in the ICU, and actually 71% of those died in the ICU. So this gives you just a distribution of the high sensitivity cardiac troponin that I was talking about. So these are the different areas that we measured. So you can see that there were a number that were less than 4, which is the LOQ for the Beckman analysis. And then there were 359 that were in the lower indeterminate range, and there were 151 that were in the higher indeterminate range. And then we looked at 3 other values. The 230 were 3 times, up to 3 times the upper reference level. Then 100 was our critical value in our institution, so we divided those above that and those in between. And actually, what we found, which was really quite interesting, and I don't think has been reported, so nobody who had an ED measured high sensitivity cardiac troponin I that was below the level, the LOQ, died within the 28 days. No one. But if you look at the two levels in the indeterminate range, which are the low and the higher indeterminate, it all starts to separate out. So irrespective of whether you reach the level for cardiac injury or MI in terms of the 99th percentile, there is clearly increasing badness that comes out with increasing troponin based on a single troponin. Now, I can't tell you how many of these had a type 1, type 2. I don't know if this is inflammation, but it seems to be a very different disease than just the classic rule-out ischemic heart disease. And I think this is the first time this has been reported that you can actually divide outcome based on divisions within the indeterminate zone of high-sensitivity cardiac troponin. So one of the conclusions we just had for this was that, again, any woman who came in who had an initial level below the LOQ survived they all survived 28 days. And then the higher the level, and as I showed on that previous slide, if you were in the highest level, it was almost a 50% mortality. So it was pretty high. So we think that future studies need to be done to try to determine how best to use these particular measurements in patients with COVID disease. But I think that the COVID disease is different than I just have ischemic disease, and with particular differences within the indeterminate range is what we found. And we haven't published this yet, and I've just been too busy. So just to summarize, non-COVID, I think that I've shown that ED physicians in the US were pretty good at determining who could go home and who needed to go in observation or admitted based on risk factors and gestalt, because they didn't have the high sensitivity cardiac troponin, and they were pretty darn good. And then when you look at COVID, we did a unique thing by studying people with acute COVID and looking at high sensitivity cardiac troponin I, Beckman assay for that, and showing that actually if you do a troponin within the ED and you get the result, that alone, and I didn't get into following up because the repeats were at various different times and sometimes hours, sometimes days, so it was kind of difficult to see what the trajectory of the troponin was, but the initial one was clearly very important in terms of predicting what would happen with patients. So I will stop here and entertain questions and comments, and would like to point out that I do think a rising moon can be very beautiful. So thank you.
Yes, there you go. A question there.
Richard, fascinating data, both sets. I think this sort of systematic study of care in patients in the observed zone is long overdue. And although the decision-making seemed good, the tests chosen were somewhat random. And I'd like you just to speculate, because if I understand correctly, in high US, none of the clinicians had access to high-sensitivity troponin.
No.
They didn't know these patients were in the observed zone. What do you think might happen if you implemented a high-sensitivity pathway which created an observed zone to testing in that group? Do you think it would go up or go down? And what are your plans for implementing that sort of pathway in your center?
You know, right now, I don't know, Nick, because right now the decisions on the indeterminate zone are really based on scoring systems, etc. And we didn't have those scoring systems, and we didn't have high sensitivity troponin, yet we did pretty darn good. So how do you actually now implement that, given what's out there? But we've had a lot of discussion and a lot of zoning, but we never really looked at what happened to the people in those zones with the management they had at the time. I mean, how good were people? And so, I think they were much better than we thought. And I haven't been around a while. I struggle with, you need objective data. It's great, yes, and we need scoring system, yes. But there is really something to some doc that is with an individual patient, talking to them, and has talked to many patients in their life, saying, no, I think you'll be okay, which they were, or no, I think you should stay. And then when you stay, I don't know what the right answer is as to who gets what, and that's what you do, not me. But it seems that that's also an area that is not so clear, at least to me, based on our review of the data.
Thank you, Dr. Noma. Thank you very much. Thank you.
Identical twins. So, welcome to the last session. So the last session will have two presentations, both 10 minutes presentation and 5 minutes discussion each. And the first one will be introduced by Professor Masi.
Yes, thank you. It is a pleasure to present Professor David Brenner, who is one of the leaders of the great meetings. He has been collaborating for years. He's the Vice Chancellor and Dean in the University of California, San Diego. And it's a pleasure to be with you here. And he's going to talk about creating a highly reliable learning health system.
Thank you.
David.
Thank you. Thank you for the invitation. There's been a renewed interest in the United States in trying to become more robust about how you improve quality in all hospitals, but in particularly in academic medical centers. And the most widely known one is called high reliability healthcare. This is emphasized by the Joint Commission. I don't know if in Europe if you're familiar with this, but Six Sigma, the idea of trying to be very precise and having things robust and very reproducible. More recently, there's been this idea of learning health systems, and this has been highlighted by the National Academy of Medicine, and it requires you to look at your own data, to systematically use that and integrate external evidence with the idea to bring new knowledge into practice. And because of COVID-19, we thought, is there some possibility to accelerate this in order to get changes more quickly integrated into the health system? And does anyone know who said, never waste a good crisis? No? Winston Churchill, who is more popular than your current Prime Minister in England. But we tried to say never waste a good crisis and see if we could do something quicker. And we coined highly reliable learning health system. And this is trying to get away from silos, that you use the clinical operations, the electronic health record, information support, clinical research infrastructure, AI. We even used people from the computer science department across the campus to try to get a process that went more quickly than our current process. So we set up what we called a choir, which is an acronym for a committee that rules on all this, that you bring your good ideas to this committee. It has everyone from physicians, nurses, pharmacists, quality improvement people, researchers, institutional review board, because some of these require an IRB approval, medical education people, and project managers, who actually who are professional project managers to do this, because we as physicians are not so good at this. And we provide support. My contribution, this was my office paid for this, so that was my major contribution to get this to go. And it's very multidisciplinary. It's not the usual siloed effects that we see in academic healthcare. And we use the outcomes both to change the hospital, but also to publish this, with the idea being that this is an academic pursuit, it should be published, as well as improve healthcare. So we had some early wins. These are very simple things, but they did go very quickly. We set up rapid COVID PCR testing for our students, and we were doing 10,000 tests every day, returning the test within 12 hours. So that was using an academic research lab to do PCR testing for the San Diego community. We use an artificial intelligence algorithm, this is very early, to diagnose COVID by chest x-rays. Apparently there's some findings that AI does better than our radiologists, which might be a lesson not to go into radiology in the future. to be able to make diagnoses and not confuse them with other pulmonary diagnoses. We set up one of the country's first vaccine superstations. We're doing up to 10,000 vaccinations a day. We also, but by keeping track of our own people, our own faculty and staff, we were one of the first places to show breakthroughs for people that were already vaccinated. And the CDC used that to recommend the boosters, that data, to recommend the boosters. That was published in New England Journal of Medicine. And we also tracked how we did with cancer. There's actually a big delay in people presenting with cancer early during COVID, and we were able to track that using the system. Okay, so the one I'm going to tell you about, though, is something that's currently going, we're doing data all the time, but it reflects this idea about how you can combine different aspects of an academic health system. And the question we wanted to determine was, we saw thousands and thousands of patients with COVID, and many of them were patients, and unfortunately many were also healthcare workers. And the question was, where was this being transmitted? Could you use this type of approach to determine where people were getting their COVID, and what were the risks of being in a hospital, how much of it was iatrogenic? And a lot of staff had COVID. Did they get it at home, or did they get it in the hospital? This was, as I said, this was approved by this committee we set up, the Acquire Committee, that let us do this project. And this is kind of the pathway that we used. So this did not project that well, but I will tell you. So this was presented to the committee. They then looked at the EPIC. We use EPIC, which is the largest used electronic health record in the United States. I guess Cerna is the largest in Europe. We put the EPIC data together with all of the sequencing data. We made a commitment to sequence every patient within a week. So every patient had their full sequence available. Then we overlaid the sequence data with an EPIC. This is almost like Facebook, where you can look at EPIC and see who was who together in the same room, in the same part of the hospital at the same time. And so you can make like an interactive chart and then impose that on the actual genetic data. And that way, it doesn't matter. You can have people come and get very similar sequences, but they had nothing to do with each other. You can show they never were in the same part of the hospital at the same time ever. And you can eliminate those as being hospital acquired. Okay, so this is what the data looked like. The concept was that if it's an identical genome, it was a match. If it was off by 1 or 2, it would be further up on the phylogenetic tree. This is what the data looked like. This is only Omicron. It took 2.5 months to do this. The Omicron variants are continually evolving. And what we learned was the following, that we could identify multiple clusters. And initially, it looked like an enormous number of people had similar clusters in the UC San Diego health system. But it turned out that if you model this and make a prediction, the model predicted there'd be no more people involved. Sorry, it's shown here. Oops. Wait, vaguely. Then you can. Sorry? Thank you for participating, though. We appreciate that. And there'd be no more people than you would have predicted by normal chance interactions. So this, as a very high level, the key insight is that we did not see more people infected in our system than was predicted from the community. Okay. So we identified multiple clusters, and in each cluster, we looked at the temporal relationship between the physician or the healthcare worker and the patient. Could they physically be at the same point at the same time? And that in multiple of these, it was very unlikely. In other words, we could not find any reason they were in the same place at the same time, even if they had very similar sequences. And that allowed us to go on and look in great detail in the clusters that we can document where they could have potentially been in the same room or the same area at the same time. And one example that we would have missed by standard technique is shown here, where there was a dietitian. There's an RD. she interacted with the patient, and then she came down with COVID one day, and a day later, she was diagnosed one day, but she was infectious when she saw this patient, and the patient got infected. So there was an example where, unfortunately, this was iatrogenic. This was an example where a dietitian gave a patient COVID. Okay, but when we overlaid and looked at the entire data, the results were actually, I think, quite encouraging, that the vast majority of the pairs did not turn, these are pairs determined simply by genetics. But when we overlaid this with our EPIC data and the actual interactions of people, the pairs dropped down tremendously. So there are only 40 clusters that we could identify. So this is our general result, is that even though there were an enormous number of people in the system that had almost identical genetic profiles, they did not get their disease in the clinical environment. They got their disease in the community and brought it to us. And so we could distinguish iatrogenic, which we said if you're in the same place and you have the same genetic variant, that's iatrogenic. But for everyone else, it had to be brought in from the community. Okay. This is a cluster that unfortunately is iatrogenic. This is Hillcrest. Hillcrest, we have a couple of hospitals. Hillcrest is the oldest. It's almost 60 years old. It's by far older than any of our other medical facilities. And we were concerned, appropriately, that maybe there was more risk. Even though it fulfills all the obligations of ventilation and everything that's required, there are probably areas in common spaces in the hallways that are not as ventilated as optimally like the new buildings, and therefore we were concerned with the risk. And this is a really good example where two patients share a room. They actually, in this older hospital, actually are shared rooms, and in new hospitals are not. They interacted with a nurse and an occupational therapist, who in turn interacted with an ancillary person. And this cluster is all the same genome. So this was done in the hospital, several steps that was caused by this. So just for comparison, this hospital is almost 60 years old. Anyone know what the oldest hospital in Florence is? Someone from Florence, so. It's the hospital of Santa Maria Nuevo, 1288. It's still being used. Yes, still being used. So the ventilation there might need some work also. Okay, in a little more detail, we looked at, of all the cases, there was no overlap in the vast majority, so they occurred somewhere else. But in 15% of these cases, we looked at Omicron transmissions within the UCSD system. Some of them were clearly because of overlap, definitely. But when we look at where they occurred, again, the majority, even though these hospitals are the same size, the majority occurred in the older hospital. So one of the take-home messages was a need to look at the ventilation in these areas. Well, a comparable size hospital, Jacobs Medical Center, much lower, same size hospital, but much lower. Okay, so these are my take-home messages. That in 45 out of 46 clusters, we can identify them using existing infectious disease protocols. We picked up a cryptic one, but it really shows that contact tracing and other infectious disease prevention protocols work. The transmission occurred more often in our older Hillcrest campus, probably reflecting ventilation in non-patient areas. Most of the known clusters that did occur in clinical areas, they were able to identify a breakdown in the systems. Either patient or staff was not masked, or there was a lapse in PPE, in personal protective equipment protocols, and that probably reflected this. But the real bottom line is that this analysis showed that the majority of healthcare workers, the COVID-19 infections were not from acquired patient care, but they were from the community, and that transmission, especially between patients and healthcare workers, rarely occurred in the healthcare setting. And even the few that did occur, you could usually find a breakdown or something that we could do better. So I think this is very encouraging. I think the system clearly worked. This was done in 2.5 months. When we used to do this on a more leisurely time scale, this would take years to do. So I think that the ability to use the incredible strength of an academic medical center to actually make decisions in real time, I think is really well documented here, and it's a good example for all of us. So I will stop there, and thank you for your attention.
Thank you. Now it's time for one question.
Sal wants to ask something. He has this urgent need to ask something.
I mean, really fascinating result, David. Could you please clarify what about Upper de la Jolla hospital compared to Hillcrest? Was there any data that comparing the two areas?
Yes. So I mean, Sal's visited us in San Diego. We have one brand new hospital and one old, very old, relative to the United States, very old hospital. And the Jacobs Medical Center, the new La Jolla Hospital, had incredibly low rates. And the patient population is very similar. The doctors are all the same. The staff is all the same. We attribute it to actually the actual infrastructure. And there's a lesson there that, the ventilation, the way we do things, could be better. And the new buildings are ventilated better. And it's a big concern with older hospitals about, infection control and how to do that better. So thank you for that question. I will stop there. Thank you.
So at this point in the program was supposed to be the presentation of Professor Kurt Huber, who is the president of the Acute Vascular Care Association of the ESD, and he was meant to give the ACVC presidential lecture. So Kurt sends his regard, but there's also some other attendees. He got stuck at an airport and is unable to come to Florence. So we need to substitute his presentation with someone who could give a presidential lecture. And we are so happy that so last night there's a person who received the legal clearance for his presidential, who has quite, I think, and his friends, I think, can confirm this presidential character. So although he competes within the senior scientists lecturer, I think there's a person who could substitute for the ACVC presidential lecture, and so I would like to ask Pedro to come to the podium. And so this is the last presentation of the great research meeting this year. So he competes among the senior scientists, and he will present on a novel approach to manage patients presenting with acute chest pain. Pedro.
Thank you very much, Christian, for the warm presentation. So, dear chairpersons, dear colleagues and friends, my name is Pedro López-Ayala. I'm a PhD student at the Cardiovascular Research Institute, Basel, and I'm really happy to be able to present today the findings of the external validation of the MI-Cube algorithm. So before starting, there's a very important disclosure I must share with all of you. So yesterday, our group slept very little. We had a 7-hour train trip until Florence. We didn't have time to eat. And for me, the worst part was I couldn't eat patisserie. So I went to Christian and I said, Christian, you need to do something to make the day shorter. Obviously, I said this in German, which sounds more intimidating. And he came up with this great excuse, and we had time before lunch to have some patisserie, some gelato. And being afraid of today, he put some gelato today also in the meal, so I didn't come with the same excuse. Now, jokes out, what really makes me happy is to work at the Crypt, the fantastic team that we have, the team players, and I'm really, really happy for that. So the MI-Cube algorithm was published in 2019 in Circulation. It was an international collaboration of 9 different research groups, and it was led by Professor Nick Mills. Now, The MI-Cube algorithm is a machine learning algorithm, and in patients presenting with chest pain to the emergency department, 3 different variables were used. It was age, sex, and the rate of high sensitivity cardiac troponin I architect. Now, it's very important, this rate of change of troponin. What does it mean? Well, you have the baseline 0-hour troponin value, and you also have a second troponin measurement. Now, this second troponin measurement, it can be 1 hour after the first one, it can be 6 hours, 12 hours. There is no time limit, but there must be 2 troponin I measurements, this serial troponin. So an individual probability is calculated for type 1 and STEMI. So how did it do in the derivation study? Well, very high discrimination with an area under the curve of 0.96 and quite a good calibration, as you can see. There were also some rule out and rule in cutoffs that were derived, showing a good diagnostic performance. Now, in 2022, the group of Professor Mills validated the MI-Cube algorithm in the high-stakes trial. They presented it. Dimitros was the first author, which you have for sure met him today with his great talk. And they showed also a very high discrimination with an area under the curve of 0.95. However, the calibration, as you can see, the observed probability is larger than the predicted probability, so there is an under-prediction of the MI-Cube algorithm. And this is starting already quite early with short, small. Now, importantly, in the high-stakes trial, the time difference between the first 0-hour troponin value and the second troponin measurement thereafter is between 6 and 12 hours. So we could say they are, so to say, late samples. So I would like to talk about the validation pi, or the concept of the validation pi, which it's already been validated, and it's been validated in late samples. But in order to finish cooking this pi, there's still the early samples, the question, how does it perform in early samples? And also compare it with, so to say, with the standard, which is the EST01 1-hour algorithm, as you might know from the latest and STEMI guidelines. So, in order to cook this pi, we externally validate the performance of the MI-Cube algorithm in a setting, in an emergency department setting with a time difference that must be less than 3 hours. And as a second aim, compare it with the EST01 1-hour algorithm. So for this endeavor, we used the APACE study. You've all already heard of APACE, so I will be very fast. Chest pain patients presenting to the emergency department were recruited. Serial blood was taken. Cardiac troponin was measured. For this study, cardiac troponin I architect. And a central adjudicated diagnosis was performed by 2 independent cardiologists using all available medical records. Importantly, for the diagnostic endpoint, the primary diagnostic endpoint was index and STEMI type 1 and only type 1. And we did subgroup analysis for age, sex, early presenters, glomerular filtration rate, coronary artery disease, and diabetes mellitus. So going to the results, from 8,267 available patients after exclusion of STEMI patients with an unknown diagnosis and an elevated cardiac troponin measurement, possibly indicating myocardial infarction, and not having at least 2 cardiac troponin I measurements, and remember, it's the rate difference of cardiac troponin, so you need 2, we had 6,487 available patients for the external validation. The baseline characteristics of this chest pain cohort is very similar to the baseline characteristics of other chest pain cohorts, with a median age of 60 years old, 33% of female, and 35% of early presenters. What I would like to remark is the time between blood draws between the first and second. The median time was 60 minutes, with 25th and 75th percentile of 57 and 70 minutes, so quite early. So to the discrimination, we can see, as expected, the area under the curve is high, 0.96. And in the subgroups, there are 3 groups that merit further discussion, which is patients older than 65 years old, where you can see both in age over 65, a history of coronary artery disease and a GFR below 60, the discrimination dropped, especially GFR below 60 to below 0.92. Now, how about the calibration? And in this case, calibration, as mainly the agreement between the observed and predicted probabilities, is good. You can see in the black curve, this is a lowest curve that we fitted, and as you can see, it's near to the optimal calibration, the red line. Furthermore, you can see 3 triangles. This is the rule out, observe, and rule in groups. For rule out, very good agreement. For observe, there's a slight under prediction. So you can see observe is higher than predicted, while for rule in, there's an over prediction by the MI-cube. But the calibration, so you can see slope and intercept, they include 1 and 0. So going on to the threshold performance, these cutoffs for rule out and for rule in, you can see that safety for rule out with with a score of less than 1.6 was high. Sensitivity was high with 8 missed and STEMI patients, while accuracy was also accuracy for rule in was high with a positive predictive value of nearly 70%. Again, the subgroup analysis showed similar findings to the area under the curve with age and glomerular filtration rate, the sensitivity and the negative predictive value for rule out dropped. Now, for the second aim, the comparison with the EST01 our algorithm, we excluded 355 patients which didn't have the 1-hour troponin measurement in order to perform a one-to-one comparison between both algorithms. And as you can see, the EST01 algorithm was very safe, no NSTEMIs were missed, and had an accuracy of, for rule-in of 60%. So, comparison. For safety of rule-out, although the MI-cube was high, the EST01 algorithm was statistically significantly superior. In contrast, for accuracy of rule-in, the MI-cube had a higher positive predictive value compared to the EST01 algorithm. So to the limitations, it was conducted in 80 patients, therefore we cannot comment on the performance in other clinical settings. We cannot generalize our findings to patients with terminal kidney failure requiring dialysis, as these patients were not included. And very important to stress out that the EST01 algorithm was derived and validated for type 1 and or type 2 NSTEMI patients, while the MI-cube algorithm was only for type 1. So there are maybe some comparisons are unfair. So, dear colleagues and friends, in order to conclude, in patients undergoing serial cardiac troponin measurements in the emergency department with a median time difference of 60 minutes between both cardiac troponin measurements, the MI-cube algorithm showed a high discrimination and a good calibration for type 1 MI. It had a high safety for rule out, however, missed more NSTEMI patients than the EST01 algorithm, and the MI-cube had a higher accuracy for ruling compared to the EST01. One last thing, I would like to thank, again, the CRIP. I would like to thank the organizers of the great meeting for putting up such a good congress, but most important of all, for selecting such a good spot location with the fantastic views. So I don't know you, but I, afterwards in the dinner, I'm looking forward to take some pictures and to be able to replicate a famous picture in our group from 2019 with my colleague, Luca Kochling. Thank you very much.
Thank you, Pedro. Oh, multiple questions. I think Jasper was first, if I saw it correctly, but only... Micro, please, Jasper.
Is it on? So thank you very much, Mr. President. Great talk. I really enjoyed it. I know that you've just finalized the analysis, but have you had time to have a closer look at those 8 patients that were missed by MI-cube compared to those patients that were not? I mean, there were no patients missed by the EST1 algorithm. So do you have an idea why they were missed by the MI-cube?
in order to see if troponin so to see more the characteristics of these patients, right? I don't have them in memory, but obviously we will present them and it will come in the future manuscript to see if the ECG might have helped, if other variables, because it was age, sex, and rate of troponin, right? But maybe glomerular filtration rate, maybe chest pain characteristics could have, but basically the ECG could have helped. Thank you.
Andrew, please.
Hey, is it? Great talk, Pedro, and I look forward to chatting with you later. Two comments. I think the calibration, although was better, I think it had the tendency to be similar to the one on the high stakes. And do you think that claiming that it's good is actually because of we had 20,000 patients, of course having 6,000 patients, it's good enough, but the observed zone was is it enough to say that the calibration was good in the observed zone? And again, just a comment. And the other thing, I was again surprised with the same performance between men and women, something that we saw that it was not the case in our paper. So the diagnosis was based on the sex-specific threshold or on the uniform threshold. And a sensitivity analysis might be very interesting. Thank you.
Yeah, so thank you very much for the two questions. I'm going to answer for the second question. I think it's a great point, and actually here for the sake of time, just presented the primary analysis with uniform cutoffs. We also have performed a secondary analysis with type 1 or type 2, and a sensitivity analysis using sex-specific cutoffs. And again, I don't remember by heart, but it could be that when using sex-specific cutoffs, the difference between male and female for the diagnostic performance might be increased compared to the uniform. I'm just hypothesizing, but we can discuss it later. And to your first question of the calibration, indeed, I think both studies showed that for rule out, agreement was very good, and that's the most important thing at the end of the day, that rule out is good. And in the observed zone, in both the high stakes and in our cohort, you can see that there is an under prediction, of MIQ, right? It's higher. Now, if it's probably from the figures that the difference is a little bit higher in your case, and it could, I don't have the answer for that, but maybe because the troponin was 6 to 12 hours, and while in the validation from the original paper, the studies used for validation, they had a shorter troponin time. It could be just that these findings that resemble a little bit more the derivation studies, the calibration and derivation is just a matter of time from troponin. But still, I think 6 to 12 hours late samples, it was safe, and this is also safe.
So last question from Andrew, please.
Well, the good news is Professor Boardinghouse actually asked my question already, but I have thought of another one. The observed zone obviously is quite important for clinicians in practice. I wonder, do you have any ideas that we might be able to take forward in the observed zone in terms of machine learning methodology? Is there anything innovative we could do to try and give clinicians a bit more advice other than just observe?
Yes, thank you very much for the question. And particularly the observed zone is something that I have great interest. It's my topic of my PhD, and we recently last year published some novel criteria for the observed zone with troponin T, and we hope to expand that. So probably, or the easy answer would be measure troponin at 3 hours. The guidelines recommend that. We have showed that you can do it. In the presentation of Dimitrios, also for the observed zone, you took a second troponin measurement, if I understood correctly, with no exact time. It can be any time, 1, 2, 3 hours, and you were able to reduce again the observed zone. So for the EST, in this case, it was Architect. So my recommendation would be take a 3-hour blood sample. I hope that next year in the next meeting I can present the cutoffs for this. And in the MI-cube, well, it's the rate difference. And obviously, I would say just re-update the model and include a third troponin, but it's much easier said than done. So I cannot say anything about it.
Thank you very much.
Thank you, Pedro.
So now it's time for closing remarks, farewell, and we have to do a brief general assembly that's missing on the program, but is mandatory each year. We have one.
Yeah, very briefly, because we are just need to conclude. First of all, I think that I have to say just some information on the event. We had 150 participants, but also we have 140 people that were following us by remote. And I think it's really interesting to know that so many people are always interested to be with us. Of course, I have to say that for me, this has been the best one of the greatest, but I say the same things every year. So this means that we are really making an amazing job, and thank you to all the people. I think that thank you will be from the president at the end, so I'm not making any comment, but I would like to say thank you, everyone. So let's just make some information for you on the situation of our group. Of course, I don't know if you can present our, let's say, General Assembly data that we do as a transparency every year. Okay, to be honest, this is a very expensive meeting for us. I mean, I'm sorry to say that you need to know that. Because, first of all, thanks to the sponsors that Roche, Orto, Siemens, Kidel, Adrenomed, Konica Minolta, we got good income, around 80,000 euros from the sponsor. This is not bad for a meeting like this, but unfortunately, we spend more than 100,000 euros. And of course, this is Florence, but I think there was a kind of a conflict between this guy and myself. I was always say, please don't spend too much. I say, no, we have to spend. So you have to say thank you to him, not to me, but... From my point of view, I was trying to save money. At the end of the day, we have two scope. It was like, to do now we have to do the best. And I would say, oh, but what about next year, right, Alex? And we discussed. So at the end of the day, the balance is not bad. We have around 50,000. Hopefully, we can have another great meeting, probably even the best one next year. We are looking to have everyone on board, but still what I really would like to compliment with my president for the great program. It's amazing. I think it's very difficult from the investigator award committee to make decision, because from my side, everybody, from people who should be awarded. That is my opinion. So with that, I say thank you and I pass to my great friends.
No, I think the only thing to say is bravo again to the young generation. We were so happy to see all of you here. All the presentations were just great. Unfortunately, since we spent the money to the meeting, we cannot give you all an award. And but I'm sure the jury did a great job. And again, I'm happy to see you tonight for the dinner, but most importantly, to have Salvatore stop speaking. Tomorrow you will see Italy losing the football game.
I am not too sure about that.
Okay, but tomorrow it's also a great event, soccer and also the Uffizi. And again, bravo to all of you, and you did all a great job. Bravo.
Okay, just before giving the final talk, I have really would like to say that at 8 o'clock we are going to have the award ceremony before the dinner. So please join everybody 8 o'clock in the restaurant on the floor number 5, and then 8:30 we will have the dinner. I think that now it's time for our president, because it's not only the current president. We decide together that Christian can still lead for next year's the group. So although there was the idea to make a rotation, he did so good that if you agree, we think that we can say that our president should continue to be Christian.
Many countries may learn from our way of doing democracy.
Yes, but you know, this was a consensus. So, Christian.
You should say you are happy.
So my personal trainer just suggested I should say I'm happy, and I really am. So it's of course a fantastic. It was a fantastic meeting. It was. We all enjoyed so much having the chance to interact with each other, to have these fantastic scientific presentations, to have a wonderful scientific discussion. I think that's what makes our life as physician scientists so attractive, and I'm so happy that we now have this feature back in our life. That it was possible to have this fantastic interaction was the result of the hard work of many in the preparation and many when we were here on site. And I want to ask you for a loud and extensive round of applause for those who really have made an enormous effort that we had such an enjoyable meeting. And of course, I want to start by highlighting the fantastic support that the three of us have received in the preparation of the meeting, and that all of us have received by being here and conducting the meeting by Valeria. So Valeria, please, a loud applause. So Valeria, you're fantastic. You made really, you deserve a lot of credit for the fantastic success of this meeting. Valeria was very smart, and she had the support of other experts, and I would really like to acknowledge the fantastic work that also this year we have received from the highly professional audiovisual team. And please, another round of applause for Mauro, Gianluca, and Steven. I think you did a great job. People, I mean, that we have so many people online following this is the result of the high quality audiovisual that you provide. And also the high quality will be highly appreciated by all of the presenters who will receive the link to the video of their presentation after the meeting. And so you will have the chance to share this, of course, with your colleagues and friends. And of course, Valeria was smart to ask for the help of two other very nice ladies. And so another round of applause for Stephanie and Alice. Thank you very much. And the last group of experts that I clearly want to express my thanks, and it was highlighted by Salvatore, are the members of the award committee. So they were present during all of your presentations, and they now have a very difficult job in order to judge among all the fantastic presentations among the junior scientists or young experts on stage category, and the senior scientists, and to give the first, second, and third prize. So I'm sure you will have great discussions within your team. So please, applause to Frank as the chairman of the committee. As well as Nisha, Thanrel, Joseph, and Sean. Thank you very much. Okay, so I think again, one last minute. So of course, we will meet at 8 o'clock at the 5th floor, but at the end of a wonderful, great meeting, it's important to start the discussion of where shall we go next year? So a lot of science is ongoing, so for sure we will have great topics to discuss. And again, as in all previous years, I would and we would like to ask for your suggestions where we should go next year. The criteria are always the same. It should be a beautiful city, ideally one that it's easy and inexpensive to travel to, and ideally a city where we might have a local host. I think we have been to great, wonderful cities, and so we are open to your suggestion, because as the three of us, I know all of you, we love to be in Florence because it's such a beautiful city and such a wonderful place to be. And so please provide your suggestions, because we want to be sure that you will enjoy the place that we pick for next year as much as you do this year for Florence. So again, thank you very much for attending, for your great presentation, and see you at the award ceremony in about an hour. Thank you.
Thank you.